serving as president for Global Minnesota, and we're grateful for your participation and interest today in our World Health Day 2021 special symposium, focused on the theme established for this year by the World Health Organization, Health Equity and Equality. Before we dive in, I want to thank all who've made this very special and exciting day possible. First, of course, our staff at Global Minnesota, our board, our interns, our volunteers. We host these international days throughout the year, like World Food Day and International Day of Education. They're a tremendous team effort reflecting our mission of advancing international understanding and engagement. That's been our work since we were founded in 1951. You can check out our website to see how we're celebrating our 70th anniversary year with special events and programming, continuing our work of connecting Minnesotans to the world and the world to Minnesota. Second, I want to thank all of the speakers, the panel members, all who've graciously and generously donated part of this special day to be with us and to share with you and all of us their perspective, their ideas, their vision, their hopes, their dreams for health equity and equality. It's a hot topic, and we've assembled an amazing range of views that will inspire and challenge all of us. Third, we could not produce this kind of free global programming without generous support from our members and our sponsors. Today's program is a combination of our supporters who are members, both individuals and corporate, and those who sponsored today's special events. Our premier sponsor is our long-term institutional member, GHR Foundation, based right here in our hometown of Minneapolis, Minnesota. Check out their website at GHR Foundation, and you'll see a hope-fueled, global-minded funder serving people and supporting limitless potential for good in the world. And if you check it out, you'll see that they are in partnership with communities and faith-based organizations worldwide, working on everything from preventing Alzheimer's to supporting educational communities and keeping children together with their families. We also have to thank our sponsors for today, King Solutions, Blue Cross Blue Shield, and our leading corporate members, Carlson Family Foundations, Delta Airlines, Cargill, Medtronic, United Health Group. And those members, all of you out there who support us year after year, our program partner, World Affairs Council, and the organizations, our friends, our partners who are our promotional partners for today's events. Now, there's some special instructions if you want to or need to use the American Sign Language and Closed Captioning in English feature. There's a special YouTube channel. You can find that in the YouTube description box. Thanks to St. Cloud State University for providing this service and for their devotion to accessibility for all. They are inspiring Global Minnesota to reach further, to do more, and they are a treasured partner for us in these international programs and beyond. And finally, thank you to all who've tuned in today, wherever you are on the planet. Perhaps you are seeing this in the archive later. Your time is precious. We know this is a moment where there's life and death issues. There are also great challenges facing us. We have to look ahead. Thank you for taking time today to be part of this particular observance of World Health Day. Every year on this date, April 7th, we commemorate the founding of the World Health Organization back in 1948. This is the 71st anniversary, with the first World Health Day being held in 1950. Every year there's a theme that reflects WHO's top priorities. Some years it's things like road crashes, something I'm very interested in. Some years it's about special breakthroughs on polio or tuberculosis. But this year they have chosen the theme I think was both perfect for the moment, but a tremendous challenge to all of us, building a fairer and healthier world, with their focus on health equity and equality. And that will be reflected throughout the day with the voices of frontline leaders from all over the planet that you'll see on today's program. It also reflects this new phase where we are in the COVID-19 pandemic. There's near universal global agreement that there's no way out of this crisis without health equity. It's not going to be possible for all of us to be safe until all of us are safe. We can't have herd immunity and be protected from this coronavirus, COVID-19, until all of us are protected throughout the planet. And so that awareness is driving us into new ways of talking about and new ways of thinking about this future. One of the elements of that is, of course, the kind of race that we sometimes refer to between getting the whole world immune through maximum vaccinations and protection through our social approach, and the spinning out of new variants that continues to happen and will continue to happen until we reach that global immunity. New ones reported recently in the Philippines and India, but they are all over the planet. It's in a danger for all of us until we reach the kind of global immunity we need to. Even in the United States, we're now seeing scientists debating the need to begin vaccinating children so we can reach the proper level because of the high incidence of anti-vaccine campaigning, propaganda, and vaccine hesitancy in the United States. So we're debating why supplies are so limited when factories in South Africa, India, and other countries are begging for an end to the nationalism, protectionism, and monopoly practices that seem to be standing in the way of affordable vaccines for the whole planet that could get us to global immunity faster, completely, more equitably, more equally. Some of us are still struggling with local distribution here in Minnesota in some places, around the nation, worldwide. We're also debating important new questions like vaccine passports. What are the pros and cons? What are the pros and cons of a greater time delay between first and second dosages of some of the highly specialized vaccines? And can that get us to having more people protected quicker? These are legitimate, important debates, and you'll hear some of that talked about today. Our world leaders have recently called for an international treaty on pandemic preparedness and response. This would be a huge step forward as well. And there's talk of a decade dedicated to global preparedness for pandemics and making sure all of us have the kind of advanced planning that is really required to think about that word resilience and sustainability. Over the past month, it's been complicated. We've had 6 weeks of increasing infections. Some states in the United States have really turned in the wrong direction. I can see that milestones that we don't want to see or we're beginning to reach. I think Brazil has reached a very high level of deaths, 300,000. We are seeing difficulties in different parts of the world. And so while there's an optimism and a vision of beginning to move forward and beginning to tackle the health inequities and health equalities that we need to, there's also the awareness that there is much to be done every day to make sure we're keeping each other safe through distancing, through masking, through the other practices we know, and we're getting vaccine to the vulnerable populations, the frontline workers, our healthcare providers, and the people who've been at risk and have suffered the most throughout this entire year. A week or two ago, I was sent an interview that I watched very carefully. It was Her Excellency Reem Al-Hashimi, who chairs the giant World Expo that's coming to Dubai starting in October. And she also chairs the United Arab Emirates National Committee for the UN Sustainable Development Goals. Recently, she spoke about her bigger vision. What should be the legacy of Dubai Expo? Some of you know the Eiffel Tower was the legacy of a French Expo. The Ferris wheel was the legacy of a Chicago Expo. She stated that she wants the legacy for the Dubai Expo to be an inclusive global care system, global healthcare system that was crisis-proof and fit for the future. Some of you know Minnesota is bidding to host a World Expo in 2027, specifically on health. And we look forward to taking the baton from Dubai and carrying this vision of inclusion, of crisis-proof, of future-ready, towards that 2030 deadline for sustainable development goals in health and other issues. Expos in the past were dreaming about the future and new inventions. It's remarkable that Her Excellency is thinking about the most important thing we need to do now is making the future inclusive, equitable, and crisis-proof. Some have called this year the Great Pause. I think of it as the year of great learning, where we've remembered the past We've studied the science. We're taking on new commitments to each other that really bring to life a quote from one of our most beloved former state senators, Paul Wellstone. He would remind us often, we can all do better only when we all do better. If he was alive today, I think he would say, with all the chorus of the whole planet, and we all must be safe by ensuring that we are all safe. Thank you again for joining us today, and let's get on with our program. It's my honor, it's my privilege to introduce a woman who both was my teacher before I entered public office, but she also was the inspiration for my decision to run for public office. My Lieutenant Governor, the Honorable Peggy Flanagan. Thank you, Lieutenant Governor Flanagan, for joining us this morning.
Bonjour, happy World Health Day. I'm Minnesota Lieutenant Governor Peggy Flanagan, and I am so excited to be joining folks from every state in the United States and from over 65 countries. For those of you who don't know me, I'm a mom, a former state representative, a lifelong advocate for children and families, and a member of the White Earth Band of Ojibwe. Wherever you are in the world, access to healthcare that meets your needs is critically important. But we know that far too often, the color of your skin or the zip code where you live determines your health outcomes. Here in Minnesota, we take a lot of pride in being one of the top states in the nation on all the lists that you want to be on top of. Healthcare, education, quality of life, you name it. But the reality is different for Black, Indigenous, and Minnesotans of color who face some of the worst disparities in the nation. The disparities that have been with us since the time of colonization are impossible to ignore any longer. When we're facing a virus that impacts those with underlying conditions like diabetes and high blood pressure more seriously, we have to grapple with the fact that Black, Indigenous, and communities of color have higher rates of those conditions. When we're talking about exposure and vulnerability to COVID-19, we have to talk about the fact that frontline essential jobs that we have relied on so heavily this past year are disproportionately filled by Black, Indigenous, and people of color. And as we are thankful for the incredible achievements of effective, safe vaccines in less than 1 year, we must now meet the challenge of making sure that everyone who wants a vaccine, especially those who are most at risk, can get it. We have to look at the full picture, tell the truth, the full story of our state, our country, and our world. And as we discuss the full global picture of health, it is my honor to introduce the opening keynote speaker, Dr. Tedros. Dr. Tedros has served as the Director General of the World Health Organization since 2017. Like many leaders in public health and government, he has faced a year that none of us could have imagined and met this challenge with focus and commitments to the health of all people. He was named one of Time Magazine's 100 most influential people of 2020. And Dr. Tedros and I share a vision of a world in which everyone can live a healthy, productive life, regardless of who they are or where they live. And it's on all of us here, in whatever sphere of influence we might have, to work towards that world. With that, Dr. Tedros.
What does health mean to you? For many people, it is the foundation to do the things in life they love, to enjoy the company of others, to work, to play, to learn, to laugh. Health is life. So many people have lost their health in the past year, but they have lost so much more: their jobs, their ability to see their families, to travel, to live life. And more than 2.7 million of our sisters and brothers have lost their lives, and we have lost them. The hard truth is that some of those people died simply because they could not get the care they needed because of where they live or where they are or how much they earn. Inequality is not a new problem, but COVID-19 has brought it into sharp focus. The pandemic has pushed an estimated 120 million people into extreme poverty. It has significantly increased gender inequalities, with more women than men leaving the labor force. And as we speak, rich countries are vaccinating their populations while the world's poor watch and wait. Health inequalities are not just unfair. They make the world less safe and less sustainable. So, as they build back from COVID-19, it's vital for all governments to invest in better health services and remove the barriers that prevent so many people from using them, so more people have the chance to live healthy lives. This World Health Day, we're calling on you to use your voice and your vote for a fairer, healthier world.
Tell Daniel to unmute me now. Thank you, Dr. Tedros, and thank you, Lieutenant Governor Peggy Flanagan. It's been such a pleasure working this year with the World Health Organization, and we thank you very much for all of your assistance, yourself, your staff, and all who've made this day, this special day, possible. It's also my privilege and honor to introduce our next presenter. Michael Ninehouse is the U.S. President of the UNICEF, the United Nations Children and Families. And UNICEF is the organization globally that partners with the World Health Organization to handle the distribution to low and middle income countries around the planet as part of the COVAX, the international humanitarian organization that's overseeing that distribution, that's tackling directly the inequities and inequalities that come with the distribution of the pandemic treating vaccines that we're now doing right now. They are in the middle of that fight to get the vaccines out and to make sure people can use those to head off the new variants that could set us back to day one again. We're very honored to have Michael here today to share with us his 30,000-foot perspective on how is it going in our planet's effort to address health inequities and how can we help UNICEF and others to reach their goal. Michael's also a Minnesota native, and 25 years of his career has been in global development and humanitarian assistance. So we're really welcome Michael back to his home state. And thank you so much, Michael, for joining us here today.
Hi, good morning. It's really great to be with you. It's wonderful to be back in Minnesota virtually, if nothing else. I am a Minnesota native, as Mark mentioned. I grew up in the Twin Cities in suburban Apple Valley. I have family stretched out from Lake Minnetonka in the west to the St. Croix Valley in the east to Egan in the south. I'm a big fan of Minnesota United soccer team, Go Loons. Professionally, I've been working in the global humanitarian and development space for 25 years, much of that time focused on global health issues. And so your focus on health equity is right at the center of my interest and passion. I took over as CEO of UNICEF USA about a year ago, just after the pandemic locked everything down. And at the same time that UNICEF's role in striving for equity in the global distribution of COVID-related diagnostics, therapeutics, and now vaccines began to ratchet up. A little bit about UNICEF. I'm sure most of you know UNICEF. We are the United Nations Children Fund. We work relentlessly day in and day out to give every child an equitable chance in life through our programs in healthcare and immunizations, safe water and sanitation, nutrition, education, emergency relief, social protection, and more. And this year we're celebrating our 75th year in existence. UNICEF is a UN agency, but it isn't funded by the UN. Our resources come from voluntary contributions from governments around the world and from the private sector, philanthropists, and donors. I lead UNICEF USA. We're an independent nonprofit here in the US charged with rallying the American public and government to support the world's most vulnerable children through UNICEF. Working through UNICEF, we have helped save more children's lives than any other humanitarian organization. We also do some work here in the US to advance the rights of children and the well-being of children. One of our programs is called the Child Friendly Cities Initiative, in which we work with municipalities to help ensure its budgets, policies, and programs create a healthy, equitable environment for all children. And we're proud to count Minneapolis as one of our child-friendly cities partners. Today, UNICEF is engaged in the single biggest effort in its history, working to ensure equitable access to the COVID-19 vaccine for health workers and other frontline workers, vulnerable adults, and ultimately everyone in 92 low and lower middle income countries. We're also supporting the vaccine procurement for another 100 countries or so. And we're doing something that's never been done before, something that UNICEF has never done before, a truly global vaccination campaign like this, and to do it as equitably as possible. The goal is to get 2 billion doses delivered and into the arms in those countries by the end of this calendar year, and then to keep going next year. To date, we've shipped 34 million doses of COVID vaccines into 99 countries, and we should reach more than 200 million doses by the end of May. In both promoting and defending the idea of global equity, I've been saying for months that the health worker in Malawi needs the vaccine as much as the health worker in New York or in St. Paul. I was thrilled 2 weeks ago to see a video from our field office in Malawi featuring a nurse there who had just received her first vaccine dose. It was later than the health workers here in the US, so not completely equitable, but it is happening. So why has UNICEF taken a critical lead role in this global vaccine effort. Our mission and our work is child focused, and yet the vaccines aren't going to children, at least not now. There are two reasons that we're at the center of this. First, we are already the world's largest procurer and distributor of vaccines. Each year, we procure about 2 billion doses of essential basic childhood vaccines, and then vaccinate nearly half the world's children under 5. We have the global procurement mechanisms, the supply chain, staff on the ground, relationships with ministries of health and local health centers, and with the vaccinators themselves, the health workers who actually put shots in arms. This is a core competency for UNICEF, and no one else has it. When the World Health Organization and a few others got together once the pandemic had begun and vaccines were first described, they put together a partnership that they called Act A, basically to accelerate the tools for combating COVID, both in diagnostics, in treatment, and in vaccines. The vaccine pillar of that is called COVAX, and they turned to UNICEF as the natural choice to do the actual work within the COVAX pillar, the equitable distribution of vaccines. So it was a natural fit for us, something, again, that is a core competency. The second reason that we are at the center of this is that we are, in fact, child-focused, and we've seen the impact of COVID on children around the world. It has been devastating. Children aren't typically those getting infected with COVID-19 and aren't suffering the symptoms, but they have suffered nonetheless. Globally, over 1 billion children were forced out of school, and still today, there are over 160 million children who have not been back in the classroom at all. Imagine the impact on their education. COVID caused food insecurity that has put an additional 6.7 million children at risk of severe malnutrition. This is the first year that poverty rates are expected to increase in the past 25 years, and that directly impacts how children live. Early in the pandemic, the Gates Foundation put out a study that said we had lost 25 years of progress fighting poverty in 25 weeks. Kids need a chance to reclaim and restart their lives, and that won't happen until we end the pandemic. And we won't end the pandemic until the vaccines are equitably distributed across the globe. You know that we really have two big reasons to champion equity in this case. First, those of us in wealthy countries have a moral obligation to pitch in. As a country, we've always risen to that call to help those who lack the resources that we do. We need our government, our corporate and foundation sectors, our private philanthropists, and everyday donors to provide the resources to make this global vaccine campaign happen. Second, we have a reason of self-interest. Until we end the pandemic everywhere, we haven't ended the pandemic. Until everyone is safe, no one is safe. Until we get everyone vaccinated, the risk that a variant of COVID that isn't tackled by the current vaccines will arise and circle the globe again is real. We saw how fast that can happen, and we have to keep it from happening again. So we want you to join with us. I'm not making a fundraising pitch here to you, but I am making an end the pandemic pitch. We need everyone to pitch in and help out. If you want to learn more about what we're doing at UNICEF, you can visit our website, unicefusa.org, or you could send me a note personally. Happy to answer your questions. My email is simply michael@unicefusa.org. Thanks again for your focus on health equity. It's the right one now. It is one of the essential issues of our time, and we all need to be focused on it. Thanks for your work, and thank you for allowing us to share a little bit about UNICEF's work fighting the pandemic. Thank you.
Thank you, Michael, and thank you for reminding us about the other implications for our children, but for our future on education, on livelihood, and for the work of UNICEF in helping to bring reality and shape and logistical pandemic response to the whole planet. So we are with you and we support your work, but we also really learn from you and are inspired by your efforts. And those of us here in Minneapolis have been greatly appreciative of the designation of our city as a child-friendly city. And we have work to do to make sure that child-friendly in the time of a pandemic, in the time of this COVID-19 crisis, has new and deeper meaning, connecting us to the whole world. Our next guest is the President and Chief Executive Officer of the GHR Foundation, Amy Goldman. Amy serves as that leadership position at the foundation here in Minnesota. Her training has been in foreign service and diplomacy all over the planet. Her work has been felt and continues to be felt today, including her work on trade negotiations and her global perspective. She sits on the board of Georgetown and the Walsh School of Foreign Policy, the Jesuit Refugee Service International Development Group, Mayo Clinic's Leadership Council, and on the Council of Foreign Relations. GHR Foundation was the first foundation that I found in our country that explicitly tied their grant making to specific sustainable development goals. It was inspired us here at Global Minnesota to dig in deeper and get more directly involved in that work on the UN SDGs or Sustainable Development Goals. I'm really grateful to have her perspective here today. And her remarks will be followed by two of our most distinguished leaders in our medical community, Dr. Jacob Tolar, who's Dean of our University of Minnesota Medical School, and Dr. Anton Decker, President of Mayo Clinic International. Thank you again to all of our presenters for being with us today.
Hello from Minneapolis in the United States. I'm Amy Goldman of GHR Foundation, and it's wonderful to be alongside GHR partners and with all of you today as we observe World Health Day 2021 and come together to advance health equity at the local, national, and global levels. For those of you not familiar with GHR, we're a hope-fueled global funder working alongside communities in the areas of health, education, racial equity, and international development. Our stated purpose is to be of service to people and their limitless potential for good. When Mr. George Floyd was killed almost a year ago, just 4 miles from our Minneapolis offices, we began reckoning with the fact that Mr. Floyd, like many Black, Indigenous, and people of color, had long been denied the right to their limitless potential. In a similar way, the devastation of COVID-19 has awakened the world to a crisis of broken systems. Health, economic, and racial inequities are growing rather than shrinking, and offering us a critical crossroad to rethink the way forward. Yet, we see reason for hope as we hear new calls for change through collaborations such as World Health Day. We're leaning into that change at GHR, taking steps today that prepare a different future, one that heals, that builds community, and creates conditions for equity and solidarity to flourish. And that's why Global Minnesota's focused conversation on health equity is so critical to all of us. In the past year, we brought an equity lens to global health by resourcing the COVID-19 Therapeutics Accelerator for Vaccine Access alongside MasterCard, Gates, and Wellcome Foundations, as well as seed funding the World Economic Forum's COVID-19 Response Alliance. GHR also believes in the values-based approaches of faith actors and supports the Vatican COVID-19 Commission, along with Religions for Peace, to bring equitable responses of faith leaders to communities globally. And we're looking beyond this pandemic in addressing health inequities. As a leading funder in the prevention of Alzheimer's dementia, we are asking ourselves how race, skin color, and income matter. Like in other health issues, it's critical to name prevalent inequities and understand why they persist to truly address them, not only in care, but also upstream into research and to prevention. Because just as this pandemic has been killing people of color and those with lower incomes at higher rates, dementia is too. only more slowly and with no end in sight. Currently, nearly 60% of all people with dementia live in low and middle income countries, which are often least equipped to cope with the calamitous impact of this disease. But we are not arguing for greater equity simply out of altruism or an innate sense of justice. Rather, we also view greater equity as the most practical and the effective approach to solving problems. Because if we aren't proactively focused on understanding and helping those who need it most, we will miss our greatest opportunity to make a global impact, whether it be on COVID, Alzheimer's disease, or other health crises. So it's really a privilege to be among you today, and my thanks to each of you for all that you do in advancing health equity. A special thanks to Mark Ritchie and the entire Global Minnesota team for their ongoing efforts to bring Minnesota to the world and the world to Minnesota. Thank you.
Hello, everyone. My name is Jacob Tolar. I am a physician. I do bone marrow transplant for a living. I'm the Dean of Medical School and Vice President for Academic Clinical Affairs at the University of Minnesota. It is an honor to be here with you today, and thank you for having me. So as somebody who has practiced medicine on both sides of Atlantic and seen it elsewhere over a span of 30 years, I have been struck how location matters. So the ancients said that character is fate. In medicine and in healthcare, it is almost that where you're born and where you get sick is what determines what kind of healthcare, what kind of life, what kind of medicine, what kind of support you're gonna get, and how healthy you will be and how long you will live. The important thing is that it doesn't have to be that way. It is in this day of digital technology, of widespread information sharing and goodwill, in my opinion, it is entirely possible to change that gradient, change that unfavorable equation for the benefit of mankind. As we have been over the last 12, 15 months looking backwards at the COVID-19 pandemic, and all of us looked at it in a different ways. But our radical reflection on that has been that there is a tremendous ability for the information flow. That's the first step. So our university, as many public universities in the United States and elsewhere, has a tremendous number of people who are coming from around the world, myself included. English is not my first language, as you probably can tell. And that is really important because all of these individuals have some experience that they can bring with them. And again, in that network of collective brain, which is the horizontal one, that is spread across the universities, you can find connections between or among fields and among the different pursuits of human knowledge that can enable, and I would argue ennoble, the pursuit of betterment of mankind. So at the beginning of the COVID-19 pandemic, we have seen this very, very well. It was at the time when there were no cases in the United States, but it was really the global connectivity that we had with our colleagues and friends in China, in Italy, elsewhere, that we have been gathering the information, and then later on from New York City, from Seattle. And these connections have been lifelines for our readiness, our preparedness for the COVID-19 pandemic. And I'm sure that other places around the globe have had the similar experiences we had. These early connections made all the difference. So we need to normalize information around the globe. We have to be able to provide the information to people that are on the ground and the caregivers anywhere, need that ability to connect with others so that they can deliver to their communities. Now, the examples from COVID-19 are, I think, important examples. So for one, we had a task in front of us to build a new ventilator. If you go back in time about a year, you may even remember how certain it was in the different prognostications that the COVID-19 pandemic will overwhelm the ICUs and that there will be in front of my ICU doctors and nurses and other teams, there would be a decision made, who's going to get a ventilator and who's not going to get one. Are you going to do it by age? Are you going to do it by geography? Are you going to just toss a coin? This is a brutal way of thinking about medicine, because our common denominator in healthcare is, our singular talent is that we alleviate suffering. So it comes as a tremendous burden to have to make decisions based on resources, not on the clinical guidance. So what happened at that time is that there was an anesthesiologist who was sort of out of work, quote unquote, because we had a restriction of the number of cases we could do in the operating room. And there was a group of engineers in the Institute of Engineering and Medicine, and they partnered together across the fields of medicine and engineering and built a low-cost ventilator that was essentially a toolbox in an ambu bag. And that was mediated by the connections we had internally at the university. It was really something that benefited from the glorious leadership of President Gable, who from the very beginning has assembled a focused team of individuals that have been crossing these college and departmental and field boundaries as if they were not existent, because they are not existent if you are tasked with a tremendous challenge such as the pandemic. And we have catalyzed this by internal grant programs that we have given, I think, 75 of them. And this one was one that we have funded. And as it's many things in science and technology, you don't know what's going to work until it works. So we have had that mindset that was not a fixed one, but a growth one, responsive one, that said anything reasonable goes. And then we will see how it works. And this was one of these grants. And what happened in a very quick succession, we went from a ventilator shortage that typically a ventilator costs about $15,000 to $25,000 on the American market. And at the time that we were trying to buy more, not only that the supply chains were exhausted, but also they were overwhelmed by increased prices. So these ventilators that typically would sell for $15,000 would go for $150,000, and we were not in a position to get them. So getting a ambu bag in a toolbox for $150 was a tremendous difference. But we also, and that's equally important, we have not cut any corners. We went to FDA, got the approval from the FDA, and the plans that we have, the blueprints that we have developed around that ambu bag and the toolbox, that conveyor ventilator, have been posted online so that anybody can use them. This is a crowdsourcing, if I've ever heard one. And that is that important portion of what we have learned from the COVID-19, that the research and technology, the advances were not driven by ego or profit. They were driven by compassion and ingenuity. That's very refreshing, and that's very optimistic. That optimistic stubbornness that went into this, that boldness of spirit that have connected people that usually don't work with each other, and the connectivity of a common purpose to actually help the communities at need. And then we have seen that these plans were downloaded more than 100 times around the globe and used in the real pandemic. And the beauty of this, of course, is that you do not have to have the best-selling, most profitable answer to the problem. The challenge here is much more egalitarian. It is to have the most inclusive one. And the ability to look at the resource-scarce environment is another power of constraints that we have learned from COVID-19 pandemic that I think is very applicable to other realms of healthcare and global healthcare, especially now. Another example can be the diagnostic and pharmaceutical and therapeutic interventions that we have been able to participate in my opinion, my teams and others, in a magnificent way with the clinical trials, with the new ability to repurpose drugs and actually make a statement that is scientifically valid whether these drugs are efficacious or not. And the one part of the of that quest that I like very much is from their medical school, where a researcher and his team in genetic engineering and genetic editing using the CRISPR-Cas9 technology. You may recall what it is because it got a Nobel Prize, which I'm extremely proud of the committee that it was given to two women for the first time in history, I think, in medicine and physiology. And so the CRISPR-Cas9 technology has been applied by his team to a very important question, which is if you have a little shortness of breath, a little cough and headache and perhaps fever, these days you are convinced that you have COVID-19, and you may not have COVID-19, and it actually matters a great deal whether we know whether that patient has a COVID-19 or not. Now, the other respiratory ailments, such as influenza A, influenza B, and what's called respiratory syncytial virus, can present much like that. And so this team has put together a sort of a multifactorial, multiplexed way of using that technology in a very simple way, simple to perform way, not simple to describe and manufacture way, but simple to deliver way, user-friendly, customer-friendly way, to distinguish among these four strains of viruses. Again, the COVID-19, the SARS-CoV-2, the influenza A, influenza B, and the RSV. This is a test that can be done in a tent, in a doctor's office, it can be done in a pharmacy, and it's a really convenient and useful tool how to differentiate among these four respiratory ailments that are then informing the care and how we go about this. So pretty cool, I don't think. These are just several examples that I don't think will be disregarded as we go forward. And what I think it comes back to the very beginning where I started, which is the question of healthcare. So healthcare has been approached differently at different parts of the globe, but at many places, in healthcare, not all people are created equal, and sometimes it's a more privilege than a right. And that is something that we have, I think, seen the massive humanizing force of the response to the COVID-19 pandemic play out and amplify that compassion that is, again, driving the research rather than ego or the profit alone. Long before that pandemic, in our Center of Global Health and Social Responsibility, led by Dr. Shaili Prasad, from whom you will hear in a little later, has been operational and connecting the things around the globe in how we can be meaningful, how we can deliver for the communities globally, and how we can amplify the local knowledge to something that is beneficial worldwide. Now, the health equity has always been a significant barrier everywhere. And sometimes these are the components of that are parts that are difficult to change or cannot be changed. The geography, the physical distance, the different flavors of government, different local histories, different cultural changes. That is a challenge. And some of it may not be accessible to our compassionate will. But there are other parts that are actually open and are in the realm of what we can do. And the most prominent of those, I think, at least for me, has been the ability to listen to the communities. And I have learned from my own patients more than I can share today, but certainly more than I have learned from different combination of textbooks and my colleagues about how exactly to approach somebody with leukemia or sickle cell anemia or other conditions that I treat. Now, the listening to the communities is incredibly important, not only because of the righteousness and the justice of it, but also because the knowledge that comes into play has many, many times benefited from the heterogeneity of ideas. And that ability, that variability, or you can call it a diversity in knowledge, has many times in the history of mankind been the driving force of nearly every civilization. And that human diversity usually that idea comes from an outlier. And that outlier sometimes, has been a person or a view or an uncomfortable emotion that has been pushed to the fringes of the mainstream, and yet has become the catalyzing, defining direction that the knowledge has taken afterwards. So we are sort of removing ourselves from coming into the communities and saying, this is how we do it, this is what you're gonna do, and rather turning this into a mindset where we are combining the boldness and reticence. The boldness in we really want to help, and the reticence in the ignorance, the humility of ignorance that we recognize is a part of every discovery. Every science, every technological breakthrough that I know has been built on that. So I think that the three main points that we are focusing in the World Health today is how to enable information sharing in a way that is accessible worldwide. The second would be that the research that has widespread benefits does not have to be the high-end, high-profit medicine or technology alone, that a scarcity, in fact, can catalyze some of the ingenuity that may not be available to us if we follow the bottom line and the logic of profit alone. And lastly, the partnerships that develop, the genuine ones that are passionately dispassionate. They are dispassionate about the values that the communities bring. They are dispassionate about the values that science and technology brings, but they are very passionate about the outcome, which is, again, alleviation of human suffering, the moral stakes of the economic competition that we are facing today globally. So these partnerships, the third component, will benefit both parties, and we are reminded this year more than ever how connected we are across the globe. This is for many, many, many times, but again, the recent examples are the most vivid. In any corner of the globe, in one continent, the event can influence communities around the globe. So whether this is COVID or climate change, I do see the health and healthcare as a dependent on our individual actions as a whole that is beneficial to everyone. And the fact that we are moving from the pandemic to endemic with COVID-19, and that we are, I think, seeing the functional end of the COVID-19, not the COVID-0, mind you. The COVID and other coronaviruses will stay with mankind as many other viruses have done, but the ability to domesticate the pandemic into something that we can deal with is only sort of a background to how we need to approach the global healthcare, our place in it. I personally think that this is a glorious time. I think that reality is fabulous. I think that the steady state optimism with which many groups have approached this last year will serve us extremely well in how we develop solution-oriented platform of knowledge, how the knowledge discovery, the knowledge production, the epistemic part of it will combine with the design, how we take the framework of the traditionally hierarchical and siloed way of distributing knowledge into more a network kind of distribution of knowledge, where ideas are non-scarcity goods. You know, the more you use them, the better they do, and they can recombine in a way that would be impossible if you don't let them loose in this way. So the optimism is born from that experience, and having this connected to the needs of the communities and maximize the public good is, in my opinion, going to be one of the best ways of approaching this decade. All right. So I'm grateful that you have all come together in celebration of World Health Day, and I hope that the discussions and sharing of information is productive and enjoyable. Thank you.
Welcome, and thank you for joining World Health Day Symposium 2021, hosted by Global Minnesota. I'm Dr. Anton Decker, President of Mayo Clinic International. Mayo Clinic is delighted to be part of this event. There has never been a more important time to address global health equity. Not only is it the right thing to do, but COVID-19 has reminded us how connected and dependent we are on our collective health as a global village. Let me share with you a personal story. I grew up in South Africa, the product of two physicians, a general practitioner and a surgeon. As a child, I would join my father on ward rounds over the weekends in a hospital that treated patients who didn't have timely access to care. So many patients would present with diseases that could have been prevented or cured had they just had access to vaccines, screening, and basic health care. Even at a young age, I thought that this was unjust. As a privileged child of a medical family, and as an adult physician in the medical profession, I've always had immediate access to healthcare of any type. That was until COVID-19 hit, and I had to wait my turn to receive the COVID-19 vaccine. It was the first time I experienced the tiniest bit of what people feel who have no or inadequate access to care their entire lives. My childhood has long gone, but I still ask myself, why have I been so fortunate, and why do health inequities still exist? More than ever, now is the time for us to address global health equity using the knowledge, people, technology, and tools at our disposal. For Mayo Clinic, the pandemic highlighted 3 lessons to improve health equity. First, the world needs a trusted source of medical knowledge. As a not-for-profit academic medical center that sees 1.3 million patients a year from the US and over 130 countries around the world, Mayo Clinic is the most trusted source of health information and care. We are guided by our primary value, established by our founders more than 150 years ago. The needs of the patient come first. That value informs everything we do, from treating patients to providing evidence-based care, up-to-date medical information for those who visit us, and for people who look to us online from around the world. It also means conducting leading-edge research to provide meaningful data about health disparities, both related to the pandemic and other diseases. It's up to organizations like ours to provide trusted, scientifically based medical knowledge to the world. Second, knowledge by itself is not enough. It must be applied to a framework of dependable partnerships, people, processes, and technology. Let me give you an example. This year marks the first anniversary of our partnership to develop Sheikh Shaboot Medical City in Abu Dhabi. This collaboration involves Mayo Clinic working shoulder to shoulder with colleagues in the United Arab Emirates. Together, we are establishing another major trusted health resource for patients in the region of the UAE, the Middle East, and beyond. We are taking the Mayo model of care closer to the patient. The same is true of our new clinic in London, where expertise in treating serious or complex diseases is accessible on-site and virtually. The pandemic also demonstrated in real time how important research collaboration is, all across the globe. Our newly established Mayo Clinic platform will create a framework for scientists worldwide to access secure troves of curated, de-identified health data that can advance new cures and treatments. For example, with data from 7 million electrocardiograms, Mayo researchers and their collaborators are creating a tool that doctors can put in their pockets to inexpensively detect heart weakness before patients become sick. This simple digital stethoscope may be a means to bring specialist care to remote or underserved locations. Third, no single entity has all the answers. The greatest opportunities emerge when we combine forces and when we learn from one another. We saw this during the pandemic. When ventilators were in short supply, one group of innovators in South Africa took it upon themselves, in a garage of all places, to develop a ventilator that can run without electricity. It's proof that elusive solutions will only be found through human ingenuity and collaboration. Our interdependency is so beautifully described in the Zulu phrase, Ubuntu. Ubuntu means I am because of who we all are. It describes our common humanity. Indeed, the COVID-19 pandemic reminded us that when we all work together, we are greater than the sum of our parts. Looking ahead, we must take some of the lessons learned during the pandemic and move ahead bravely with new approaches and new resolve. So as we think about what organizations, communities, and individuals can do to address health equity for people worldwide, remember this. We need not wait a single moment longer to improve healthcare in the world. There's no greater moment for us to work together than now. One of Mayo Clinic's founders, Dr. Will Mayo, said it best long ago. The best interest of the patient is the only interest to be considered. And in order that the sick may have the benefit of advancing knowledge, a union of forces is necessary. From all of us at Mayo Clinic, thank you.
Hello, everyone, and welcome back to Global Minnesota's World Health Day 2021, where we're focusing on health equity and equality worldwide and right here in our backyard. For those of you who've just joined us, we've just had excellent presentations from Dr. Jacob Tolar, head of the University of Minnesota Medical School, one of the leading research and public service, public health facilities in the planet. And we also heard from Dr. Anton Decker, who's president of Mayo Clinic International. These two global leading institutions are part of a bigger picture of how we are institutionally tackling health inequities, inequalities, and disparities that this COVID pandemic has shown a bright spotlight on. And it's exciting to hear about some of their successes and to look forward to their continued leadership in that realm. Our next guest is a very special leader, a global leader, who has had the responsibility over the last year of looking at the entire realm of the response at the global level to the pandemic. Prime Minister Helen Clark, who was Prime Minister in New Zealand. Before that, she served as Health Minister and then went to the United Nations, where she was the head of United Nations Development Program. A year ago, she was asked by the World Health Assembly, which is the governance body of the World Health Organization, to bring the independent panel of experts to look at the response at the global level in terms of preparedness, in terms of where we need to be going forward. They'll be presenting their findings and results to the World Health Assembly that'll come up later this spring. And I had the good fortune of being able to interview her at her home in New Zealand. I'm so pleased that she could be part of this important day. She's one of the true lifelong public servants at the national and global level who's put health equity and equality in the forefront and then help to make the global policies to turn those words into reality through good deeds. Prime Minister Clark, you've been leading very important views and commissions that have been looking into the future of children, future of where we need to be. You are coming up with an overview, in a universal vision of what we're learning. Can you share with our audience from around the planet some of the things that we should all be learning from this current experience?
From July of last year, I've been rather preoccupied with the independent panel reviewing preparedness and response to pandemics as requested by the World Health Assembly. And we produce our report in around mid-May. We've learned a lot of things. We set out to be not a blame casting, but a truth-telling commission about what went wrong, what the lessons are that can be learned from that for the future, and then making recommendations related to the evidence and the learning from it. I think in a nutshell, we learned that most countries were not prepared for this. Secondly, the responses were too slow at each level, and that includes, frankly, for most countries as well. And then thirdly, many didn't have in place the mechanisms to stop the pandemic becoming a full-blown social crisis and also economic crisis. So going forward from this, and I'm not giving away any secrets because I've said this many times in discussions about COVID, it is a disease of inequality. It has hit people very, very differently, both country to country and within countries. Those who have been able to cushion their people from the social and economic effects are those who have had universal social protection in place. But 4 billion of the world's citizens don't have even basic universal social protection. So along comes a lockdown to contain a disease, which can be very necessary, but people still have to put food on the table, and there's no social security to do that with. So I hope that out of this pandemic comes a call for universal basic social protection to be financed by whatever means. Obviously, mostly from a country's own budget, but for least developed countries, it will require a global solidarity. Secondly, universal health coverage is an absolute must, and it has to be universal. It has to reach every corner of a society. That means migrant and undocumented workers, because otherwise you may sit self-satisfied as a country thinking, oh, we've got COVID contained, but you forgot about the migrant workers' hospitals, where it got away again because you weren't reaching them. Thirdly, COVID has brought to the fore the issue of health inequalities, the non-communicable diseases burden, which again falls most heavily on marginalized groups, on lower socioeconomic groups, on ethnic and indigenous minorities. We have to work much harder to overcome those. So those would be, three very basic learnings: the universal social protection, the universal health coverage, attacking the social determinants of health. These are critical before we even start on your stress testing for preparedness and how you're going to respond. You need the basics in place.
Well, I know that when you were serving as Prime Minister, much of Asia had this shock of SARS, and that it mobilize thought and action at the legislative level in terms of preparedness documents. Can you give our audience a little sense of that history and some of the lessons then that were very, very effective in making New Zealand a real model for the entire planet in terms of immediate action, definitive action, and success?
So for most of the world in 2003, SARS was the dog that didn't bark. It hit in China, it hit in some countries in the region. In New Zealand, we were very, very vigilant, as I'm sure Australia was, sitting at the bottom of the Asia Pacific basin as we do. So I was Prime Minister. We did a review post-SARS of whether we'd had the level of readiness, had the worst happen for us. And one of the learnings was we needed to update our legislation. And so in 2005, our government passed the Epidemic Preparedness Act. And that was very important going into this pandemic because our government had a not ancient piece of legislation, a 15-year-old piece of legislation which had been specifically written after a pandemic event in the region. I think that was very, very important.
And will there be a way that some of these new ideas, the notion of an international treaty around preparedness, the talk of maybe a decade of action on preparedness, like we have now on natural disasters, but on epidemics, or some of these multilateral and more global things, a good next step for bringing us all up to that sort of level of preparedness?
I think there's a growing consensus that a framework pandemic convention of some kind is going to be a good idea. It will focus attention that helps mobilize action. When I was a young health minister in 89-90, I was going to the World Health Assembly pushing for a framework convention on tobacco, and it happened. And that has galvanized action on tobacco. So in the same way, I think a framework convention on pandemics will elevate the issue again. And that's very important because the response to public health emergencies of international concern hasn't been what we would have hoped in this instance. Dr. Tedros made the declaration of that public health emergency of international concern, a FIEC for short, and we'll use that phrase from now, on the 30th of January. But as our panel has looked at what happened after that, and of course before, but after the month of February is like a deep hole where nothing much happened in many countries. Now, let's accept, East Asia from that because, Korea knew about SARS. The countries in the region had had the experience that they were much more vigilant. But elsewhere, it was almost as if the world having escaped a bullet with SARS and escaped a bullet with Ebola and largely escaped a bullet outside Latin America and the Caribbean with Zika. We watched what was happening in China as though it couldn't happen to us. This was ridiculous. When you have such a declaration made by the Director General of the WHO, every country has to move on to alert. It's not about other people over there. It could be you. And here's the difference with SARS from 2003, or one of the key differences. In 2003, China was not the globally connected country that we know today and whose tourists and travel we value today. Today, a pathogen like this virus, which gets out, will be on a plane within hours and it's moving. So we have to respond faster. And that's a message to every country. Never ignore a FIEC as though it did not apply to you because we'll all pay the price as we have.
I've noted that some countries like, let's say, South Korea, who certainly have the financial and technological and pharmaceutical firms and capacity to have produced their own, like the US, a kind of a nationalist view, and the UK and others. But South Korea and other countries, yours and others, said we are going to be part of the COVAX system because that's what it'll take to have an equitable approach to something that we know either is going to be universal or none of us are safe. Do you think that awareness is part of that kind of learning that, SARS kind of was a shock to the system and there's no way to say, oh, we're going to be safe because we're rich or we're, an industrial country? There seemed to be as much disparity in the intelligence and the future thinking of countries' responses as we see disparities in, let's say, the deaths for indigenous people and people of color. So there's several different kinds of disparities in this COVID response.
Yes, there are disparities at every level, the disparities within our countries and then the disparities globally. Now, when our panel issued its interim report with observations about what had happened in January, we made a call for vaccines to be rolled out equitably. And at that time, the background was the People's Vaccine Movement. And the point was a simple equity and rights one. It said, what's fair about us in New Zealand and Canada, say, being vaccinated in the next few months, when in Sierra Leone or Somalia, it may be 2023, 2024. Because COVAX only set an ambition for this year to vaccinate 20% of people in low and middle income countries, which clearly is grossly insufficient. They have had hopes of getting up to 27%, supplementing COVAX by other means. Even that's tough at the moment with the vaccine nationalism, which is leading to restrictions on exports and so on. But what became even more apparent after our January report was that the issue of the vaccine rollout goes beyond that equity between each of us to be able to access an essential protection, to the fact that if we don't stop transmission everywhere, we are going to see more and more variants. The control of the disease becomes more challenging. I think in many countries like my own, the assumption was a vaccine will come along, we'll all have it, and we'll be fine. No, because the variants are going to challenge the vaccines. Now, the scientists will find a solution, but it will mean regular revaccination to cope with new variants. So we've got to try and get this genie back in the bottle, because you can see the logistical challenge now. It's tough enough to roll it out to the significant proportion of the world's 7.6 billion people once. To do it every year, I mean, this is huge. So we have to arrest transmission. Vaccine is a critical tool in that right now, and updating vaccines. So, by the way, are the non-pharmaceutical interventions, the public health measures. We are going to have to keep up a significant level of vigilance. At the moment, the best hope is to move from pandemic phase to endemic, but I would personally love to see our world aspire to what countries like New Zealand and Australia have set as their goal. If you see it, you stamp it out. Every time you see it, you contain it, you stamp it out. That's where we want to be. It's a big hill to climb at the moment.
Well, and I think people have resonated with, some, for example, the big accomplishments that have been made on polio and, other things in their lifetime, and organizations like Rotary. And, there is a kind of a social awareness of this general idea. But at some point now, the discussion becomes something about money. People in more wealthy countries spending quite a bit of money on stimulus and other things. Today, the U.S. Treasury Secretary Janet Yellen began bringing home to the United States a discussion I think she's been having kind of quietly with the larger partners of the United States about some kind of a minimum corporate tax and some way of a more global approach, so there isn't as much of an incentive to sort of have a tax haven or to use tax rate manipulations to attract. But do you see from your experience with heads of state, finance ministers, the international bodies, the European Bank and the World Bank, do you see the way that we might move to ensure the amount of money that's needed to invest to first be prepared to stamp it wherever it shows up and then be able to do it in the way that would make it effective and would eventually basically have it under control to the extent that we can?
The issue with investing in preparedness is that it's often about investing in the dog that didn't bark. And when budgets are pressed, it's easy to sort of put aside money for the kinds of things which would help you be resilient to a pandemic threat. But clearly, every finance minister in the world knows the cost of COVID to their budgets and to their economies. I know the IMF World Bank meetings are online this week out of Washington, D.C., and the IMF tells us broadly that the global economic loss for 2020-2021 will run at about 10 trillion, not small, and for the 2020 to 2025 period, the loss from COVID will be about 22 trillion.
Billion.
So this is huge, right? So then finance ministers start to get very interested. And by the way, one of the keys to getting the right level of preparedness and response in this is to elevate how you deal with preparedness and pandemic threats out of the sort of bottom layers of a health department bureaucracy with the International Health Regulation focal point and get it up to the level of finance ministries and presidential and prime ministerial offices and the whole of government coordination. If we can do that, we're on a roll. So a number of things I think are important here. Firstly, the IMF does have tools. The IMF has its Article 4 consultations. And in the time of Christine Lagarde in particular, it began to broaden what it was interested in talking to countries about as it assessed their overall fiscal and economic conditions. It added in climate change, for example, as a risk.
Right.
Pandemic is a huge risk. And so I think there's quite a lot of interest in the IMF sort of putting into its Article 4 consultations a discussion about what is your level of resilience to this? Because this matters for the projections of a country's economy. Are you prepared for this risk if it comes along? That's one point. Second point is that clearly we're talking about a global public good here, because an outbreak like this in any country that's highly interconnected is going to be something with potential risk to all of us. So how do we finance on an ongoing basis preparedness and then response? So if you separate the two, I think that for the high middle income countries and the high income countries like New Zealand and Canada in the latter category, of course, we're expected to finance our own preparedness and response. But for many of the lower middle income countries, there does need to be a global finance aspect to this. The question is it a standalone facility? Is it a window in the World Bank? What extra fiscal tools and promissory notes, if you like, does the IMF need? You need to build the capacity for preparedness in lower middle income countries that don't have it. And then when a pandemic threat materializes, the response will need finance, and that needs to come pretty quickly. So you do need a dedicated window or facility somewhere for this. So there's a lot of different concepts about our panel. We'll have something to say on this. The G20 has set up a task team headed by the former head of the International Finance and Monetary Committee of IMF and Singapore Deputy PM and Finance Minister. And they're looking at what the mechanisms might be. We're talking to them. I think Mario Monti, who's doing a review for the European region of WHO. A lot of people are thinking along these lines now, how to finance a global public good and make sure that the money can reach every corner on earth.
So this seems like a very good thing. You're mentioning the necessity of kind of pushing it up the agenda and getting it at that level. That's one thing about the proposed treaty. Then heads of state and other ministers get involved. I've been aware that some of the large sort of public events, the Olympics debate and questions in Tokyo, the World Expo planned in Dubai and the World Expo planned in Osaka, this has generated a certain kind of discussion. And Her Excellency Reem Al-Hashimi, the head of the Expo in Dubai, came out, I think in a Bloomberg TV interview, saying our legacy of the Dubai 2020 Expo, which has been postponed a year, but coming in October, won't be something like an Eiffel Tower. It will be a universal, inclusive global healthcare system. And so she's taken the opportunity of this crisis to say out loud what you've been saying and others in their conversations, that we're not all going to be safe until we're all safe. That means it has to be global. That means it has to be about inclusion, everybody, not just somebody. And we have to do this together. And we were thrilled here in Minnesota because we're bidding to host the World Expo in 2027, so after Osaka, on Sustainable Development Goal number 3, good health and well-being for all at all ages. So we can imagine if the Dubai folks kick off a global campaign of some kind about a universal, inclusive global health system, that 2027, we can help push that ball. In 2030, the deadline for many of those sustainable development goals, we can see progress over a decade. Are you optimistic that we can get this ball rolling and keep it rolling now that we've been warned a few times?
Well, if not now, when?
Thank you.
So, look, it never before has a pandemic threat, which actually materialized into an actuality and catastrophe, commanded the attention of heads of government and state like this. So, this is the time to act. And certainly our panel will have things to say about the way in which heads of state and government need to be involved. You know, if you go back to the great global agreements of 2015, the Sustainable Development Goals, there was a summit at the UN. But the same year, there was the Sendai Framework for Disaster Resilience. Well, how many heads of state went to that? Very, very few. And actually, in the Sendai outcome document, there are good references for the pandemic resilience that needs to be built and the preparedness and being risk informed about pandemics. So we now have the opportunity to lift this out of the sort of levels of ministers of civil defense and IHR, International Health Regulation focal points, and bring it up to the top level of government, which is where it needs to be. These are existential threats. The far-sighted in our global community have been warning us of what a pandemic could do. I don't think anyone really took a lot of notice of them. Now we've seen what it can do. We know that zoonotic diseases, the animal to human transmissions, are going to keep coming at us. So we've got to be ready. We've got to be better prepared. We've got to act. When WHO says jump, we jump, right? We don't mess around and watch. I'm confident if we can all get these messages, if government's determined to really review and overhaul all their response and preparedness mechanisms, and we get the right level of global focus and attention and alert and surveillance and communication and good scientific guidance, we can do this. It's not rocket science what has to be done. It's political will. And I think my appeal to your audience today would be help generate the political will to lock this in so that we don't just forget. We'd forgotten about 1918. My father's 99 years and 3 weeks old. He wasn't born in 1980. Very few among us living today have any memory, probably no one, of 1918. Let's not forget this one.
Prime Minister Clark, thank you so much for inspiring us, for terrifying us, for giving us a picture of the fact that we have the raw materials if we put the political will together, and if it gets taken to the highest level of leadership, and all of us have to be engaged in making that political will come to life, in addition to taking our personal responsibility and be part of the solution. Thank you again for joining us, and be safe there in New Zealand.
Hi, my name is James Hereford. I'm the president and CEO of Fairview Health Services, and we're here to mark World Health Day, and I'm here to talk about health equity. I'm very proud of our organization. mHealth Fairview has led through action, and we do so at a time when healthcare systems have become increasingly unaffordable, inaccessible, and inequitable. The pandemic has laid bare these inequities. Statewide data shows that minority and underserved communities in Minnesota have experienced greater rates of illness, hospitalization, and death since the pandemic began. While BIPOC Minnesotans represent 21% of the overall population, they also represent 28% of COVID-19 cases, 31% of those hospitalized, and 36% of those admitted into ICUs. Latinx Minnesotans test positive for COVID at a rate 3 times higher than whites, and Black Minnesotans are testing positive at twice the rate. Adjusted for age, Indigenous, Black, and Latinx Minnesotans have the highest COVID-19 death rates. And national data suggests Black, Indigenous, and people of color and the disabled have had less access to vaccines as they're distributed nationally. mHealth Fairview, the team that we put together to think through vaccinations, knew that if they approached this solely on the basis of age, it would lead to disparate outcomes. So they made the decision to take proactive steps to ensure underpopulations have access to vaccines. They did so through a multi-pronged approach. They leveraged community health needs assessment data to identify areas of highest need. And then they stood up pop-up vaccine sites in partnership with trusted community organizations. They also identified our own clinics and conducted tracking to our patients most at risk, and then partnered also with public health in areas of highest need, including Ramsey County. The diverse and historically disenfranchised communities have faced significant barriers to healthcare and have had little trust. We approach this from the use of our mini clinics, the Minnesota Immunization Network, that has immunized over 100,000 Minnesotans in the last 15 years in a partnership. So we used this mini model, and we're able to move and mobilize quickly into action. So since January, we've been delivering vaccines in community centers, church vestibules, homeless shelters, and food shelter offices. Trusted leaders, the minister, the imam, the neighbor, is there to reassure and assuage fears. And our cultural broker program also provides a trusted face, a trusted individual to work with. Through this model, we've delivered more than 250,000 vaccines across the mHealth Fairview system. More than 11,500 have been at 65 different community partner sites, including sites in partnership with County Public Health, with more vaccines being administered to patients every day. We've made our COVID vaccine information available in 6 different languages. And we've shot videos with trusted community leaders in 3 languages to give voice about the need to be vaccinated. As we begin to look beyond the pandemic, we must ensure we're delivering culturally competent care, both inside and outside our walls. Systemic racism in healthcare appears many ways. One place is in the calculators that healthcare providers use to assess risk. One of those is for kidney health. The estimated glomerular filtration rate, or eGFR, has been automatically adjusted based on the race of the patient. Black patients had one set of guidelines, non-Black patients had another. mHealth Fairview will stop using this eGFR adjustment. This change is necessary because the science that underpins it about a race-adjusted EGFR is just wrong. It's incorrect about its assumptions. Race is not a biological construct, it is a social construct. It's simply bad science, and it can have a significant consequence for that person's healthcare. Health equity must be a driving force for transformation and innovation in healthcare. The pandemic has rapidly accelerated both our innovation and adoption to better serve patients. One great example is virtual care. During the pandemic, in the first month of COVID, we delivered more virtual visits than we did in the entirety of the prior year. More than 400,000 virtual visits have been delivered since then, and the benefits and impacts on health equity are clear. We can provide health care without having to take time off of work or to deal with transportation issues or to arrange childcare or many of the other barriers that people experience. In addition to virtual, we're looking beyond to new and bold ways to improve health outcomes and deliver better care. The definition of insanity is doing the same thing over and over again and expecting different results. The same is true in addressing health disparities. We simply can't deliver the same care and the same delivery methods and somehow hope to improve health outcomes. That's why we're reimagining our facility at St. Joseph's as a community hub of health and well-being, to really get upstream, to really think about health, not simply being the high-quality provider once sickness has gotten to a stage where it has to be dealt with. And that's so true for many communities where they use the ED as their primary care provider. That emergency department at St. Joseph's, we know 70% of the visits there were avoidable. If we had done a better job of prevention, they would have been unnecessary. That's the basis of moving from sick care to well care, to get upstream, to focus on wellness, to focus on early intervention, to focus on prevention. It also means focusing on the so-called social determinants or social risks to health. These upstream interventions are especially critical to the unsheltered population. They frequently seek shelter and care in our ED. This does not set them up for long-term health or success. So that's why we partnered with Ramsey County in using our Bethesda facility to create a safe shelter. And that partnership has been ongoing. We have a nurse on site to be able to deliver care and to make sure that we're heading off inappropriate ED utilization and to make sure that we're focusing on early care and prevention wherever we can. We've also partnered with the county to provide COVID testing and vaccines on site. Public-private partnerships drive innovation towards more affordable, accessible, and equitable care. Real progress is going to require us to take integrative approaches, not simply across our healthcare systems, but across all of the services that serve our communities. It's also going to require us to really take a hard look at Medicaid reform, which doesn't promote the kind of upstream wellness-based approaches, early intervention, and it doesn't promote the kind of holistic approach to really identifying and dealing with social risks in the way that they need to. We need to make sure that our investments are fully utilized in terms of promoting health, and we need to advocate for more investment in social supports. Working to maximize community partnerships is going to be critical to building trust and to build connection to make a real difference in healthcare and health status. So on World Health Day, let's commit not just to talking about or even celebrating our advances, but let's commit to doing the work to ensure that we have affordable, accessible, and equitable healthcare for all of the communities that we're here to serve. Thank you.
Hi, I'm Ed Bastian, the CEO of Delta Airlines. And on behalf of our 75,000 employees worldwide, I'd like to welcome you and thank you for everything that you have all done with your collective organizations and as individuals to help us through the most difficult year of our lives in facing the pandemic. It's been a year of unbelievable success in terms of racing and finding a vaccine that's protecting our lives and allowing us to return to life. But it's also been an incredibly difficult year as we've lost so many and have had such a tragic year that we've watched unfold. At Delta, we've done our very best to take care of our people, to protect our people throughout the pandemic, from testing to ensuring that they are, if they're at risk, they can't be at the job, protecting their pay, to finding ways to get the vaccines delivered around the world, to opening up our campus here in Atlanta and having thousands and thousands of vaccinations occur right on our campus, the largest vaccination site in the state of Georgia. And all of this has been about a theme of protecting our health, protecting our wellness, protecting our future, and also understanding that in today's world, the pandemic has opened our eyes to those that are most vulnerable throughout society, including those that haven't had a voice, whose voice was finally heard. We had a chance to see and decide what we were going to do to stand by them and lift them up and help them through this most turbulent time. So on behalf of all of us here at Delta, I applaud you for an amazing, amazing year, and hearts go out to all of you. I wish you nothing but the best in the year ahead as we now are firmly into the recovery phase from the pandemic. And once again, thank you. Your work means so much to so many.
Welcome to all who've just joined us, and welcome again to all who were here earlier. We are moving into our panel on tackling health at the strategic level. We've been looking at the question of inequity and reaching health equity, equality at the global level, but we know it takes work, serious plans, preparation, and then implementation. And there are many things to be overcome, but also we have a lot of momentum and excellent examples. This panel will look at it from the strategic level. It'll look at it in terms of how is it going inside of their companies, the decisions that they've been making, and how that implementation has been truly addressing equity issues, inequality issues. Each panelist will give brief opening remarks, and then we'll have a discussion and conversation about what we can learn, what we can take as lessons at the strategic level. We'll start with Dr. Henry Ting, formerly with Mayo Clinic and now the Chief Health Officer at Delta Airlines. Dr. Ting and his team at Mayo were responsible for shaping the approach of Delta Airlines towards a pandemic and their success in regards to keeping their employees, customers, and the broader community safe by their commitment to following the science, being committed to equity and to community service. Thank you so much for joining us today, Dr. Ping. Please join me on this Zoom screen, and thank you for your opening remarks.
Good morning, everyone. It's a pleasure to be here with Mark and an honor to be on this panel with my co-panelists. My name is Dr. Henry Ting. I'm a cardiologist. My career has spanned much about health services research and has, I think, guided me towards the importance of not just health equity and health justice, but social equity and social justice. I think the two are critically linked. Just sharing a little bit about myself and my own career. I started my career as an interventional cardiologist and treating people who are having heart attacks. And that's where I began to see that it's not about the care that a physician can provide in the cardiac catheterization lab or the operating room. Much of it is about everything that happens or doesn't happen before it and after it. My career as a health service researcher led me to understand large databases because it's not the individual and it's not a small group. It's what happens at the population level or the community level and the care that we say is ideal, evidence-based, guidelines-driven versus the reality of the care they provide every single day. And I was struck at an early stage in my career that what we say is the best care that every American or every person should have after a heart attack, that when you look at these large databases, the actual delivery of that care is approximately 50% of the eligible people who have a heart attack and receive these treatments. From that research, I understood that it wasn't enough just to demonstrate the gaps or the opportunities or identifying people who are doing it well, the best practices or the leaders. The hard part is really about translation and spread. How can we take something that works in one area or one country and translate it and disseminate it across the entire world? That led me into a career of trying to change the world and change medical practice. The two senior positions I held were one, the Chief Value Officer at Mayo Clinic. And at Mayo Clinic, we defined value as quality plus safety plus experience of care in the numerator divided by the cost of care per person over time in the denominator. And trying to enhance high value care across all of our sites, 20 hospitals for the Mayo Clinic, regardless of whether that heart attack patient came in through the front door, the back door, or any side door. I also served as the Enterprise Chief Quality Officer at New York Presbyterian, which is the University Hospital Cornell in Columbia. During the global pandemic and early on, I had the opportunity to lead a multidisciplinary broad team from Mayo Clinic, which provided consultation with Delta Airlines so that Delta could rethink and reimagine all their processes and systems to improve safety. And that's what led me today, after 12 months working with that team and working with Delta, to become the Chief Health Officer and the first Chief Health Officer at Delta Airlines and the first in the US airline industry. So I look to hearing from my co-panelists and look forward to hearing the discussion today. Thank you.
Thank you so much, Dr. Ting, and thank you for giving that life story so we can see that when a doctor or a caregiver begins to look beyond just the patient, the emergency room, we come into the broader society, and then our ambitions to really address these issues of equity become paramount in the fundamental mission of caregiving, really the care of that patient, the care and direct, making a difference in the life of that patient. Thank you. We'll be back to you with our discussion. I want to welcome our second panelist. Dr. Margaret Mary Wilson serves as the Chief Medical Officer for United Healthcare Global. United Healthcare, a local Minnesota-based company, has a global clinical practice, and Dr. Wilson is responsible for that global clinical practice throughout the group. Her career has spanned many different fields of medicine and worked in many parts of the planet, North America, Europe, Africa. United Healthcare is our nation's largest health insurance company. It's also a healthcare provider, ranking 7th on the Fortune 500 of US public companies and 15th on the World Index. It's a very large institution that has devoted itself to care. And when you visit there, visiting their offices, like visiting United Nations, everybody is part of the United Healthcare Group. And I'm so thrilled to be able to welcome Dr. Wilson. Please join us and please give us your opening remarks.
Thank you so much, Mr. Ritchie. It's an absolute pleasure to be here today and to share the panel with my distinguished colleagues. I'm really looking forward to it. First of all, I'd like to start, during times like this, with a word of extreme gratitude to my colleagues out there, all the healthcare professionals and clinicians across the world, and also to people across the world. I think the past year and a half has really been a lesson for all of us in grit and resilience, and it's been with such admiration and humility that I have really watched how we've all come together as a global unit. I must also express my condolences, recognizing that Several have lost family and friends during this trying time, and that is indeed very hard. So thank you, Mr. Ritchie. My name is Margaret Mary Wilson, and I'm the Chief Medical Officer for United Healthcare Global. My career has spanned several different continents. I practiced and taught medicine, so clinical bedside and academic medicine in Africa, in the United Kingdom, and in the United States. And in all those three, across those three continents, I have had the opportunity to experience health inequity and observe healthcare disparities, both through the lens of a provider and also through the lens of a patient. And that indeed started my personal search as an individual, because the observation was that healthcare systems, no matter where they were positioned across the world, all seemed to experience challenges that drove health inequity. And I'm really, really honored to work with an enterprise where health equity, as we say, is the measure of our mission. At United Healthcare Global, we serve specific populations across the world. We have a footprint in about 130 countries. And we serve specific populations in some countries with their in-country healthcare needs. And we do this by providing health benefits, medical care delivery, and health services. We also provide health and well-being solutions to globally mobile populations, expatriates, and international travelers. So across the world, we have, outside the US, we have 70,000 employees in total and about 36,000 clinicians. With a presence in 130 countries, our largest footprint is in South America. We also have a presence in Portugal, the United Kingdom, India, and Australia. And we serve a total of about 6 million beneficiaries outside the United States. So this brings together a collection of countries. It brings together different cultures, different languages, different healthcare systems, different clinical models, different consumer and provider populations, and has really been a great training ground and a great learning ground for us around the challenges of health inequities and health disparities. So I'm really excited. Health equity, as I said, is the measure of our mission. I'm really excited to be part of this conversation today as we collectively think through how we advance health equity across the world. Thank you, Mr. Ritchie.
Thank you so much, Dr. Wilson. And now I'm pleased to invite our third panel member, Dr. Pierre Theodore. Pierre Theodore is one of the world's leading heart transplant specialists. And in that career of developing that skill and that very special way of practicing medicine, Dr. Theodore developed a number of new innovations inside the industry and within his clinical work. And he was eventually asked to come and join the team at Johnson & Johnson, where he leads the global external innovation as vice president. And Dr. Theodore has also been a person who's been developing a much broader global vision about what we can do, how we might use the current attention that is on healthcare and the global nature of threats to really look at some of the other equity issues, like the lack of affordable and available surgeries wherever you are on the planet. And so I've been a real fan of Dr. Theodore's work in bringing public attention and then political attention and global attention to addressing some of these bigger issues that face us in the question of equality and equity in our system. Dr. Theodore, please join us and please greet us with your opening message.
Thank you so very much, Mark. Your remarks are too kind. And I also must say in response that all of us very much remain in all of your personal energy and commitment to the well-being of all, and the central role that Global Minnesota plays and the state of Minnesota itself plays as a leader in the domains of equity and healthcare delivery. For that, we are all very grateful. And I would also like to add my voice to express a sense of condolence for where we stand now globally in facing a pandemic and recognizing how much work there is still to be done in addressing health inequities. There is a theme that I have heard repeated by virtually every speaker thus far, which is the notion that the pandemic, if it has taught us nothing else, is that we do not live in a bubble, and we never did. And the health inequities that we have observed, they create a tremendous drag on productivity, and the costs are simply enormous, as anyone in the healthcare sector can attest. As you mentioned, by background, I am a surgeon first and foremost, but now having joined what I consider the largest diversified healthcare company in the world, with a footprint worldwide and goods and services that face 1.2 or so billion customers per day, I now have and have been given an opportunity and a responsibility to address some of the systemic inequalities that exist in healthcare. Patients that present late with advanced disease or die early, leaving families, takes away from their productivity for a productive life and deprives their families both economically and emotionally, leading to several of the inequities that we face. We've never been isolated, as I mentioned, in terms of our healthcare concerns. And the pandemic has really brought into relief how much we are connected, whether it's on a national level, where there is no such thing, of course, of national or regional isolation, but also in terms of sector, where we recognize that public and private sector each play a significant role in addressing health inequities. In 2020 and going into 2021, in the US alone, we saw an all-cause mortality increase of over 20%, with a lion's share of that burden falling on patients of color. And that creates a responsibility from our perspective to understand some of the fundamental drivers of inequity, both domestically in the US and worldwide. As the largest diversified healthcare company with marquee brands in the spaces of consumer health, medical devices, and pharmaceuticals, while there is great capacity here, this also brings great responsibility. We consider our first responsibility to be to the patients at Johnson & Johnson, but beyond that, it's to the employees that also work there, and also to the communities in which we bring our products and services. What we have seen over the course of the last year and into 2021 that has struck us so much on both the healthcare front and in terms of social justice was a call to action, an action in terms of words, financial commitment, and emotional commitment to bold action, including creating a people-first culture at Johnson & Johnson, whereby we drive additional levels of diversity and inclusion in our own ranks, where we make enduring long-term partnerships with community-based organizations that are driving change that will narrow the gap in outcomes across populations, both domestically in the US and worldwide. We are extraordinarily proud, just recently, to have entered into a commitment with the African Vaccine Acquisition Trust to make available hundreds of millions of doses of COVID-19 vaccine to the world's most vulnerable populations as we continue to address the most pressing healthcare needs in the United States. I am delighted to participate in this conversation where we start to tease apart the role that the private sector can play in addressing these very critical public health concerns. Thank you so much for the invitation. I look forward to the discussion.
Thank you, Dr. Theodore, and maybe I'll come right back to you, having been one of the recipients of Johnson & Johnson vaccination. Although I had to drive many hours to get to it, it was literally a life-changing moment to begin to look ahead. But as you mentioned in your comments, all of these gifts of science and medical technology, all of these add the extra question, what are you doing with that extra life? And Earl Bakken, the founder of Medtronic, inventor of pacemakers, he spent his last 20-some years asking everyone whose life was extended by a pacemaker or perhaps by a heart transplant, what then are you doing with those extra years? What's that responsibility? I know one of your passions is the question of essential surgeries, and that Johnson & Johnson has helped some cities get some mobile surgery units and mobile units for vaccination and others. Can you share a little bit about that as a putting words into action kind of deed? You're on mute.
Thank you so very much. It wouldn't be 2021 if you didn't have someone start talking while still on mute. So thank you for bringing that up, Mark. With respect to mobile units, think of that as a technique to overcome some of the barriers that often exist with patients, which is to say that there is often a lack of trust or, frankly, trustworthiness of healthcare systems. So to the degree that we can break down some of that barrier of this traditional brick and mortar healthcare system and bring healthcare to those in need, we consider that to be an important logistical strategy to overcome inequity. So in 2020, we were able to partner with a series of community-based organizations in rural settings, in urban settings, on indigenous lands, to stand up mobile health systems that allowed us to reach patients for COVID-19 testing, distribution of PPE, and connecting into social services as a specific strategy to address health inequity. But the theme is not to make healthcare mobile necessarily, but really mobilizing access to the healthcare, making sure that the doors are open for all to access healthcare.
Dr. Wilson, you mentioned some things around getting that access to telemedicine and new things. It seems like United Health, in its global nature of delivering healthcare services in different parts of the planet, but you've really created a platform or an opportunity, a laboratory, if you will, to really see where can this pandemic lead us to that build back better model. Could you speak to that in terms of what you're seeing and what you're excited about, what you're inspired by?
Certainly. Thank you, Mr. Ritchie. You know, I think that we've seen this coming for quite a while, but the pandemic accelerated a lot of thinking around the criticality of telemedicine and virtual health. You know, where we are as we think about healthcare transformation, medicine is not simply a question of disease prevention, and certainly not simply a question of wellness preservation. I think, you know, the way we view it at United, our thinking has evolved beyond that. Health is a construct that must be seamlessly integrated into the life of a person, right? So as we think about the rising costs of healthcare, as we think about the fact that even though the cost of healthcare is rising, clinical outcomes still remain suboptimal. The consumer, the nature of the person is changing. The provider is changing. And we really need to think through both the consumer and the provider experience, right? It is becoming critical that we recognize that we cannot brick and mortar our way through healthcare. We cannot possibly build enough facilities to service, pay people, and to preserve health with a brick and mortar structure. We have the technology to create a virtual healthcare ecosystem that is uniquely customized for each person. And COVID, the pandemic, actually taught us that we can no longer, anywhere in the world, rely on a healthcare system model that is constrained by geographical boundaries, because diseases don't operate that way. Diseases are not a respecter of boundaries. So it is become really critical. And I think what excites me about this is the urgency with which all stakeholders are leaning into telemedicine. And also the other exciting piece is the adoption rate. I think the pandemic really accelerated the adoption rate by both providers and consumers. And here's the benefit of this as we think about the healthcare system that we are all collectively creating, leveraging telemedicine. We have increased connectedness by all providers involved in the patient's care, all coming together in a real-time, very dynamic way. We also have the consumer and the consumer's caregiver able to access that. Healthcare is coming into their lives as part of their lives, sitting at the center of health preservation. And I think this is important as we think through health equity, because one of the greatest challenges around health equity is access. How do people in vulnerable populations or in remote populations access high quality healthcare. Geography has always been a constraint to that. And we're seeing that telemedicine is able to get us beyond those barriers. The other piece that we're witnessing is around simplification, leveraging technology to eliminate several of the barriers that made accessing healthcare difficult for our patients. You know, one of the things that we found really exciting during the pandemic, in several of the countries in which we operated in South America, government regulations precluded telemedicine between physician and patient. But very, very quickly, we recognized that if we were all collectively going to address the pandemic challenge, we would need to quickly reevaluate that. And you saw those regulatory barriers come down very quickly in those countries. And at the same time, you saw providers and patients lean into really rapid adoption. We were able to put together robust telemedicine models in countries where this had been prohibited prior to the pandemic over a course of about a month. And we did this in all our countries, and we saw really, really high adoption rates. It was critical to helping us manage the surge. Hospitals were being overwhelmed, outpatient offices were being overwhelmed, and we were able to create a low complexity telemedicine healthcare ecosystem to cope with patients who needed that. And I think what I find most exciting is that even as the pandemic appears to have stabilized, our concern was that adoption rates would fall precipitously. We're actually seeing that they're holding stable, which says to us that both the patients, the people, and the providers recognize that this is truly the new direction in our transformational arc of healthcare. So I'm really excited.
Very exciting. And this afternoon, we'll be hearing from the folks who are working to bring the 5G, very high speed broadband, to marry in with the great success in Rwanda, where they have really been very successful in dealing with COVID, but many, many other issues. And so knowing that this is your experience, it's exciting to think that this will also advance other infrastructure, other types of accessibility for things like education and other parts of it. I know that both Dr. Theodore and Dr. Wilson, you're really focusing on how this has accelerated, and people are leaning into changes that will be very important as we go forward. I know that in the case of Delta Airlines, and I am a little bit conflicted here because I'm both a native of Georgia, but I live now in Minneapolis, and Northwest Airline and Delta are, of course, a merged airline, but we are very proud that our fellow Americans and others speak in this way. They say, you know, there's only one airline that feels safe to fly on. I had to fly, and so I was so grateful that Delta was there with the kind of care, the explicit care and the exchange of information that made people feel like this was truly different. Dr. Ting, you and your team at Mayo and then the team at Delta have created what looks like a very successful business model alongside of or integral to this health protection model. Can you give us some insights into that? Am I reading the situation right, or am I just being a kind of a Georgia and Minnesota spokesperson and not really seeing the full situation?
Thank you for your kind words, Mr. Ritchie. At Delta Airlines, safety has always been our number one priority. And we did that extremely well in terms of the safety at the airport, the safety during your flights. What we experienced during the COVID global pandemic was an external threat and a situation that many of us have never faced before, unless any of us were around for the 1918, 1919 influenza pandemic. And as pointed out by my co-panelists, what we experienced was this humility and collaborativeness, and at Delta Airlines we call it teamwork on the fly, where experts from Mayo Clinic, Emory, Delta Airlines, CVS, Lysol, State Departments of Health, CDC, came together and really tried to, one, protect our people and our customers when they had to fly during the pandemic for essential travel. And the pandemic really emphasized that it was the safety of our people and our customers that we had to preserve, and that really became the focus. So some tangible, real examples beyond what you experienced, Mr. Ritchie, on the flight, where behind the scenes, all of our policies and procedures were carefully reviewed and redesigned so that the safety of people and customers were prioritized. We developed testing for all of our people because we knew that over 50% of cases were asymptomatic, and identifying early and isolating our people and our employees with early testing before they can expose others was a core component. And we worked with Mayo Clinic and Quest and other groups to really implement this testing for all of our employees on a weekly or twice weekly basis, completely predicated based on the case rates in each area of the world where we operated. Further, I think we have the first of its kind public-private partnership with the Georgia Emergency Management and Homeland Security Agency, also known as GEMA, to deploy vaccinations in the state of Georgia. Delta Airlines has 80,000 global employees across the world, but our world headquarters are in Georgia, Atlanta, Georgia. And we partnered with the GEMA and Department of Health and the governor of the state of Georgia and deployed a mass vaccination site at the Delta Airline headquarters through our parking lot with drive-through vaccination using our expertise in logistics and operations and access to vaccines from the state. And we deployed this vaccination and brought it to our people in Georgia. So all the vulnerable people across the state of Georgia. The vaccines were available in Concourse C for all airport employees. The vaccines were available at our Delta Air Flight Museum and also in our parking lot. And over the last month, we've vaccinated over 60,000 people, and our vaccination rate is on pace at 5,000 doses per day. It's the largest vaccination site in the state of Georgia, particularly targeting the most vulnerable to COVID. The second thing I would say is at Delta Airlines, our mission is we say that no one better connects the world. Pre-pandemic, we carried 200 million passengers across 50 countries and 300 destinations. And by doing that and connecting the world, we believe that we have a responsibility, as been mentioned, to change the world together for the better. And the decisions we'll make are guided by our core values. And those core values include social justice, social responsibility, diversity, equity, and inclusion. I do want to add my voice to what my co-panelists have mentioned in terms of the gratitude and what we've learned. And I would add that perhaps the most notable consequence of COVID-19 has been the unequal toll on the poor, the vulnerable, and the minorities. Whether you want to measure that in terms of case rates, mortality rates, access to personal protective equipment, diagnostic testing, or vaccines, this is what we've witnessed, and this is the opportunity and challenge in front of all of us. I would pledge that our next normal will not be defined by our old normal or by fate. It will be defined by the choices that we can make today. And at Delta Airlines, those choices will be guided by our core values of social responsibility, social justice, and equity.
Thank you, Dr. Ting. And of course, as somebody who, has been off flying for quite a while, but I know that there are those special moments, and I have potentially a 100th anniversary family reunion in Georgia that's been postponed a few times, and so that may be in my near future. But in any case, it has been remarkable to see this commitment to social justice and to equity, but also to see the application of that with that commitment to safety then played out in the community, among customers, in the employees, and to see that that has been a very successful strategy. And so it's inspiring to hear that story. I know that in the case of Johnson & Johnson, which is really a global corporation, there are opportunities to both see and appreciate new approaches, bring those ideas back and share them with others, and to see advancement go faster and faster when you have such a global footprint. Is there a kind of way that Johnson & Johnson, through your particular, when you're responsible for that sort of global external innovation, that you bring in these ideas from around the planet and then they help improve everybody's lives?
Yeah, thanks, Mark, for that important question. And before answering directly, I want to echo something that the Dr. Ting mentioned, which is that the pressure of the pandemic has forced private sector entities to truly reflect on the values and the mission statements that guide us. And for us, for example, in our credo and clearly our similar values that are being held by both institutions, or all three institutions represented today, we have this opportunity to truly pressure test our capacity to live into our value system. I think it's one of the more important lessons gained from this pandemic. Who are we as institutions? There is a theme that we like to use at J&J, and I do not think this is a cliche, and it goes that good ideas can come from everywhere. Our chief scientific officer several years ago revamped our innovation system to put what we call innovation centers around the world in major hubs of innovation, so that we could have essentially an open door on new ideas. And as the organization of J&J continues to expand its footprint into sub-Saharan Africa, Southeast Asia, South America, and beyond, so too do we continue to expand these innovation centers and versions thereof to allow additional areas of innovation to come into the organization. For organizations like all of ours, that are deeply matrixed and sometimes complicated to access, it becomes a major area of focus to make it easy for good ideas to penetrate, if you will, the organization. That is someplace that we have worked very hard over the course of the last several years to create an environment and an ecosystem where those who are building new companies, who are developing new ideas, whether it's in a university setting, in a startup, or in a publicly traded organization, have a place where there's a conversation that can be held and innovations can enter in to a large matrixed organization. Very critical to our mindset.
Great. I know that later today we'll be hearing from some of those grassroots networks like Global Black Youth, which has been really lifting up the entrepreneurs everywhere in response to COVID. So it's important that there is a kind of a global openness and an appreciation and a company commitment to bring those ideas from everywhere and to bring them together so that all can benefit. Dr. Wilson, your focus in a global setting, Brazil is a huge part of the global aspects, and Brazil, like the United States, has had a very high level of infection and death and difficulty in getting our arms around it. Are there lessons from the United Health Global that have helped to figure out the best strategies and to help us all move forward together?
Yes, Mr. Ritchie, thank you. It's really, I think you said at the beginning of this session that this has been a year of great learnings, and it actually has. And as we think about our large footprint in Brazil and across South America, for us, it's become a question of, how do we share best practices? How do we facilitate knowledge transfer in a way that we mitigate health inequities? My background as a physician is internal medicine, geriatrics, and cardiology. And prior to joining United Healthcare, I had been one of those frontline physicians standing at the bedside and experienced knowledge transfer depending on which country I was in. It was either a trickle or it was a gush. right? And then at the front line, we had to spend time trying to figure out what applies and what doesn't apply. If you don't really have the time for that, that knowledge is lost. Those best practices are lost. I think one of the things that the pandemic has taught us, it's accelerated our ability and insights into how do we transfer best practices. And I think the key there is what we have learned is that we approach it with intentionality, because it's really about recognizing that as broadly diversified as we are, within United Health Group, we have really a large body of thought leadership. We have extensive capabilities. And so the learnings here is how we pull that through and harness all that and localize it in the different countries, recognizing also that the learning goes both ways, right? So it's really about engaging the local clinicians. It's really about ensuring that they receive this knowledge and are able to rapidly, practically apply that, and in the form of practical innovation. And Brazil, you mentioned, is a really great example of that, because I think one of our biggest learnings from Brazil, what they are very skilled at, the healthcare community and the clinical models that are developed there, they're really skilled at very practical, urgent, and rapid innovation. And we see this across South America. A couple of examples of, the work that we've done in this regard, and a lot of it was related to the pandemic. When the pandemic struck, the question was, how do we rapidly bring together knowledge in a way that it can be immediately utilized by the front line, recognizing that no one organization is the owner of knowledge. So we actually put in place COVID clinical roundtables, where we pulled in experts from across the world who were standing at the front lines. So we pulled in the Chinese group who had helped to manage the epicenter in China. We also reached out to the Italian group in Moderna. We reached out to the South Korean group who were doing a lot of work around vaccine development. And we also reached out to the New York group in Columbia Presbyterian who were managing the surge. Brought all this thinking together, and collectively we were able to leverage that and immediately apply it locally. We also had the same challenge working with external stakeholders. We were able to partner around modifying ventilators. So we worked with the Boston Scientific Group, University of Minnesota, and were able to work together to develop these basic ventilators that could be used in countries that were resource constrained. So I think the other thing we're learning is the power of thought leadership. Really reaching out to the local leaders, those physicians at the front line, to teach us, and providing a forum whereby we showcase their thought leadership. At United, we have recently, over the past year, developed a global clinical journal. And the purpose of that is actually to showcase thought leadership and practical innovation from our colleagues across the world within United Health Group. And this has actually really helped rapid knowledge transfer. So I think that when we bring all this together, the question is, what are we seeing in terms of the impact? And I think the impact that we're beginning to see is that we are actually able to build clinical care models that truly serve the local communities. We're able to pull all this together and support the local communities in developing meaningful clinical solutions that truly change lives. We help drive practical innovation at the local level. And I think most importantly, we stimulate cross-learning from parallel communities that had previously existed in silos.
What I've heard from all of you are some themes about the collaboration part of this, about thought leadership, about pulling threads together, and about the practical and being able to respond rapidly. I'm wondering if in the last couple of minutes, Dr. Theodore, Dr. Ting, anything to add before we have to give up today, but I want to keep this conversation going. So last words.
Well, I'll just say very briefly that indeed collaboration is critical, but as has been mentioned, to not miss the opportunity to take in the lessons and to make sure that our organizations and our healthcare systems do not in some way clamor to what we had before. We have this opportunity presently in front of us to evolve into new, more vibrant, more inclusive healthcare systems. And it's my hope that each one of us listening today thinks not how do we get back to where we were before, but how we can continue to advance the care that we're trying to deliver to all. So thanks for the time today, Mark.
Thank you. Dr. Ting? You're still on mute.
My fault. I'd like to, and maybe with a word of optimism, we've all been through now 13 months of an experience that none of us wants to repeat. And there's some great learnings. And speaking to everyone that's watching and each of you, I know we've all experienced the losses, whether that is a loss of someone who had a consequence or a complication from COVID, or whether that loss was not being able to celebrate a birthday or holiday with a family member or relative. We have the tool within our reach to end this pandemic through the collaboration of scientists and the private sector right now. I would encourage everyone to do what you can to take a friend, to take a neighbor, to get this vaccine, because as a world, as a country, and at Delta Airlines, all of us are ready to reclaim our joy and to reclaim our lives again. And we have that possibility. So thank you very much for this opportunity. I look forward to staying engaged with all of you.
Thank you so much, Dr. Tiemann. I just love that notion of reclaiming our joy through this opportunity that's come to us as a gift from the science and from all who've made this now a possible brighter future if, and that's, you're correct in putting this on all of us, we do everything we can to get everybody to claim their possible joy. Thank you so much to all our panelists. Look forward to our next conversation. And to our viewers, stay tuned. Dr. Michael Osterholm, some of you are devotees of his weekly podcasts and information, but we're going to have a fireside chat about where we're going now and look a little bit at some of those controversies and debates underway. So we'll be back to you in just 2 minutes. Thank you so much again to our panelists, and thanks to all who are watching and being part of World Health Day 2021. to all of our viewers from all over the planet, dozens of countries and states from Alaska to Florida. This morning, we've been looking at the global, the strategic side of addressing today's theme, health equities. And in that larger picture, we're aware that we're in this race between getting ourselves vaccinated and building out a herd immunity with the growth of new variants who can overcome us if we're not able to move quickly enough in that broader area. One person who's been the voice of reason, voice of science, voice of looking ahead, not sugarcoating, but being very optimistic about where we are moving, is Dr. Michael Osterholm from the University of Minnesota, from CINRAP as we call it. Dr. Osterholm has been in the running for Sexiest Man Alive among some people with George Clooney, because his voice and his way of bringing us into the global conversation is so compelling. I want to ask Dr. Osterholm to join me here on Zoom, and we're a day early. You're always coming out on Thursdays, but if it wouldn't be upsetting anybody, would you give us a little brief peek into your message coming tomorrow, because we're in a kind of very active period in the changing nature of this COVID pandemic?
Well, first of all, thank you very much, Mark, for having me, and congratulations on just an incredible program and all the work that you do. It's a real honor for me to be here with you today.
Thank you.
You know, we're in the tale of two cities. It's the best of times and it's the worst of times. The best of times based on what you were just talking about with vaccine. I think that the current rollout of the vaccine is going as well as it could go in terms of getting us the number of doses out into the community. We can surely talk more about how maybe to use those more effectively. But at the same time, as you're seeing what's happening in Michigan and Minnesota, places like this, that despite the vaccine rollout as it is, we're still seeing a very rapid increase in the number of cases, a B117 surge, as we call it. B117 is the variant that originated last fall in the United Kingdom, which we now know is about 50 to 100% more transmissible than the previous viruses we dealt with. It produces 50 to 60% more severe illness, and it has basically taken over here in North America as the predominant virus that we see. Based on the experience in Europe and other locations around the world, particularly Europe though, we've seen just how difficult it can be to control this particular strain of the virus. And as many of you know, large parts of Europe have been in lockdown of one form or another since Christmas time, trying to deal with this virus, as well as in implementing their vaccine programs, and it's been a real challenge. And so we anticipate that over the course of the next 5 to 7 weeks, we're going to see a number of other states showing this big increase, because in fact still 45 to 50% of the US population is not yet protected against the COVID-19 because of the fact they've not yet been vaccinated and they have not yet had natural disease and developed immunity. What we're seeing is a changing epidemiology a bit. We're seeing less individuals who are critically ill in the older age population. We've had more vaccine, but today is a good example. In Minnesota, we had 14 more deaths, where many of those were older individuals. And we also are seeing a situation now, though, where 20 to 49-year-olds are the majority of the cases ending up in intensive care, severely ill, more than we've seen in the past. And we're seeing a lot more kids, younger kids, particularly under 8th grade, who are now involved in a substantial amount of transmission in our communities is actually occurring as a result of kids transmitting to adults. And that's something that we just didn't see nearly as much of prior to the arrival of B117.
I know in some of the conversations about equity in particular, there's a concern that low-income families could be more affected, negatively affected, with our children going back to school with the passing of this infection, as you just described, kid to parents. Is there a way that we could be rapidly altering the procedure or the availability or something to get us faster to something that looks like or could be close to herd immunity?
Yeah. Well, at this point, let me just say that your assessment's right on the mark in terms of we are challenged right now to get vaccine to our younger adults in this country, meaning 20 to 49-year-olds. And given that we're seeing such a high increase in cases in this area, this is a real concern. I'm part of a group that put out a plan almost 7 weeks ago now that would have that urged the U.S. government to consider a single dose of the vaccine now with the deferred dose for anywhere from 8 to 10 weeks later. This approach was used quite successfully in England. It's now being used in Canada. Why do I say this? Because we actually have data supporting right now that if I get 2 doses of the Moderna or Pfizer vaccines, I surely can get 90% plus protection. But even with 1 dose of either of those vaccines, within 3 weeks, I get more than 80% protection against disease. And let's just do the simple math here. 1 person gets 2 doses, 90%. 1 person gets 0, none. That's about a 45% protection, 90 divided by 2. If I give 2 people 1 dose at 80%, that's 80% protection. And right now, as this virus is moving through our communities, we need that. And so some of us are still continuing to shout loudly that we need to go to a program approach where we give 1 dose to as many people as possible. And when you hear each day about the number of vaccines being rolled out, that's a great, great piece of news, but it needs a caveat. So when I say 3 million doses were put out there today, people assume that's 3 million new people. It's not. Half of those are people getting their second dose. It's really 1.5 million people who are new vaccinees. And in a country that still has over 13 million individuals 65 years of age and older who've had no vaccine at all, where we know there's a much increased risk for serious life-threatening disease, hospitalizations, and death in that group, we want to get that out there. So we're still hoping we can do that. Time's running short, though. Right now, we're in a major challenge situation of getting vaccine out before this surge really takes over. And we're watching it day by day by day really increase around the country.
I noticed reports of new variants from Philippines, from India. Where are we in this race with getting us vaccinated or the variants spinning out of control and putting us back to day one?
Well, the variants surely are game changers. There's no question about that. And they really came onto the scene in November. Prior to that time, we knew that the viruses were mutating, which causes these variants to develop or strains of the virus, but didn't appreciate that they would have any real impact on any aspect of the virus-human illness picture. Well, we learned that there were certain mutations that did do that. The B117 variant that I mentioned from the United Kingdom, as I already said, causes much more severe disease and is much, much more transmissible. There are other variants that actually have a third category of concern, and that is the fact that they can evade the immune protection from either the vaccines or from natural infection and having recovered. And that's a variant area that we're very concerned about. P1 is one of the variants that we've seen there. There's another variant, B135, that we've seen from Southern Africa. And all of those variants are ones where we do have some interference with the vaccine protection. How much is still unclear, what its clinical implications are unclear, but it's also a variant that is also spreading around the world. Right now, British Columbia is experiencing a major outbreak here around the community of Whistler, where we've also seen the Vancouver Canucks hockey team has been now out of playing for the past 2 weeks because of an outbreak of P1 in that group. So surely we're going to be following this very, very carefully. But I think if there's one message I could bring back, it's exactly why you're here today and why I'm here today. This is a pandemic. It's about the world. And what's really important to understand is that right now, about 80% of all the vaccine has been used in just 10 countries in the world, all high-income countries. 30 countries in the world have not even seen a drop of vaccine and probably won't for some time. COVAX, which is the organization put together by the WHO and other groups, including philanthropic organizations, has as their goal, which is laudable, and from a humanitarian standpoint, to get up to 20% of low and middle income country people vaccinated in the next year. That's just not enough. It turns out that ongoing transmission in low and middle income countries, while surely a humanitarian issue, it is a strategic, critical safety issue for the world. Why do I say that? Because this is where the variants are now spinning out of. And if we have uncontrolled transmission in the rest of the world, our vaccines are not safe. We don't know what other variants could occur that would threaten the effectiveness of these vaccines. So the one message I want to come back to today, as long as this virus is circulating in the world, everybody in the world's at risk. And I think this is a really important message on a day like today with World Health, that we realize we need a Manhattan Project together with a Marshall Plan. How are we going to vaccinate the world? We don't have the manufacturing capacity right now. What's it going to take to get it? This is about being penny wise and pound foolish. If we end up losing our vaccines to additional challenges through these mutations and variants, where are we? What are we going to do? So I can't thank you enough for the chance to be here to say that, because this is such an important audience. They understand the critical aspects of world health.
Well, I noticed this week at the meetings of the World Bank and IMF, there was a discussion of a pretty major new facility that could be part of this. Our Treasury Secretary Yellen was bringing out the idea of more of a global approach to some of the infrastructure and some of the taxation. I do see these conversations, even about a treaty, rising up to higher levels of governments, that the message is beginning to get to them. But I was tracking this last week, and I think you might have been too, that gigantic 1,300-foot ship that blocked the Suez Canal because of a big windstorm. That was quite world news, but it didn't quite reach the same level of world news that a 1,000-foot ship got stopped in Milwaukee because its crew got COVID. So if, we're talking about little tiny microscopic virus stopping 1,000-foot ore ships, we are reaching a stage of having enough examples that perhaps it can create the political momentum. Do you see any pressure points or direct, we're not a state without political savvy and political representation. What advice? Did somebody pick up the phone and call?
Well, and as you framed this so very, very well, this is not a partisan issue. I've served roles now in the last 6 presidential administrations. With the Trump administration, I served as a science envoy for the State Department on pandemic preparedness around the world. I was on the Biden-Harris Advisory Board transition team for COVID. My job is just to help government, help leaders do what they need to do. And this is one of those examples where this pandemic has really opened up, I think, the eyes of a number of people as to our global vulnerabilities, and particularly around things like manufacturing, trade, shipping. Our group at CIDRAP at the University of Minnesota has been very involved looking at critical drug supplies. And we have found that of 153 drugs that are critical drugs that we need every day or people die, what's on the crash cart, what's in the emergency room, what's on the emergency rig. And of those 153 drugs that fit those categories, 100% are made outside the United States, and they're all basically generic with very, very thin, narrow, and very breakable supply chain lines. And so when something happens around the world, whether it's an infectious disease, whatever, that can disrupt that, that's amazing. Our further studies have shown over 80% of the brand name drugs, the ones that are still on patent, are made outside the United States. And in many cases in countries where right now we're concerned about the COVID-19 activity. So I think a number of people are becoming aware of the global nature of health, the global nature of trade, the global nature of how the two intersect with each other, and why it's so critical that we really address these together as partners in both problem and in solution. And so I couldn't support your comments any more strongly than to say, this is exactly why we need to have these kind of meetings. This is exactly why we need to put this issue forward. It's all about helping all of us. And when you help the world today, you find out, oh my, that does help me too.
I feel like it's very, very fortunate that CIDRAP sits within the broader University of Minnesota with all the different components, you know, the human rights part and the law school and the engineering. And do you find that these silos that sometimes exist, that COVID has helped bring you, CIDRAP, to the whole university and the whole university in when it's useful to you and your colleagues?
Well, let me slice this into two sections. One is that, you know, for the past 46 years, you know, I've had the good fortune to be involved with a number of rapidly emerging public health issues. I was very involved in the very earliest days of HIV/AIDS, where it was Minnesota that was the very first government entity in the world to make HIV a reportable condition. And there were many gay men at the time who were highly concerned about the issues of confidentiality and what might that do to, you know, would they be disclosed somehow, et cetera, all really legitimate concerns. And of course, it didn't happen. And because of our work, we were able to actually really jump on HIV in a much more effective way. So I've seen a lot of the tough times. I've never seen anything like this before. In the last year, the number of death threats I've received, the kind of email I get every day, you know, people who look at this as still a hoax, and it's being perpetrated by individuals for their own personal purposes. Just in the last 24 hours, if you were to see my incoming email, it'd be hard. And so I think that that has by itself added a whole new dimension to how do we deal with global problems. You know, I find it interesting, you know, so many of us were so concerned about calling it the Chinese virus and how that basically impugned China as such. But today we don't have any problem talking about the UK virus or the South African virus or, you know, wherever. And I think it's really called into question, you know, how do we address these kinds of issues without creating prejudice, but at the same time just being scientifically factual and what we need to know and how to deal with it. So in that regard, it's been an eye-opening experience for all of us in public health to see that kind of rancor and division that politically I'd never seen before with a public health issue. In terms of the University of Minnesota, you know, I've been at the U now for 46 years. Even the time I was at the Minnesota Department of Health, I was still in faculty at the university. I can't imagine being in a better place in the world right now for the work we do and the support that we've received and the collaborative efforts across the university. And so while things have surely stepped up some, I'm actually happy to report that the Consortium on Health Law and Values, which has been in place under the leadership of Professor Susan Wolf for many years, has been one of the most unique entities in all of higher education in terms of bringing together all the different parties that you just mentioned and more. And we've had a whole series of webinars, major webinars for the world, thousands and thousands of people attending them on these critical political and science interface issues. And so, you know, stay tuned if you want more. The University of Minnesota right now is one of the global leaders in providing this very kind of information. The most recent one we had was all on racial health inequality, and it was stunning. It was a stunning example of what the University of Minnesota can do. And so I'm very proud to be a Minnesotan. I'm very proud to be part of the University of Minnesota.
We had the good fortune of having Dr. Tolar this morning, and you know, just seeing the capacity to touch and reach, but to bring all the pieces of the world together in one place. We're just so fortunate to be here. Now, I can resonate a bit about the hate mail and the difficulty of that in my office, but I also know that you occasionally get love letters and really sweet letters. And you read on air a beautiful letter about our children and education, and I asked if you could share that with us in the final minutes here. Thank you so much.
Well, I will do that at your request. This is a communication that I've had ongoing with a school superintendent from northern part of New York, who is, in my mind, the teacher of teachers. She's a gift. And she's been described by many of her colleagues in very fascinating ways. As I pointed out before, She's emerged as an articulate voice of reason in the education level. She's been described as one of the boldest education leaders in the country. And the dean of a major school of education at college once said, and her name is Dr. Schneider here, ask Dr. Schneider any question about education and prepare to enjoy a profoundly reflective, creative, passionate, learner-centered, and well-informed conversation. Well, so I reached out to her on the education piece. I have been very pro kids going back to school from K through 8 because of what it was a relatively low incidence of disease, transmission, et cetera. Now that's surely changed with the B117 situation because now we see this transmission. So I read on air and included in our podcast a letter that Superintendent Teresa Thayer Schneider had shared with the world. And I think it reflects, Mark, what you're all about here today. So let me share that letter with you. Dear friends and colleagues, I'm writing today about the children of this pandemic. After a lifetime of working among the young, I feel compelled to address the concerns that are being expressed by so many of my peers about the deficits the children will demonstrate when they finally return to school. My goodness, what a disconcerting thing to be concerned about in the face of a pandemic which is affecting millions of people around the world. It speaks to one of my biggest fears for children when they return. In our determination to catch them up, I fear that we will lose who they are and what they have learned during this unprecedented era. What on earth are we trying to catch them up on? The models no longer apply. The benchmarks are no longer valid. The trend analyses have been interrupted. We must not forget that those arbitrary measures were established by people, not ordained by God. We can make those invalid measures as obsolete as a crank-up phone. They simply do not apply. When the children return to school, they will have returned with a new history that we will need to help them identify and make sense of. When children return to school, we will need to listen to them. Let their stories be told. They have endured a year that has no parallel in modern times. There is no assessment that applies to who they are or what they have learned. Remember, their brains did not go into hibernation during this year. Their brains may not have been focused on traditional school material, but they did not stop either. Their brains may have been focused on where the next meal is coming from, or how to care for a younger sibling, or how to deal with the missing grandma, or how it feels to have to surrender a beloved pet, or how to deal with death. Our job is to welcome them back and help them write that history. I sincerely plead with my colleagues to surrender the artificial constructs that measure achievement and greet the children where they are, not where we think they should be. Greet them with art supplies and writing materials, and music and dance, and so many other avenues to help them express what has happened to them in their lives during this horrific year. Greet them with stories and books that will help them make sense of an upside-down world. They missed you. They did not miss the test prep. They did not miss the worksheets. They did not miss the reading groups. They did not miss the homework. They missed you. Resist the pressure from whatever powers that to be who are in a hurry to fix kids and make up for lost time. The time was not lost. It was invested in surviving an historic period of time in their lives, in our lives. The children do not need to be fixed. They are not broken. They need to be heard. They need to be given as many tools as we can provide them to nurture resilience and to help them adjust to a post-pandemic world. Being a teacher is an essential connection between what is and what can be. Please let what can be demonstrate that our children have so much to share about the world they live in, and in helping them make sense of what, for all of us, has been unimaginable. Please, this will help them and us achieve a lot more than can be measured by any assessment tool ever devised. Peace to all who work with the children. Teresa Thayer Schneider. Thank you for letting me read that.
Dr. Osterholm, thank you for being our bridge to the future. Thank you for every Thursday being on that podcast, and for all our viewers, go to SIDRAP, go to that podcast. But also thank you for being as clear and as focused and remembering on what it will take us to get to the other side and what it will take so we don't forget when we get there, like it was described in the letter. We will have been changed. We won't go back, but building forward better won't just mean better arrangements. It'll also mean a better understanding of who we are, this human family that for the first time in history, probably all experienced something that interconnected us. Thank you again for being with us today, and I look forward to
Thank you.
tomorrow's podcast. Goodbye now.
I'm honored. Thank you.
Welcome back, everyone. We're about to begin our afternoon program here in Minnesota, but to those who've just joined us and those who've been with us all morning, we're so glad you're here with us on this special day. I wanted to remind everyone who wanted to make use of the American Sign Language and closed captioning, there is accessible programming. The information is on the box, the description box on the YouTube channel that you're watching. I want to thank St. Cloud State University for providing this service, but also for inspiring us and being our treasured partner on deepening and expanding our accessibility here at Global Minnesota. So thank you so much to St. Cloud State for that. The next part of our program, we're going to be looking very deeply at how one of our main healthcare providing and medical device companies, Medtronic, is partnering and partners with the community to find those special ways to address critical issues that relate to our theme today, health equity and equality. To kick off this afternoon, we're going to first hear from the president of the Medtronic Foundation and vice president for philanthropy, Purvi Bhatt, in the foundation role. I first met Purvi when the company Medtronic became clearly one of the true leaders in our nation and around the world on the Sustainable Development Goals. And beyond just sort of how that affects them and how they make their decisions, they were the strong voice saying that Sustainable Development Goals need to be generalized and socialized throughout our companies. They created an organization with others called Impact 2030 to provide a vehicle for involving the employees, the team members from companies everywhere in achieving those important goals. And so I'm really pleased to have Purvi leading our session coming up right now. Also joining us is the Chief Executive Officer and Chairman of the Board of Medtronic, Jeff Martha, who is the leader of one of the world's largest and the world's innovative leader in medical technology. Some of you earlier heard me mention Earl Bakken, who was the founder, co-founder and creator of one of the earliest products. And my life has been changed when I heard his message about not just the importance of innovation in medical device and medical care, but asking the ethical questions about what do we do with the extra years of life that we've been gifted through modern medical technology, but also through things like heart transplants, pacemakers, heart valves. These are things that we're very proud of in Minnesota, that we've been able to be the home for innovation for so many of these things, heart valves, et cetera. But we're also proud that we're part of the thinking, the intellectual, the ethical, the thought leadership about what are the issues that come out of these kinds of opportunities being presented. And of course, this COVID-19 pandemic is an opportunity for changing and thinking, but it's also a great challenge to us all. So I'm so thrilled to have this opportunity to hear from Medtronic about special partnerships that they're making. And Purvi, please take the mic and welcome to all of your team. We're so excited to hear this new partnership that Medtronic will be talking about over our noon hour.
Well, thank you, Mark. And it's just terrific to be here today. It's World Health Day, and that is a cherished day for so many of us. But this particular topic really comes home for us because, of course, equity is so central to all of our thinking. It always has been, but I think none of us can look away from what's happened over the last 18 months, and just so proud of what we've been able to achieve together, and just in the humility of exploring how do we think about equity in these times. And just love that you harken back to Earl Bakken and even the really important call to action of what do we do with our extra life. I think the partnership that we're coming into, and you're going to hear a lot about today, really brings that to life. So just excited for this time in front of us, and couldn't be even more excited to be here with Jeff. We've had some time to do this in a few rounds, and to do this at home in Minnesota, and to really talk about the importance of global issues for us right here in Minnesota, and the important role that companies and nonprofits and just the Minnesota perspective offers when we bring what we have to solve some of the largest global problems that the world is facing. And the whole day has been focused on that. So Jeff, it's great to have you here, and would love to kick off and just, talk about personally, what does, health equity mean to you, and why have we really come into this so deeply as Medtronic?
Sure. Well, thanks, Porvi, and thanks, Mark. Thanks for the introduction, and really excited to be here today on Global Health Day and talking about a topic that you'll see that is something that near and dear to our heart as a company and me personally, and very passionate about. So I'll just kick it off then. So your question was about health equity. What does it mean? Or
yeah, and to you personally, and then certainly as it's woven into our mission.
Well, sure. I mean, like you mentioned, I would start there with Medtronic's mission, which, for those that aren't familiar with it, was written. Mark mentioned Earl Bakken, our founder. He and a few others on his team wrote the mission 60 years ago, and it hasn't changed. And there's multiple tenets of it, but it does talk to. There's actually 6 tenets, but a number of those tenets get to things like improving patient outcomes, but not just. But for all patients and around the world. And so this whole idea of healthcare outcomes for everybody, whether you live in the United States or in other parts of the world, is something that Medtronic's been focused on for a long time. And so, so for us, this is something that is very important. And the opportunity, we feel we're in a good spot to help out with health equity here. And it's, in an age of innovation, the technology innovation that's taking place right now inside of healthcare and outside of healthcare, but we bring that technology into healthcare, is really making it possible for us to address what we call the universal healthcare needs simultaneously, improving outcomes, but at the same time of lowering cost and improving access. And all the improvements in technology that have really accelerated put us in a position to do that. And technology is having a meaningful difference, including driving healthcare to underserved areas. With heretofore it's been difficult to have meaningful healthcare outcomes in those areas. And so that's a big driver of it. And so we're a technology company in healthcare. We think we can use that technology to help, but there's broader. We do have to work with governments around the world to help this. We have to work with different partners, like we're going to talk about some of those today, because we're not a healthcare delivery company per se. We're more of a technology company. We've got to work on, beyond technology, new systems of care, moving from we're in a volume-based healthcare environment in the United States to more of a value-based one. But ultimately keep the eye on the prize here, which is those outcomes. And driving that access. So everything we do is not just technology for technology's sake, but driving outcomes and for all people. And so we've had to make, and Porvi, you've been a big part of this, we've had to make a very specific focus on some of these underserved areas around the world, because actually providing meaningful healthcare outcomes in these underserved communities where the resources just aren't there is something that is very challenging. And we determined a few years ago that it's going to take a very specific group of dedicated resources and investments on our part to really get there. You can't just take our products that we use take the United States, and even if we gave away, like Omar used to tell the story, even if we gave away pacemakers in India, that's not enough because they don't have the infrastructure. So we've got to do more in these under-resourced environments.
Well, and that challenge that we've taken on has rapidly become a very global and boundaryless one. Those challenges are happening right here in the United States just as much in different ways as around the world. The underserved is everywhere, and that has been such an anchor point around universal health coverage and even this SDG discussion that's afoot, which is for every country, every location. And so, as we've been perseverating on this, I think there's so much that happened during COVID. Where we really dialed up, what's our role when there's something that happens that really shocks the globe. And it's been a big thread of the conversation this morning. And so it'd be remiss if we didn't take a little time here to just walk through how did our perspective on addressing a global problem and living out that mission that said everyone deserves something in this time, what can we do? Our work with the ventilators and just stepping in that we did with COVID, Jeff, would be great.
Yeah, I think COVID really did, to you, as you've intimated here, really did remind us of the role that we could and should play, and to think big here. And in this case, for us, there was a number of things we did during COVID. One that gets a lot of attention is our role in ventilators. So if you rewind the tape back to the spring of 2020, when COVID was really taking off, there was a lot of unknowns. Hospitalizations were on the rise, and hospitals didn't know how to treat COVID patients very well. They've gotten a lot better at this. Put aside the vaccine, this is treating people that are sick with COVID, and ventilators were considered to be, and still are, considered to be a huge part of the treatment protocol. And there just wasn't enough ventilators out there. And so, and they didn't have the right functionality to accommodate these patients. And hospitals wanted remote capabilities, how you operate the ventilators remotely, monitor patients remotely on ventilators versus having to go in the room. And there just weren't enough of them. And we, the critical care ventilators in the United States and over a quarter around the world. And so we were, in a position where, one, we needed to dramatically increase production. We needed to improve and enhance the capabilities of these ventilators. And in addition to that, we had to take on a primary role of allocating these ventilators around the world, and that had to be done in a very needs-based way. It can't be, we took the approach, it couldn't be, okay, who pays you the most, or your strategic partners. It had to be needs-based. And so we, in many ways, changed, really had to come up with some new things. We're not normally put in a position where we're allocating things like that. And we didn't get much guidance from governments. And matter of fact, they were conflicting. Everybody wanted ventilators. They wanted to save lives, but lives of their constituents. And we're a global company. So navigating all these things, our mission really helped guide us. We knew this was a moment in history that will always be remembered. And I'm proud of the way we stepped up. We were able to increase ventilator production 5x, 5 times in a very short period of time. And kind of how we did that with partnerships and open sourcing the ventilators. So we put our plans online so everybody could see them and download them. And that we had people coming from all over the world, different industries, helping us with solutions to ramp production and to improve the functionality of it. And then we work directly with governments all around the world to help allocate these ventilators in the best way possible and navigate the politics, because we didn't want to get involved with that, and keep the patients first. So it really reminded us of the role that we can play on a global scale and the impact, and really proud of how we handled that.
Well, and that segues so well into really putting a real life frame on what we mean when we say social impact, really bringing the full power of everything that the company can do to address some of these pressing issues. And in addition to everything that was happening from the company, there were certainly things that were happening philanthropically, and the whole envelope of what we did together really certainly lived out our mission, but also put us on the map. And couldn't be more proud to have done that together. And I think we're on the brink of that today in the announcement that we're going to be making and the partnership that we have with Children's Heartland. As you're thinking about social impact and social outcomes and reflecting on our foundation, you sit on our board as well. What kinds of things do you see are transformational in the way that charitable foundations can behave in this time? Really getting outside that check writing mindset and thinking more about social outcomes.
Well, like I said earlier, Medtronic, we're a technology company, and we're not a healthcare provider, but ultimately, so we're not a hospital. We work with hospitals obviously and enable them, but ultimately we're in it for the outcomes, and so partnering with these organizations to help is what we do, and the foundation provided us a unique way to create partnerships that went beyond our technology in some cases to help and during the pandemic and the social unrest issues that popped up. And so I think a couple things that come to mind over the last year, both the pandemic and the social unrest, is our ability in the foundation to do a couple of things. One, focus on and have a narrower set of issues that we're focused on, or opportunities, depending on how you want to look at it, and go deep with that North Star being an outcome, and defining that outcome in a tangible way, and holding ourselves and our partners accountable. So the couple things, that clear focus on the outcomes that we define up front, these focusing on big issues, but specific ones, and going deep versus many issues and not going very deep. And then these partnerships that we formed, and then finally engaging our employees in those partnerships, because to magnify our impact, like you said. So we're not just writing checks, but we're using our skills-based volunteerism, as I used to use the term, to magnify the impact. So it's focus, it's the outcomes-oriented approach, focus on key areas, partnerships, deep partnerships with organizations that can really, we can help them, they can help us, and then so those are the, and then engaging our employees directly involved in these partnerships.
Well, I think, that's just a perfect opportunity now for us to talk about Children's HeartLink, because all of those threads come together in this incredible relationship we've had over the years with Children's HeartLink. For folks who don't know about Children's HeartLink, you also sit on their board. Give us a little flavor of who they are, and the connection between us as a company and them, and then we'll broaden this conversation and take a look at some videos and invite Jackie to share things.
Yeah, so I moved to the Twin Cities 10 years ago. It was 2011. And so I've been here 10 years. I moved I was working at GE, came in and sat on the executive committee, so reporting into the CEO, and wanted to get involved in some of the community organizations, and was introduced to Children's HeartLink, and really fell in love with their mission and their approach. What I liked about Children's HeartLink is, hear me talk about this being scalable and sustainable. So it was very focused on children born with congenital heart issues, and in under-resourced countries around the world. And they have a model that is very outcomes focused. It's also very focused on a very specific condition, because healthcare is hard, and if you try to be all things to all people, your impact, I think, is going to be limited. Right. They're very focused, or are very focused, and it was they showed the ability to scale and make it sustainable, because the model of knowledge transfer, where they match up a hospital in the United States, like a Mayo Clinic, and pair them up with a health system in an emerging market like Vietnam or India or parts of China or Brazil, and over a course of several years, that knowledge transfer occurs, so that you're training the trainers effectively, and then that hospital becomes a trainer in that region. Plus the fact that they work with governments to show the outcomes of this work, so the governments prioritize this as in their healthcare spending, and they're getting the outcomes. The problem is significant. I skipped over that. 1 in 100 kids around the world are born with a heart defect, and many of these, no matter what your, no matter what your race, or if you're born in a rich country or a poor country, those are the numbers. But and many of these are solvable with modern healthcare techniques, and the children will go on to lead normal lives. Some are more complicated, but many of them are eminently solvable with the right training and resources. And HeartLink has got that model down, and the results were phenomenal. And so I was blown away, and it looked really good to me. And after working with them for a couple of almost like a year, I said, boy, they got to meet Omar, my predecessor, who's a student of healthcare systems, and that'll be the real test. So we scheduled like an hour meeting, and Jackie and this woman Bistra, who works with Jackie's team, and that leads all the programs, came, and it was supposed to be an hour meeting, and the thing lasted 3 hours. Omar kept canceling his meetings, And because he was fascinated and kept asking more and more questions, and those who know him already know that's how he learns. And Bistra and Jackie kept having all the right answers, and from there, the marriage between Medtronic and Children's Heartland really took on a course, an inflection point, and we've really enjoyed the partnership over the years. And we learn a lot. We learn a lot. Necessity is the mother of innovation here, and Children's Heartland doesn't have a ton of resources, but still gets a scalable and sustainable improvement of outcome in kids around the world, and it's amazing. And so we've learned a lot as well from this partnership.
Well, it's been incredible, and I can just say, as someone who's been in the health arena for a while and in global health in more traditional ways, it's also helped us learn about how this particular condition and these types of partnerships are really part of a new generation of how we come into global health. And it's very exciting to see this all come together. Now, we've talked quite a bit about previewing a partnership. So let's just say we are announcing a new partnership today, and it's an exciting long-term and deep partnership between us and Children's Heartland, and we're incredibly excited by it. And let's first take a look at a video, and then we'll bring Jackie in and have a deeper conversation.
90% of children born with heart disease don't have access to the care they need. Most of those children live in low and middle income countries. Children's Heartland works to change that by training and empowering medical teams in underserved regions of the world. The Medtronic Foundation is launching a new multi-year partnership to take that work even further, focusing on equitable access to congenital heart disease surgery, improved patient outcomes, and engaging Medtronic employees to ensure high-quality, sustainable systems of care.
We would not have had the program that we have today with our patient outcomes and training capacity if it hadn't been for our multi-year partnership with Children's Heartland.
The Medtronic Foundation partnership aims to provide 10,000 children with quality pediatric heart surgery in Brazil, China, and India, train 10,000 health workers, including pediatric surgeons, cardiologists, and nurses, to provide congenital heart disease surgery, and leverage Medtronic employees' time and talent to reduce health disparities in access to care.
Patients like Hari, whose parents waited for 16 years for his life-saving heart surgery. We were able to help him thanks to a 3D print of his heart that showed us how to correct his heart disease.
The surgery I had makes it possible for me to go to university where I am studying technology, because medical technology saved my life. I look forward to one day contributing to medical advances that will help others.
Together, we will strengthen global health equity and improve access to the quality care children deserve.
So it's always moving when I see that video. So I've just got to catch my breath for a second. I invite Jackie Boucher, who's the president of Children's Heartland, to join us. I also just have to say, for anyone who really needs an example of what Earl Bakken's call to action is about giving back with your extra life, that story is inside of Hari, what he said in that video. Because of what's happened in his life and being able to have a life-saving surgery and his own commitment now to be a part of the next round of advancements, that who knows where that's going to go, and that's the extra life. And so it's just really powerful to see that all come together as a part of this conversation. So Jackie, thank you for joining us and being a part of all the work that you do and what you've led, and a part of a really exciting day today with this partnership. Welcome.
Yeah, thank you, Porvi. I'm thrilled to be here with you and Jeff talking about a topic that both of us, or all three of us in our organizations, are passionate about: equitable access to healthcare. Just to say a little more about Children's Heartland, I know the video did probably a better job than even speaking about it, but for 50 years, Children's Heartland has been really focused on addressing inequities for children born with heart disease. And we do this, as Jeff mentioned, by the trainer approach, really working to transform pediatric heart care in underserved parts of the world. I know Jeff mentioned, 1 in 100 children is born with a heart defect. So really put that issue in perspective. Every 5 minutes, 10 children are born with a heart defect. 9 of those 10 children won't get access to the care they deserve. Congenital heart disease is a rising contributor to infant mortality and is a leading cause of mortality from a non-communicable disease in people under 30 years of age. So it's really the leading cause of death for those ages 0 to 30 with a non-communicable disease. And I know that's part of today's World Health Day focus on inequity. Even in the United States, where we have more access to treatment, there's racial and socioeconomic disparities in infant mortality related to congenital heart disease. So it's wonderful to have this partnership to really start to address the issue in some of these underserved populations and take our train the trainer approach. And as Jeff mentioned, scale that approach. Right now, we reach about 170,000 children per year in the 5 countries where we work: Brazil, China, India, Malaysia, and Vietnam. And we hope to grow in the future to other countries. We've definitely grown our reach, but the need is great.
Well, that's impactful to know, especially given the number of countries and the opportunity for scale, not just within a country, but across, based on what we're able to do together. You know, and Jeff, you've already outlined so much about why this partnership matters to us, just the long and rich history that we've had together and the opportunity of staying very focused and really getting to outcomes and getting to scale. But you know, what makes us really unique, and I think many corporate foundations unique, is the combination of all of our assets, not just the financial ones, but also our employees. And so I'm just wondering, you know, what you've seen and how you're thinking through some of those combinations of our skills. We mentioned skill-based volunteerism.
Right.
We've got some folks that are coming in. We know that in addition to you on this board, we have Anu Kadadi, one of our general managers, who's also on the board of Children's Heart Link, and really just galvanizing more and more, not only enthusiasm, but bringing in some of the skills of our employees. You know, you have a lot of passion around that kind of engagement, like how to bring in engagement.
There's all kinds of areas. I mean, one you mentioned, you know, also on the board to have with the strategy of the Children's Heart Link organization, but also we've got there's a lot of areas. I mean, government affairs. We have large organizations, large employee base, big business in these countries, and access to government officials. We can help drive awareness and get the Children's Heart Link, narrative out there. And our evidence generation team that can help design and collect more evidence to prove the outcomes and to prove the health economics and how it's beneficial to these economies, so that it's protected in the funding as these healthcare systems prioritize where they spend their dollars. We want to make sure this is protected because, one, it works, and two, it's good economically for them. It's good economic investment, and you've got to be good in how you present that. I think we can help there. Technology solutions, as new technologies emerge in this space that could make these procedures more minimally invasive and easier perform. So the list goes on in terms of even communications. There's a lot of areas we can apply our resources, and then we actually have groups of as a development opportunity in Medtronic. We provide and this is a lot of this is funded out of Porvy's organization, this organization called the Global Innovation Fellows, where we take cohorts of up-and-coming Medtronic leaders, very bright, ambitious young people that want to also give back. As part of the development, we put them in dedicated teams that go into these markets and investigate a problem or an opportunity in terms of how can we fix something, or how can we take greater advantage of an opportunity there. And it's a so-called a surge of resources that we can apply to very specific questions or problems to help out. So there's a number of ways, and then I think the more we talk about it within Medtronic, just like when we open sourced the ventilator, I talked about, the more you talk about it, the more people come up with ideas and raise their hands. And so that's kind of how we want to do these partnerships, versus just here's a check and good luck, but here's some money, and I wouldn't call it strings. It's it's like it's here's some resources too, but there has to be a mutual interest or mutual need. So that's how I see it going.
Yeah, I think it's been powerful to see, especially that Global Innovation Fellows effort that you're referencing here. We had a cohort, and they're basically employees across the organization. They come together with different skills and different perspectives. It's actually a great way to even think about diversity and inclusion because they are representing all different parts of the world and society, and they're coming in together with Children's HeartLink and thinking through some solutions and opportunities, and frankly, giving a different perspective on service as they grow as leaders and integrating that into their next chapter. And during COVID, we had to grapple with a virtual way of doing that. And so, Jackie, how did that feel, and what kind of ideas came out of that when you had the innovation team with you?
Yeah, that was a fantastic opportunity for our organization to have them work with us. Obviously our model was built on more in-person contact, and like many organizations, switching to virtual, and also being a small organization, having access to Medtronic is such a global innovator in so many areas. So helping us think about technology, helping us think about how we can educate virtually and be engaging, but achieve objectives of what we're trying to train all of these different clinicians, whether it's the surgeon, the perfusionist, the nurse. Every clinician's part of the pediatric cardiac care team. And so it really helped us think differently, help us develop more of a scalable solution, and has really helped us sustain impact during this time.
No, it's also added to creativity on their side, our side as well, and thinking about, again, one of those moments where, okay, we're in a seemingly insolvable situation. What are we going to do? And you see the best ideas come out of that. So what do you think about how deep this partnership can go, and the kind of broader impact that can happen, knowing that we're going to ultimately improve the lives of at least 10,000 kids, but also build up the capabilities of 10,000 health workers. And you've got access to a whole host of centers of excellence and health systems around the world. How do you see that in crossing disparities and also going to scale?
Sure. Yeah, this partnership is transformational for the organization. I think it's going to help us scale in underserved countries that experience high disparities for children who need congenital heart surgery, but aren't able to access it. So because of this partnership, in the next 3 years, we'll be adding 5 new partner hospitals in Brazil, China, and India. And that will help us really double our impact between 2025 and 2030 as a result of this train the trainer approach that we use. I think creating more access to treatment is important. We're talking about equities today here at the Global Minnesota event. Every parent who has a child born with heart disease wants the same thing, access to the best care possible as their child can live a long and healthy life. They want them to move, be a contributor to the world, and to have happiness. Congenital heart disease, as we mentioned earlier, as far as equity, it's the 7th leading cause of infant mortality globally. 85% of those deaths are in low and middle income countries. Access to quality pediatric cardiovascular care is a huge issue for these countries. There's also inequity, not only inequities to access to treatment, but we know there may be some inequities by gender. And I know we've talked a little bit about gender in the symposium today, inequities. The incidence of congenital heart disease is the same for boys and girls. However, there is some evidence that cultural practices may drive decisions to treat girls less than boys in some countries, but this has to be studied further. So not only are we working on partnerships with Medtronic, but one component of this partnership we're really excited about is to conduct an equity study so we can add to the data gaps in this area. I think the other part of the access gap in the countries where we work is also due to the shortage of trained health professionals and a lack of specialized training for pediatric cardiac care. And so these are major barriers to care equity in these low to middle income countries. And together we hope to address both. We'll train the local workforce by partnering with leading medical volunteer institutions that will provide some of the training to help us in the countries where we're working, build regional centers of excellence so that children born with a heart defect are identified, they're treated, and they get high quality care. I think the other piece of these centers of excellence that's really exciting is that, once they achieve a center of excellence status, they're delivering a certain quality of care, but they're also training and doing research. And so we're really building local capacity. And so the lasting impact is exponential.
It'll be really interesting also to see how this combination of resources that brings the financial assets together with the talent of a company can maybe get to some of those opportunities even faster. And I know we're really open to joining on with others and ensuring that we can bring the very best collectively in collective action on this topic. I know through your work and Bistra's work, there's a lot of policy work to be done here and elevating this particular issue as a pretty strong driver of maternal and child mortality, and what do we need to do there? So it'll be an important time. We've hearkened so much about this partnership being unique, throughout this conversation, and we've all been working in different partnerships for some time. What would you say to this community that's listening today, which is representing pretty much every sector that's involved in healthcare from all parts of the world, but certainly in Minnesota? What are the things that you would say offer as guidance on unique and different types of partnership?
Oh, I'm going to take a shot at that. I mean,
yeah.
I talked a lot about some of the ways that we've changed our thinking, right, around the outcomes orientation, the focus, but the deeper partnerships. But one thing I'd say for companies like Medtronic, look, there's a lot we get out of this too. I mean, you got to think of the win-win here. So like what Jackie was talking about, opening 5 new centers. I mean, that's music to my ears. I mean, 5 new partner hospitals. I mean, because that's exponential growth, right? Because then they'll treat it's a bunch of new patients, and then they'll train other trainers to treat more patients, and then she talked about more evidence. I mean, the impact to patients here, especially in the Children's HeartLink model, is huge. And so that's enough, really. But I think there's for us just to know that, and we feel good about that. But there's more that can be had here. I mean, we can, like I said earlier, we can learn a lot, from this partnership, and we are learning. And we would like to apply it to create other children heart links, if you will, in areas outside of congenital heart, problems. And we're working on setting up organizations like this in hypertension. We have one set up outside the United States, as well as hearing loss. These are other areas, clinical areas that we're in as a company, and we're learning new models of care. We're developing new technologies that are specifically designed for these under-resourced environments and these conditions, but will be applied to other areas of the company, even here in the United States. And so it is, we're getting a lot out of it. And it's not a side job. It needs to be something that has direct access to the most senior people in your company. It has to be more integrated in with what you're doing and tied to your broader company strategy, whether you're a technology company like Medtronic, or you could be a large health system. Don't treat these things like a side job that you get good PR from, or just even get good feel good from. You can learn. I mean, this is strategic for us. It's tied to our mission, but it's strategic for us. And so I think of it that way, and you get a lot more out of these partnerships. I mean, what I've come to learn is you can do, in a company like Medtronic with our resources, you can do almost anything, but you can't do everything, and you got to focus. And so if you're going to partner, then partner, go big or go home. That's what I'd say.
Well, and Jackie, so here we are, we're going to try and go big. We're definitely not going home. So what you've been partnering with a lot of folks too. I know today we are the special one, but there's been a lot of partners in the mix. What kinds of things have worked well, and what kinds of tips do you have for the future, and possibly even a call to action for us?
Sure. Yeah, no, sure. I think, today in the World Health Day, there's been some mention of sustainable development goals, and just want to say a word about that and then answer your questions for me.
Yeah.
That's, countries around the world signed on to the Sustainable Development Goals in 2015, which have specific targets for reducing childhood mortality and mortality from non-communicable diseases. And I think what's exciting about this partnership between Medtronic and Children's HeartLink is that we're working to address both by serving children with a non-communicable disease, which is heart disease. Mm-hmm. As we've kind of seen the communicable diseases decline, congenital heart disease is constant, right? Children are born at the same rate. And so it's becoming more visible. And I think this partnership helps make it a lot more visible. I think the other exciting piece about the partnership is that it's not just about funding. You know, it's as Purvi and Jeff, you both have talked about engaging the Medtronic employees. Is also, you know, I know it's great to hear, Jeff, that you're saying you're learning from us. We're going to learn even more, you know, from a global thought leader, Medtronic. And so I think this partnership will have a long-term impact on our program model, just like we talked about earlier with the Global Innovation Fellows and how we've had to go to remote training. But as a small organization, I think partnering and sharing knowledge, technology, data, and even talent pools, it really helps us expand our model, our reach, and our impact. And that's important if we want to address this issue of congenital heart disease. And so I think as far as innovative in the partnership, you know, I really do see that this is innovative in the sense of sharing this talent pool and sharing information. It's more of the true sense of partnership. Sometimes I think partnerships are in theory, organizations. And I think because our missions are aligned, the work is aligned, that hopefully, you know, this lasting impact of the 10,000 children impacted receiving surgery and 10,000 health professionals trained has a very big impact in years to come as a result of those outcomes that we're working to achieve.
Well, I mean, I'll also say, and I know, Jeff, I've heard you speak on this before too, there's just so much to learn from the nonprofit sector, you know, as we come into it and start thinking about these different sectors and how you need to have government plus the nonprofit sector plus the commercial and private sector to get to the solutions. You know, Jeff, if you wouldn't mind, you've shared in the past about what you've learned just yourself as someone who's come up through business and your own personal journey and in service. What kinds of things you've learned from the nonprofit sector as a sector?
Well, look, I think, you know, I've learned, and this Children's Heartland is a good example of this, that, you know, small teams can do great things.
Right.
And sometimes, and this is, you know, one of anybody that's following Medtronic knows that I'm trying to go Medtronic from this $130 billion revenue company to $31 billion companies. Those $1 billion companies are still pretty big, but they're a lot smaller than 30 billion, to kind of get the teams focused on big ideas, but smaller teams working on big ideas. And I think, you know, I think that people get caught up in, you know, sometimes use, you know, I don't have resources, I don't have enough funding, and they forget the power of the idea. And just, it's woe is me, I don't have enough this, I don't have enough that. But if you focus on that idea and then communicating that idea, I do think resources, the appropriate resources will come. I do believe that. People may say that's naive, but it's worked. You know, I've seen it work, and it's worked for me actually. And so that's one thing I've learned is if you have an idea and you have a hypothesis that you can test, that the power of the idea is big. I mean, I do believe innovation is very a democratic thing. The best ideas will ultimately get resources. And it's a very democratic, but you need to be creative in how you communicate these things, and you got to have perseverance. And so that's what I see. But I do see some nonprofits get lost in the resources and lose their sense of their outcomes shift from, you know, that real impactful outcome to some other outcome along the way that isn't so impactful, and they get too wrapped up in that, and it creates problems. So I keep those outcome focused and keep those outcomes pure. Don't lose sight of the power of the idea, and those resources will come with perseverance. I believe that.
Well, that's incredible. That's actually terrific as a call to action as well. And Mark, you're back.
Yes, I couldn't miss a chance. Well, I wanted to get a chance to brag on Medtronic just a little bit. And we have a lot of viewers today in Washington or who come through Washington from the embassies and all that. And they may not know that over at the Smithsonian, there's a hall of innovation, and it has, you know, Silicon Valley and the Boston corridor and all of that. And right next to Silicon Valley is Minnesota's Medical Alley, and it features 3 specific innovators, you know, Earl Bakken and Dr. Lillahai and Manny, but it also features our region, and it talks about where did innovation come from and what were the elements of having the university system, having the tinkerers in their garage, having the capital. And I think that this aspect, and I'm urging all of the folks watching this that when it's safe to go see this amazing exhibit, but it's a reminder that everything comes from the spark of an idea, and then it grows, and it may or may not be able to flower or flourish. But if it can, and it does, then it creates the opportunity of, you know, in Minnesota Medical Alley, there's 700 members, I think. So there are at least 700 companies that have really come out of that spark of innovation. And so finding this discussion really about how do we generate the energy of new ideas through the lens of Children's Heart Link making this incredible contribution around the world, I think is a very special way. I happen to devote a portion of my life to issues around heart transplants, and it's that whole area has been transformed from the times when things couldn't be fixed to the time now when they're fixed at birth. And so we have a special story within our family about this, but I'm aware of the advancements that mean that some lives can and have been saved. And I've, you know, been a fan and follower of Children's Heart Link for a very long time. But today to hear these exciting plans is part of that notion of it inspiring us to get up the next morning. COVID can beat you down. You know, losing family and people dying alone. There are elements of this, but there's also how much we can help each other take tomorrow as the first day of that next birth, rebirth, that expansion, that what are we going to do with that extra treasured time?
Yeah, that's so beautifully said. And I can't help but think of Hari again, you know, right? It's just emblematic of everything you just said. And it just makes you believe that there's so much more we should all be doing, right? There, back to, you know, Jeff, it's not all scarcity. It's actually, there's a lot of opportunity if you just change your mindset about it. And I think all of us are saying that in different ways. That's very Minnesotan too, and being able to do that as well.
Occasionally Medtronic hosts people or like some singers or events out in your atrium, and you have a history wall that helps just a regular citizen be able to walk through and say, oh, that happened in Minnesota. Oh, that came before that. Oh, that was just a few years ago. I mean, you know, there's not a big explanation, but you are both overcome with the pride, but the amazement, but you also think, oh, how does my story fit into this? And, oh yeah, my grandpa has one of those pacemakers. Oh yeah, my neighbor has that heart valve, you know, and so then somebody can see how they fit inside of that story that Medtronic has helped bring to the whole planet.
And when I see it, I see that every day when I come in the office. I get inspired and kind of think, okay, what are we going to do next here? There's been a lot of innovation. What's next?
No, it's very true, and I just keep thinking again about the life that keeps getting amplified by more and more people surviving and doing more and adding more, and that timeline is just going to grow because of the next generation of innovators that are going to come through because they themselves have been touched in some way, and
well, I'm sure it's a good time to be in this space. I would argue, you know, because obviously the need is here like never before, and there's a better understanding around the world of the importance of equity. I think more people are tuned into this issue, and less people are ignoring it. I'll say that, and the opportunity to make a difference now is like never before because of, now I'm biased, I admit it, being a technology company, but because of technology. Technology is democratizing good care. technology will break down access barriers. Now, there's other things that are needed around that. You need the evidence, you need the government, these public-private partnerships, you need government regulations to change and things like that. But technology, there is a path to provide things like, I just got off an interview with some media on colonoscopies, and we've got a new, a pill cam, a little pill you swallow that basically gives you your diagnostic colonoscopy. This eliminates the need for, the traditional colonoscopy procedure, which I won't describe, but you know what that is. But you have anesthesia, physicians, complications, and it opens the door for some of these countries that just can't do colonoscopies that way, to get colonoscopies and prevent colon cancer. I mean, so that's just one small example, but it's all enabled by technology advances, miniaturization, battery, image processing, cloud computing. All of that enables this and opens the door for hundreds of millions of people around the world to get access to this diagnostic and then treatment that they wouldn't have otherwise had. And it's just all from advancement of technology over the last 5 years. I mean, so I can give you 100 examples of these. These can be provided. You can build a children's heart link around a technology like that.
Mm-hmm.
And I think it is about inspiring others with directions. We have the good fortune of a 3M who thinks about physical properties of things. We have the good fortune of thinking about Medtronic, thinking about the miniaturization and the making of things so that they can be less invasive. We have all of these different components that then have made this region special, and that willingness to share. Your government affairs person in Washington, often at speeches, I see him bring a sheet of paper out, and he is a list of the innovations from other parts of the world that have been very important to the success of Medtronic. And I just am so proud to be a Minnesotan and to have Trevor representing the appreciation that it's the sharing of ideas and incorporation into successful ways of saving and extending and improving lives. That's what makes the future bright, even in the middle of this crazy pandemic and the upside down economy. Those kinds of values, which are at the core, like you said, you haven't changed your mission since the founding, that gives us all what we need to do to get up tomorrow morning and to do the right thing again. Thank you so much for bringing this incredible story, this partnership. Jackie, it's always a thrill for me to think about all of this, and it makes me, sometimes it makes me cry, all of the things in my own life. But as a practical matter, the partnership that you have been describing is an example of that SDG number 17. There's all those 16, cut car crashes and deaths in half, that kind of thing. But then there's number 17.
Yeah,
partnership.
That's very true.
And Medtronic led the way, saying that means partnering with all of our team members and employees, partnering with our civil society and nonprofits. Partnering is the secret to the success of the vaccine and all that we've done. Thank you so much for giving us that treasure of inspiration, that example of partnership, that opportunity to get up tomorrow and do the right thing. Thank you again.
Thank you, Mark, for the opportunity as well. And for all
Thanks,
you.
Mark. Well said.
Bye now.
Thank you.
Bye-bye.
Thank you, Parvi.
Thank you.
All right.
Thanks, Jeff.
Bye.
Thanks, Barry.
Hello, everybody, and welcome back to those of you who've been with us throughout the day, and welcome to folks joining from wherever you are on the planet. It's early afternoon here in Minnesota, and we're so glad you've joined us for World Health Day 2021, with our focus on equity and equality. And we've been hearing opportunities and ways and perspectives from all angles, from big companies and small nonprofits and the larger structures that we face in our society. We're going to turn our attention now to learning from each other, because we know that the work of achieving equity, and we know that we have to achieve that at the global level if we're going to get in front of the variants that could overtake us and push us back to the beginning of the pandemic. But if we're going to be making that kind of progress rapidly, we have to do it by helping each other and learning from each other. I'm really thrilled to be able to invite to our panel for this session people that are making this happen in the real world around the planet. Some of you know what a success Rwanda has been in terms of really public health, population health, just incredible control of the COVID situation. But on many things, Rwanda just really stands out in front. But it takes infrastructure and it takes planning to do that. And our first panel member this afternoon, Ali Diallo, founder and general partner at United Capital. He's been a telecom entrepreneur and a visionary working with others to create what they call the next billion users. Their work in bringing the 5G broadband to Rwanda is one of the most exciting projects. It's going to really make a difference in terms of taking down one of the key barriers to healthcare. And Rwanda is a country that has always stayed on the front edge. And Ali will be joined by one of his technology partners, CEO Nixati, Jean-Paul Schmetz, to share about this exciting work that they are doing there in Rwanda and around the world, and hopefully soon here in the United States, where we have our own struggles in meeting the broadband needs that are crucial for taking care of our own healthcare issues. Ali, thank you so much for joining us, and please share with us your story of the progress and what you're doing in Rwanda and around the world.
Thank you, Mark. Thank you for having me. First of all, I'm very humbled to be here. I'm very grateful. This is a great panel, a great event, and certainly needed in these times. And yeah, so I'm one of the co-founders of United Capital, which is a global impact organization. We're based in Washington, D.C., operating in about 20 different countries and in several sectors, from renewable energy to telecom to telehealth as well. And Rwanda has been one of our key focus from the very beginning, and for good reasons. The country is at the forefront of the digital health revolution, as some of you already know. It's one of those markets that really succeeded in the fight against COVID-19. And in our case, we found great partners, local partners in Rwanda to collaborate with to really scale not only digital health, but also, on a much broader scale, broadband. And Rwanda has been the first country in the world to implement a national universal healthcare service, digital only, right? Which is pretty unique for a country in sub-Saharan Africa. It's also the first country in the world to deploy a medical supply using commercial drones, right? And the country has been very committed when it comes to supporting broadband, right? And we know that there is a direct correlation between broadband and healthcare as well, especially now, in those pandemic days. And President Kagame is actually, I believe, he's still the chair of the Broadband Commission for Sustainable Development, which is affiliated with the ITU, and the government has been spending, more than $100 million to support fiber infrastructure. So in our case, at United Capital, we felt the need to be involved and to support local communities. And we partnered with a local telecom operator, a Rwandan telecom operator, to really deploy a 5G ready network, a broadband network, not only in the city, in Kigali, but beyond that, in all the remote areas as well. So the project is currently ongoing. We've been in collaboration and we've been collaborating with the national regulator, and we recently received a spectrum to deploy the network. So we're working on the details currently. The end goal here is to not only support 5G, down the road in terms of deployments, but also provide a low-cost access, right? So right now, with the technology that we have, which is called vRAN, which is used by some of the largest telecom operators, but also telecom providers such as Ericsson, Nokia, and so forth. So the technology really allows, a low-cost deployment for wireless infrastructure, right? And in our case, because we're an impact-driven organization, we're able to pass on that saving onto customers, onto the end users. So that's the end game here. And once we have this infrastructure in place, right, the idea is to have additional layers of content deployed, such as telemedicine, infotainment, and mobile financial services as well. I'm not sure if Mark can hear me, but I can share a little bit more about Bluetel. Yeah,
please do. Okay. Yeah.
Okay, great. So yeah, as I was saying, so our group is called United Capital, and what we do is we really support local communities, but also organizations and even government agencies when it comes to deploying a broadband network and different solutions. And one of our portfolio companies is called Bluetel, which is a wireless infrastructure provider. And we were scaling the operations here in the US and across sub-Saharan Africa. One of the key projects that we have is called UBA, Universal Broadband Access. And the end goal here is to really support, communities, not only, in Africa, but also here in the US, minorities, to have access to a better broadband service. So here in the US, we're targeting the African-American community and also the Native Indian community in the Midwest, in the South as well. And across sub-Saharan Africa, as I mentioned, we're working in Rwanda. We also have other West African markets that we're planning on penetrating as well. And this is a unique time for connectivity, right? Because of what happened with the pandemic. This is a unique opportunity to really leverage, such a technology, which is open source, by the way. So it's not a proprietary technology, and that's the beauty of it. Because once you deploy it, you can have additional content providers providing all different types of content. So to go back to Rwanda, one of the key things that we saw, I mentioned the Universal Primary Healthcare Platform. So what the country did is they partnered with a UK-based healthcare organization, and I believe the Bill and Melinda Gates Foundation was also involved. And they came up with a way to create a national AI-powered telehealth platform, right? And if you look at how Africa is structured, right, a lot of the solutions, the services are now mobile only. So the platform is actually a mobile platform that allows anybody in Rwanda to have access to telehealth, telemedicine services. So anybody that's in a remote area could just take their phone and schedule meetings with doctors, have access to consultations, and doctors would be able to provide real-time feedback. And beyond that, even have patient monitoring, which is sort of unique. So it's the first country in the world to have implemented such a service at a national level. And the goal for us is to support such initiatives along the way.
And Jean-Paul, you're partnering with this. Can you give us a picture of how this fits together with the other technological kind of change and the fast pace that this COVID pandemic has created?
I will try to give you a few very practical examples. I actually even brought some hardware to show you and to show that it's not only abstract things, but super easy and practical things we are discussing. So I'll try to share. It seems it should work. So, of course, we all know that there is telemedicine. I don't know if you know, but for example, just like in Rwanda, all doctors now are available through video conferencing in France through a mobile phone application. But what is maybe less known is, I don't know if you've seen this device. It's something you plug on your phone and turns your phone into a COVID testing device. Have you ever heard that? Maybe no interaction. So, and maybe you've heard also an Israeli company that has made a smartphone application. You just cough on your phone and it tells you if you have COVID. For all this to work, you need, of course, infrastructure. And people very often believe that making a telecommunication network is something complicated. Actually, it is not. You just need to purchase PCs like the ones you see on this presentation. Then you run a software inside. The one we use is called Amarisoft. Then we plug the PC to some kind of amplifier. It's not a sound amplifier, but a radio frequency amplifier. And we get a 4G and 5G network. So overall, a PC, a software, and an amplifier. That's enough. If you want to look a bit more in details, then the way we will deploy it is with something called smart glasses and artificial reality. We ship the hardware like we would ship IKEA furniture with procedures. We then ask people to put smart glasses, and then we can remotely help the person with the smart glasses to set up the network. And just by doing so, after some time, we get a result that looks like this and provides 4G or 5G network. This is in France's countryside, but it will be very soon the same in Rwanda. So deploying networks is, with vRAN, has become something extremely easy. And for example, I just brought one. This is a PC I have in my home. It's just a PC, and it brings a 5G network in my home. So deploying networks nowadays has become essentially not more difficult than deploying Wi-Fi, because you just need to run some software on a PC and you get a 5G radio system. So that's all.
Jean-Paul, well, so thank you so much for giving us this visual, this understanding that we are able to leapfrog technology. Sometimes we talk about that. You're talking about bringing to Rwanda the most advanced to aid their ability to stay on the cutting edge so that the rest of us can learn from Rwanda and from other countries. And thank you so much for bringing that.
And they are more advanced sometimes because they already got their fears out. They don't need to outsource. They just do grassroots with their own hands. And this will make it so easy to get 5G deployed there, actually, sometimes faster than in France or Germany.
Well, so our next guest, Nyosha Roshini, one of the co-founders of Global Black Youth, has been specializing in bringing webinars and conferences and big explosive events together to see the technology and the innovation that's coming from all over the planet, but also to talk about the ways that people can exchange and support each other. Nyosha, thank you so much for taking time. I think you're coming from Africa and you're middle of the late in the day for you, most likely, but we so appreciate both the inspiration from Global Black Youth, but also the work that you're doing to bring that knowledge that is in our communities everywhere into a more general and socially aware place so that all of us can be better faster in this way. Thank you for that, and please share with us your story.
Thank you very much, Mark, and thank you for Global Minnesota for putting together such an important event and having these spaces to really discuss and try to include very fast, some of the knowledge that's being produced by very much overlooked and underinvested populations. So in this case, I'm the co-founder of Global Black Youth. We connect into the most cutting-edge solution generated by Black youth on a global scale. And by global, I really mean from the Pacific to Latin America to the Americas in general to the African continent to Europe Middle East, as the African diaspora is everywhere in the world. We try to bring to the fore some of their knowledge and really disrupt those grim stats of underinvestment, of funding, solutions, opportunities, knowledge into Black founders. We see that as missed opportunities. So as we move forward, and I don't disqualify the efforts of diversity and inclusion, but it's just a surface cover up. It's so much more than this. We're missing out. We're in revenue and in knowledge through our current global crisis that could further our efforts, and we are using only a fraction of our capacity, of our global capacity. So we really try to use a decolonized, a decentralized approach to innovation. When we think about innovation, that's really important to address our critical needs, to research, to business policies, to practices, or anything that's related to our well-being, and to be able to harness the full potential of innovation that growth and minimize harm. We at the same time, like I said, we see the correlation. We at the same time, like I said, we see the correlation between economic crisis and the underinvestment into Black founders that threatens the ecosystem of the accelerators, the incubators, and especially in the global South, that are often overlooked, that can, that basically foster that health system. We try to connect and really foster a global community, not just to each other. So, for example, connecting some of the fantastic work that they're doing in Rwanda with some of the fantastic work that they're doing by Black communities in Colombia, with what's happening in Brazil, with what's happening in South Africa and Australia and New Zealand, so they can learn from each other, connect to each other, inspire, collaborate with each other, but also really establish that pipeline where it doesn't exist, or widen the pipeline to industries and to policymakers, to these knowledge producers. Yeah, so that's in a nutshell what we're doing at the moment. I'm not sure if there's any specific questions, Mark, that you wanted to ask or for me to focus on, but I can give some specific examples of, like Ali did a fantastic job of kind of stating what's happening in Rwanda. We have, very similar examples in other parts of the world. But
yes. And I go to your website to get inspired by the stories that you've included there. Give us some of those specifics.
No, that's fine. I mean, so just a quick stat. I mean, just and this is an understatement, but just, about 13% of the technological innovations that happened in response to the COVID-19 pandemic were pioneered on the African continent. Again, that's a very large understatement. I'm sure it's much more than this. I'm positive of that. But because of those dominant narratives that we have, because in our global imaginaries, we cannot perceive that these valuable knowledge can emerge out of the African continent or Latin America, we're missing out. We're not even considering it. And I think that's why it took us so long to be able to get to where we are. So two of the things that we did last year, and this is how we met Mark, and I'm so glad for this introduction, is that we grew very much tired of the negative perception in the media that was expecting for this apocalypse to happen on the African continent, the disproportionate impact of the pandemic on Black population, but there's really nothing that was harnessing and that was really highlighting the knowledge that were produced by these young innovators in the global South. And we decided to hold a series of webinars, and that was our, the first ones, looking at, what is it that young Black people in the global South are doing in health and innovation? What is it that they're doing to mitigate the economic impact? How is it that they're, even with the threat to basically wipe out all the SMEs on the continent and Latin America, how is it that they're bypassing this? And what is it that they're doing in terms of misinformation that was threatening also the efforts to mitigate the pandemic? From this, there was a really growing need to bring together a much larger number of innovators and entrepreneurs together. We held our Global Black Youth Fest, which is our annual summit. We brought together about 2,000 young Black innovators over 2 days around topics, from AI and machine learning to innovation in health and sciences to female-led technologies. capital and access to capital entrepreneurship, and a wide array of topics. And that was the first time that we're able to bring together somebody, like a policymaker like David Lammy, who is one of the few Black MPs of the UK, in conversation with young innovators and environmental activists from Jamaica, an entrepreneur from Kenya, in conversation with an impact investor from the US. And it was fascinating to them because they never had these cross-regional, intersectoral, and intergenerational conversations. We also held demo days to really try to disrupt, like I said, those underinvestment and those really grim stats of 0.3% that go in funding that goes into Black female founders, of the less than 1% of funding that goes into Black founders in the US. I mean, the numbers are just so ridiculous, actually. And so we really tried to connect them and show basically businesses and corporations, but beyond just business corporation, policymakers, what they're missing out on by not tapping into the knowledge and the efforts of young Black people on a global scale.
I know that you're planning a founders conference coming up relatively soon. What was the motivation to really kind of create that new forum that you're working on right now?
Like I said, it's just as there was a need. So we're doing several things. We're launching next week the Black Entrepreneurs Club, to have a space where we can have semi-structured pitches by young Black innovators and entrepreneurs to an ecosystem of founders, of bankers and funders and investors, and to really be able to bridge that gap, and really disrupt those grim stats I was discussing. We're also creating a platform to really showcase some of the most high caliber Black entrepreneurs, and really have bring them to the fore and really bring visibility to the work that they're doing. Like I said, it's just as we have these conversations, and as as we, for example, we interact with the Black entrepreneurship ecosystem in the US, they're highly surprised to know that these kind of cutting edge enterprises take place in Brazil or in Colombia or in South Africa or in less, of the usual suspect African countries, in Senegal, which is a booming ecosystem. I'm in Cape Verde at the moment, and Cape Verde is actually, really up and coming, and very few people have that notion of Cape Verde, unfortunately. So it's the work that we want to do to really bring that knowledge from the global South, and so we can learn from here to the rest of the world, rather than having that, the top-down approach from the north to the south.
And our friend Ali, who is focusing on the infrastructure. Ali, I wonder, this is your experience that you've been able to see that Rwanda and many other places, with the proper infrastructure, then it becomes possible to hyper and really put a booster rocket on innovation, on entrepreneurship. And it seems like you're having a lot of success with that in your impact firm.
Yeah. So, to piggyback on what Nyusha said, the key is, beyond the infrastructure, is really to be able to support the ecosystem, right? We use an inclusive innovation model, which is modeled after MIT's inclusive innovation ecosystem, right? So the whole idea for us is not just to deploy an infrastructure, but to make sure that we empower local communities, local entrepreneurs, local corporates, even governments, agencies. We work a lot with a lot of agencies. So the goal is to empower them and do a lot of knowledge transfer, so that once the infrastructure layer is put in place, we can have an ecosystem that actually bubbles out of this infrastructure, right? So when you look at telecom, for us, putting together the actual infrastructure to enable 5G across multiple communities, this is just the first step, right? The real opportunity, the real value is when we're able to open this ecosystem, so that anybody, to Nyusha's point, anybody that has a startup idea or an innovation, right, would be able to tap into this infrastructure and deploy their own solution. Because, as a global organization, I mean, we're based in Washington, D.C. We have around 20 venture partners scattered around multiple geographies, from Jordan to France to Sub-Saharan Africa to Canada. We cannot really know, or we cannot even pretend to know all the challenges that, specific communities or nations around the world, have to deal with, right? So our key for us is really to empower local leaders, local impact leaders, community leaders, entrepreneurs, because they know the challenges that their countries are facing much, much better, right? So we see ourselves as an enabler, right? As opposed to an actual, principal driver of change. We want to create and foster that ecosystem, but we really want to support and empower local communities. And the governments, governments have a lot to play, in that ecosystem, just like entrepreneurs, and investors as well, right? The key for us, when you look at the technology sector, and we do the same thing in energy, in private equity, in fintech as well, right? So when you look at the telecom sector, when we want to build an ecosystem around it, the first step for us was really to help that baseline and create that infrastructure layer. That's why we started with Bluetel. And once we have it deployed, that's when we would be able to onboard a lot of entrepreneurs, a lot of startups, innovation-driven companies, and have them deploy the services that their countries need, right? Rwanda, for instance, did not wait for anybody to tell them what would be the best solution to solving the pandemic, right? And when you look at Rwanda, I think the country had so far 300 deaths, from COVID. It's 300 too many, but it's still a much better number than other countries. And I think there are around 20,000 reported cases so far, right? So the country did not wait for anybody to implement this national pandemic plan, or the digital, the AI-powered platform that I had mentioned. So they knew exactly what the challenges were, right? And they were able to implement it much better than if another company had to come in. So we were very, very mindful of the needs and the cultural sensitivities and the realities of each market we penetrate. We have a very inclusive approach. That's actually why we're called United Capital. We work with a lot of stakeholders, not just deploying an infrastructure network and then leaving. So I think that's the key, especially if you want to drive impact at that level and create some sort of ecosystem that goes beyond just one solution having a monopoly in an industry. That's actually why the technology that we chose is an open source technology with Jean-Paul and Amarisoft as well in the back end. It's open source, so anybody can, once we deploy the network, anybody can add, any types of services, and there is a lot of security, tied to it. And when we go in a country like Rwanda or Ghana or Senegal, I'm actually originally from Senegal, so I know Francophone Africa very well as well. And when we go to those countries, we try to work with local stakeholders, right? So we look at the telecom operators, we talk to government agencies, and whatever is already in place, instead of just disrupting it, our goal for us is to serve as a catalyst to really amplify, the impact that those local solutions have been having.
Well, Neusha, I can imagine that there is conversation about the sort of disparity globally on the availability and the rollout of the vaccine, and there are innovations taking place. And South Africa has been, at least at the World Trade Organization, really pushing hard to get the waiver that's been promised but not delivered, so they can be generating through their own pharmaceutical system and their own manufacturing system. What do you see from your perspective in Global Black Youth about the innovations that might help the whole planet get to some kind of a more universal immunization and vaccination through the efforts of young entrepreneurs?
Thank you, Mark. So just to take from, because it's very much all linked, just to take from what Ali was saying, when we think about, as he was talking, I was thinking that, for example, one of the efforts that we're trying to do is really trying to strengthen and that knowledge sharing, a South-South knowledge sharing, because we saw that during the pandemic, even before the pandemic, that knowledge that we're trying to adapt from the global North to the global South was not working. right? Our quarantine measures, the reality was just not feasible in these places. But it comes a way that the same way that we think about innovation as well. And like I said before, what we're trying to do is really decolonizing innovation. The way that we measure innovation, that we perceive and understand innovation needs to be centralized and decolonized. And like I always say, the most innovation that I've seen was not stemming, out of the Silicon Valley or Berlin or London. It was Cuba was one of the most innovative places I've ever been in my life, because it's the cradle of innovation is necessity. So we've always been innovative as a humankind. So it's become a buzzword, but it's just something that we've had to do. We had to be creative in order to meet our needs. So I think that a lot of the issues that we're facing, because we're not investing into these local innovations that are much more, adequate to respond to those local needs. We're not harnessing that knowledge that can address our most, our global concern, our most pressing issues. When it comes to, the example South Africa is great, but I think the fact that we're trying to hold on to a patent, an international patent around the vaccine, but also not tapping into that local knowledge is hampering the way that we're addressing. And then for that knowledge and those responses to the pandemic, to health issues to be fully harnessed and maximized. I'm sorry, I'm going into circles to respond to this, but for me, it all comes to the same issue, that the much greater issue at the center, at the core of the way that we're approaching this.
I've been very impressed to kind of follow the news and to know that in general, Africa and Asia have done very well in protecting their citizens and protecting the whole planet as a result around COVID. The Americas and Europe, very unsuccessful in general, but also that there's been more developments that have become, I would say, public recently about some of the early planning, like among for example, the United Arab Emirates beginning to redeploy their big aircraft to make sure there was transportation for protective gear and for vaccine, and just things that people have been thinking about in general. Does it feel like, from all of your perspectives, Jean-Paul, Ali, Neosha, that we can bring the learnings from this period, the so-called great pause, which seems to me like is the great learning, can we bring these learnings together somehow at the moment through Zoom or these electronic communication, so that we are really able to support each other in building back better, as everybody is, prone to saying, at least now at this moment?
I can go first, if if Jean-Paul and Yusha allows it. I totally agree, and I like how you framed it, Mark. The great learning. I think this has to be the key way to define what we've been through, right? And at United Capital, that's what we focus on, right? It might seem strange that we sometimes operate in places like sub-Saharan Africa and emerging markets, while still being based in the US, in DC. But there is a method to our madness, right? There is a reason for it, and the key reason for us is to be that bridge, right? I'm an American entrepreneur. I've built startups and companies, in Silicon Valley, in Vegas, in DC, but I'm also from Africa originally, right? So I just like so many other diaspora members, I sort of embody that bridge between different cultures, different communities, and different geographies. And throughout my life, I've seen that there is an opportunity to learn from each other, right? So being based in DC is really key for us in the US, because we're somehow operating as a bridge between the US and Africa and Jordan, where we have also, a great presence, right? So being able to create that environment, right, an ecosystem that enables multiple cultures, multiple markets to learn from each other is key here in this world, especially in a post-pandemic world, right? What we try to do on our end, we've been documenting every learning opportunity and every mishaps, right? Every mistake that we've made. And we made a lot of them, at the height of the crisis. We had, we had an office that we opened in India, for instance, another one in Senegal, and we had to shut down, some of those offices, because of the crisis, right? We had some of our portfolio companies that did well, right? Especially in the telecom and fintech space, right? But others that did not do so well, right? So we try to aggregate and document all of that, right, based on the geographies we operate, and we try to make sure that we share that knowledge with other portfolio companies, but also other stakeholders, and I think that that's a key element of the new landscape, in this world, right? We need to be able to create that open learning environment, for all communities and for all stakeholders, so that we could learn from each other. I don't know if Nusha or Jean-Paul want to add anything.
It's hard to go after you, Ali, but I'll let Jean-Paul go, and I'll go after Jean-Paul.
Right.
Okay, thank you, Nusha. So I would say from Europe and our terrible failure, what we were forced to learn is how to teach others things that we used to teach by traveling. And we came with a new idea. We call it open service. It's not open source, it's open service, where if we want, for example, to implement remotely at 3,000 kilometers away a service like a water distribution, cloud computing, telecom, whichever, then we are forced to define very precise procedures. Then we have to provide the freedom to people who are far away to learn how the service is made, to learn how to copy how the service was made, and to learn how to operate the same service based on the same bill of material or based on the same procedures. And this idea of open service would probably have never emerged if we hadn't been forced to stay home and not to move, and have to have people far, far away do very complicated things, which are not just about building furniture, but providing a service. And I think this will be, I would say, the most positive outcome of this crisis. For the rest, I think it's still too early to learn what happened. Personally, I don't think it's Asia or Africa versus US and Europe, but it's communist countries and underdeveloped countries versus developed countries, where developed countries fail and communist countries or developing countries succeed. And we'll have probably to learn a lot, maybe in a year or two.
Thank you, Jean-Paul. So I would say that, so I think it's a flawed perception that the more developed an economy, the more, it innovates. Like I was saying before that, it's just the way that we think and that we perceive innovation. I think one of the things that, so similar to Ali, I'm also a US citizen. I'm also from the Ivory Coast, West Africa. I've lived in Latin America for a very long time, so I consider myself Latin American as well. And you become a connector and you realize that the only way to really respond in a sustainable way, in order for us to reach any of the SDGs, the same way that we failed at the Millennium Goals to meet them, we're going to fail at meeting the SDGs unless we shift the way that we think, unless we really decolonize the way that we think about innovation and entrepreneurship, technology, and we really democratize the process. So, and by that, I mean that the way that we think about it, right? So we put value to certain regions of the world and less or higher value, depending where it comes from. So I would say that one thing that came positive out of this, it basically, one that it put in the whole innovation realm, it really put the innovation in the African continent and Latin America in high gear because they could not rely on the governments, right? In Colombia and Brazil, they could not rely on the government. So despite everything that's happening and very, very, very sad numbers in Brazil that has the second largest death rate after the US, is still the entrepreneurship ecosystem is still thriving, is still booming, especially of Black women entrepreneurs. There's a lot of health tech that emerged just last year that really grew. The knowledge sharing of the South-South knowledge sharing is also has also strengthened over 2020 and hope continue in 2021. So we really, that's the part I think that really has helped to put to the fore and bring and shift the way that we think about knowledge, and not just a one-way pipeline, but a multi directional pipeline where we learn from each other and then where we value that knowledge. So, from the way that, for example, they use AI and machine learning, for example, and to really bring about quality healthcare in Ghana, to the way that they use AI to harvest water, clean water from water reservoirs in the Congo, that could be, for example, a response to the drought issue in California. But because of those dominant narratives that we have about Africa and Black communities in general, we're not able to see that knowledge as valuable. And the only way that we move forward is that if we really disrupt those dominant narratives, the way that we think about it. So that's the way I see forward. And I'm hoping that because of everything that we have faced during the pandemic, we are able to disrupt the old ways and not the business as usual, and then really adopt and not even a new normal, just adopt. Yeah, I don't like the word normal, but we have to also take into account, and I appreciate what Ali is doing, the fact that data is still the most expensive on the African continent. That has to change, right? We still have 50% of the population that's not connected digitally. So these are realities that we still have to face. And even though we value the work that we do at Global Black Youth, we also understand that we're only able to reach those who have those the privileges to be able to access and produce that knowledge and be on those digital platforms.
So each of you brought a very positive perspective because you've been seeing it before the COVID pandemic, kind of took over, and you see the other side. Do you have a picture of, let's say, Jean-Paul suggested that this set of circumstances, being stuck in one place, wanting to provide services thousands of miles away, but that there is a new way of approaching the work that is addressing disparities and historic colonization. Is there a new way of being colleagues with each other on a global scale that you can imagine coming out of this?
I can add a quick word on it, real quick. I definitely agree. I think that there is a way to reinvent, the workspace, the actual way of collaborating. From the very early on, very early stage, United has been collaborating with a lot of different stakeholders and partners around the world. So we have 20 venture partners and around 50 global advisors. And for us, the key is really to, again, going back to that, empowerment, the key is to recognize the value that each one brings to the table and figure out a way to really ignite that value, right? And we're very open, very unstructured in the way we harvest talent, right? And opportunities for impact. Right, the key for us is to really support our advisors, our collaborators, even our competitors. We see ourselves as an ecosystem enabler, right? And leveraging technologies, such as remote technologies, such as Zoom, such as remote training. We're able to really empower a lot of leaders, right? Because we really believe that everybody has something to offer, right? That's the way forward, in my personal opinion. I think that's how the world and companies will start evolving. The closed loop environment is really not working. COVID-19 showed it, to all of us. We need to think strategically about how to be more open, not just metaphorically, but really, systematically, right? And that's where the world is moving towards a more open society, leveraging what you call the great learning.
It's always hard to go after Ali. It's so fantastic and articulate. I just think, so in the same way that I would just think about the way that, Mark basically and I connected, and how he was able to help us really amplify the work that we do, and connected. When I first heard about Global Minnesota, I was like, that's kind of weird, that's kind of odd, but I love the fact that it had global and Minnesota in the same title. So I always say that the work locally can be strengthened by connecting globally, and that's the only way. Like, I can only think globally, even though I'm from the Ivory Coast. Like I said, I'm from so many parts of the world. We're global citizens in the end, and this pandemic has really pushed us to realize that there's no other way than to connect and think globally. And one of the introduction that Mark has done. And Mark, I promise you that Joseph did not pay for me to say that, but we're partnering with a fantastic person that Mark put us in touch with, who is really trying to disrupt the private equity market and models, and which when I met him and I heard of his vision, I really fell in love with the work that he was doing. And so we're partnering with the company called Belgata to really create this an investment portal. We will be one of many others on an international level, and where international investors can come and meet some of these high caliber, promising entrepreneurs, and really, like I said, disrupt those underinvestment and grim stats of the 1% or the 6% that we often see. So that infusement investment is key, because it will help to really foster and strengthen the ecosystem that people like Jean-Paul and Ali are trying to are doing it successfully, right? Building those ecosystems. So, but in many parts of the world, and parts that we least expect them to flourish, I would like to see them, emerge out of South Sudan. For example, we're working with a female-led enterprise that from Somalia, that's very innovative, that uses solar energy to bring about healthcare to patients in rural regions. So, and this is something that you never think, this kind of innovation coming out of Somalia. Same thing, we're working with innovators out of South Sudan. So really disrupting those dominant narratives we have of these places that are, resonant in our minds, unfortunately, with war and misery. And like we saw, for example, the example of Rwanda, in less than 30 years, they're able to shift the dominant narrative of the genocide into a hub for innovation on a global scale. So I think that now is the time, and to really think forward, and then really think about everything that happened last year, not just in terms of the health crisis and the natural disasters, but also it brought to the fore all the issues around that. For example, racism is a health crisis, right? And not just because it disproportionately affects, Black populations and indigenous populations and people of color, but and it happened on a global scale, that the movements in the US had a repercussion around the world, and it really helped to foster a global community. So, I'm not trying to say that it was a positive thing, obviously, but we're saying how we can use the lesson learned from the pandemic. We can think about, connecting globally to, enforce our work locally. Like one of the other things, for example, we're doing further this month is really looking at, for example, facial recognition and AI, and how the threat to our privacy, and with efforts that the city of New York has been leading. I'm not sure if you know, but they banned facial recognition, and connecting it to other efforts, similar efforts of using and maximizing tech tools and opportunities in Nigeria, South Africa, and Brazil. And I think that, and then the way that we're thinking now globally is really it's revolutionary to me. So I'm hoping that we'll continue to collaborate with Minnesota and other partners. So yeah, thank you.
Well, we were committed to that vision, but I also want to note that one element of Global Black Youth is the notion that youth are leading globally, whether it's on gun violence, on racism, on climate, on entrepreneurship, on changing our relationships to each other and to the planet. And so I feel like there's a generational change that feels very global. And the rest of us are the beneficiaries of that leadership, but we're trying to find the ways to be partners, partners in innovation, partners in the ways that Ali was describing and John Paul was, where we're being forced to think differently. But I feel like one of the aspects that I've been learning, and of course, Minnesota is in the middle of a continent, but you know, there are many people who have come here, our indigenous people who've come from other parts 10,000 years ago, the people who came here early here from France and all of that, and the people who've come in the last decade or 2 or 3 from East and West Africa, from Latin America, from Asia. The world now is within this space all over. And Minnesota has been incredibly favored and incredibly, importantly enriched and engaged in the rest of the world. And so how we keep that up. I know that having the ability to, with Zoom and with digital technology to connect has really been important. But I also know that there's still disparities globally that we need to be thinking about how we work those. And then we have the perception about youth, perception about Africa, perceptions about young people. And so in this opportunity today, World Health Day, we've been able to thread some of these pieces together. But what I'm looking forward to is the ability to take our conversation and to really amp it up. And I want to offer to all 3 of you the moments for last comments, giving us all some inspiration about the best ways that we might connect with each of you going forward. Audiences from the whole planet, how can we work together, taking all of us into a better place?
I would say that the easiest thing to remember is never be afraid to share the knowledge, because that's one thing that will stay alive even after your death. And I would just give that word as a conclusion.
Amen.
I'll go next real quick. So one of the things that we've been doing that has been quite successful for us is at United Capital is really mobilizing as many resources as possible and organizing them around global impact initiatives, right? So at the height of the pandemic, we put together an initiative called PRISM, PRISM, which stands for Pandemic Response Through Innovation and Scientific Methodology. And we were able to really connect with great leaders from multiple sectors, right? And to onboard them, right, in a very collaborative way to think strategically about how we could, come out of this crisis. So that was our initiative for healthcare. More recently, we've been working on telecom infrastructure, and we have 2 initiatives. One of them is called BEAM, right? BEAM, which stands for Broadband Equality for American Minorities. And that project is really, again, a coalition of multiple leaders, an open coalition. So we invite anybody that, wants to partner with us or collaborate with us, or even, help scale, broadband solutions for, minorities here in the US. So we were very open, and we invite anybody to use this platform. It's very early. We're still structuring everything, but the key here is, again, empowering the locals, communities, local stakeholders, and, from the corporate, from the government, from the, private equity, venture capital sectors, and obviously from the entrepreneurship ecosystem. At a much global scale, we're doing the same, in the energy level. We have several, portfolio companies, but also several, independent, collaborators, big industry leaders from Europe, from the US as well, and from Africa, working together to solve the energy crisis around the world with renewable energy. Operated by my co-founder Bashir out of Canada, and also by Marley, who's heading a company in renewable energy operating in Africa. And on the telecom scale as well, we're doing the same. So the key here, the pattern that we have is let's work together, let's collaborate, let's find a way to really take the best of what each one of us has to offer, and push an impact strategy that would really have an inclusive component, reaching local communities. So those platforms for us have been key, and they are all open. We, like I said, we're very unstructured when it comes to those initiatives. The key here is to onboard as many collaborators as possible, and obviously Zoom has been a tremendous help for all of us. But to your point, Mark, what happens, when you go to places where, broadband is a challenge, right? Where connectivity is a challenge, how do you onboard those local leaders? That's why for us, having a foot in the actual telecom infrastructure ecosystem is very key, right? Because like I said, this is just the bare bone layer. It enables additional opportunities for all of us to connect with remote collaborators in so many places. So we're very open, and we're also very early. This is a very small organization. We have 5 general partners. We are fortunate that one of them is, the Prince of Jordan, who came in as a co-founder. Prince Abbas, who's a Jordanian American, and the rest of the team is here in the US and in Canada and across Africa. So at the core, we're a very small team, but we were able to really scale and have or drive some sort of impact through the help of different collaborators, by empowering them, but by also welcoming them, right, and welcoming their ideas. And I think that's really key, having that platform approach and nurturing an ecosystem when it comes to driving impact.
Great, thank you so much, Neosha.
Thank you. I waited because I was like, you know what, the trend has been for Ali to go first, but I should have not gone after him again to close this. But I would just say that we saw last year, and we've been seeing throughout the years, young people have been demanding change, right? They've been hosting a lot of online campaigns, offline campaigns. They've been disrupting the way that we're doing things, and it's been fantastic, and I love that. So we have to kind of own that generational change. We have to really pass it on to the young generation, but especially to those young generations that are overlooked and underutilized, underinvested in. And just to think about the African continent that has the largest young population in the world, followed by Latin America, we're missing out. So what I would say to especially big corporations, but also large organizations, we can't think about DEI efforts. It's nice, but as a person of color, I always feel a bit insulted when I hear DEI, because I feel like they're doing me a favor. Like, oh yeah, we have this policy. Now we have, 2 people of color on our board or in our staff. And it's like, yeah, but am I supposed to thank you for that? It's not enough. It's very superficial. We have to really disrupt that. That's very nice, but these are baby steps. And we're in 2021. We're beyond baby steps. We have to embrace that change in a much more drastic way. We have to think about missed opportunity. So even if we don't really care, but we don't really see the value of tapping into that knowledge that's being produced by the most overlooked populations around the world, in this case, Black youth, especially in the global South, we have to think about this. We're missing out on money. We're thinking about the largest population in the world, in the African continent, second, Latin America, that are driving innovation and the different types of innovation that we're completely missing out on, that we can be gaining money, we can be gaining knowledge, and it's going to be a much more prosperous effort forward. So, so that's what I would say. And again, and not because from a sociological, kind of like fluffy way of thinking about narratives, but if we want to really achieve the SDGs, like for real this time, not like the Millennium Goals that we failed at, we have to disrupt the dominant narratives. We have to change the way that we think about the African continent, Latin America, people of color in general. Because if we continue to underinvest into young, founders, especially, or innovators, entrepreneurs, young leaders of colors, we're going to completely fail at society at the way that we're doing things and continue into the same trend of inequality and disaster that we're going forward. So that would be my last message.
Thank you so much, Jean-Paul, Ali, Neusha. Look forward to finding all these exciting ways to work together. We have many things to change, many things to do, but we have the opportunity because we have the possibility of connecting and helping each other be better at this connection going forward. Thank you again for being part of World Health Day 2021, and I look forward to seeing you again soon. Goodbye now.
Thank you for having us.
Thank you. Thank you very much.
Goodbye.
Bye-bye.
Thank you for having us.
Cheers.
Bye-bye.
Hello again. Welcome to all who've just joined us for World Health Day 2021. And hello again to all who've been here for this morning and for this early part of the afternoon. We've been looking at this theme of health equity and equality from a global macro level. We just had a fabulous panel looking at the specifics of what we can learn from each other. And this next hour, we're going to be talking to three of the most important experts, thinkers, thought leaders on how being preparedness is part of that reach where we're moving towards a more equitable, a more equal, a more resilient society. And we know that some parts of preparedness have been ignored, neglected. They just haven't been on the radar, but now we know that preparedness is coming back. Proposals for treaties, proposal for decade-long preparedness processes. We really have a chance to say being prepared is a critical component of health equity, and health equity is an absolute requirement to actually be prepared. And we're going to open today with brief presentations from our three panelists and then engage in a conversation. Our first panelist, Leith Greenslade, I've got to know in her role as coordinator of Every Breath Counts Coalition. It's the most effective and comprehensive global coalition I've ever observed, and I've observed a lot over the years. It's the way of bringing together powerful players, global players, and the grassroots players that are out there. And it's built on her deep knowledge about the issues that are crucial to be concerned with and applying the mechanisms of connectivity and coalition building and political organizing to help bring about pretty fundamental change. I'm just so grateful that Leith could join us, could be part of this process today. And I want to invite Leith to the Zoom screen and welcome to World Health Day 2021.
Great. Thank you, Mark, so much. Hi, everyone. Welcome. Very happy to be here with Global Minnesota for World Health Day. I want to talk to you about one of the deadliest inequities that have emerged during the pandemic, and that's access to medical oxygen. So I'm going to share my screen because I have a presentation I'd like to show you very briefly. So you can see a photograph on the cover of this deck, and this for me exemplifies the pandemic and the vulnerabilities of people, particularly across the global south. This is a picture from Peru. We don't know if it's a man or a woman, but this individual is sleeping overnight, waiting in line to get oxygen. The big green cylinders are empty cylinders of oxygen, and they're all lined up in order of your place in the queue to be filled. This individual sleeping probably has a sick loved one at home who is struggling to breathe, and they're sleeping, waiting to have that tank filled. Imagine the stress and the anguish when you know someone at home is depending on oxygen and you're waiting to receive it. So I want to talk to you a little bit about the crisis in medical oxygen. This is a tool we built. Our coalition, the Every Breath Counts Coalition, built this tool to measure the daily need for oxygen across all lower middle income countries. So today, it's 15 million cubic meters of oxygen are needed just today to treat COVID-19 patients in lower middle income countries. If you translate that into cylinders, those big cylinders we just saw, that's about 2.1 million cylinders are needed every day. You can see the trend graph on the right is tracking up. That's because the cases of COVID-19 are rising in many lower middle income countries. And when the cases rise, the oxygen need rises. So we're in the middle of a surge, an oxygen surge in the poorest countries of the world, the countries who have health systems that are least able to respond to this demand. And here are the faces of the people behind those numbers. This is just a selection of some of the images we've seen this past year of the oxygen crisis. They're images of suffering, for sure. They're also images of love and determination and sheer resilience to get the job done. So I like to look at these images every day because this is why our coalition is working so hard on this issue of access to oxygen, which, by the way, is not often a topic, a priority when we're talking about COVID-19. We, of course, hear a lot about vaccines, which are critical to end the pandemic. And we've heard a lot about diagnostic tests and PPE and some medicines like dexamethasone, all very important. But what we often miss are the simple things like oxygen that we take for granted because we have them in hospitals in the US, we have them in hospitals in Europe, but we can't take for granted that oxygen is available in low middle income countries. And this is the evidence you're looking at now of what happens when there is no oxygen. Our coalition appealed to global health leaders, WHO and UNICEF and others to respond to oxygen, and to their great credit, on the 25th of February, they announced an oxygen emergency response. That's the announcement there. You have most of the major global health and development agencies now working to help low middle income countries close the gap, but we are really racing against time. There's many more deaths that will occur because of lack of access to oxygen, because we simply can't move the emergency architecture fast enough. We called today for World Health Day. Our coalition called on the US government to step into the mix here. So far, we haven't had US government leadership on access to oxygen, but we know they could do it. And we know they would make a huge difference. So today we've called on the US government to invest more in US aid, to really step up here and provide some leadership in low and middle income countries to close the oxygen gaps. What can you do to help us? We would love, we welcome partners. We're very active on social media with Invest in Oxygen and Every Breath Counts. We're very actively engaged with political representatives from all countries, not just low and middle income countries. So contact your local representatives and talk to them about oxygen. And of course, we would welcome you to join our coalition. We are an open access coalition, and the more the merrier is our motto. We need all hands on deck. And I just want to close with a story of a gentleman from Malawi, which was hit very badly with oxygen surges earlier this year. His name is Paul Masoma. He was 44 years old, one of the leading lights of Malawi, someone you would think of as a future leader, someone Malawi needs to keep alive. This is a real message that Paul wrote from his hospital bed in Malawi on January 13th. He wrote it on his Facebook page. You can read it. It's extremely sad to read, but I'm going to read it to leave you with a message from Paul. Paul wrote on the 13th, SOS, in hospital, diagnosed COVID positive. The hospital staff are so wonderful and I can see pain in their eyes. Yes, they have oxygen cylinders, but in my case, they can't connect me to the much needed oxygen because the whole hospital has no oxygen flow meter. That's the little device that measures how much oxygen is coming out of the cylinder. My situation is getting bad and I desperately need oxygen. Anyone who can urgently help out there, please, please help by donating this very gadget. Unfortunately, nobody could help Paul in time and he died 4 days later. There are many Pauls out there and we do our work to prevent these tragic stories from happening. We urge you, anyone involved in the COVID-19 response, to remember Paul's story and that often it is oxygen that is needed in many low and middle income countries, and we can't turn a blind eye to the very simple things that are often needed in low income countries. Thank you very much for the opportunity, Mark, to address your forum, and I hope we can continue to work together to close some of these egregious inequities as we come out of the pandemic. Thank you.
Lee, thank you so much, and thank you for sharing that story and reminding us of the people and the grief and the tragic loss. And all day long, we've been able to be thinking about the people, the loved ones, and all that have been impacted, but also trying to look forward. And I have to say, your calls on Mondays at 11 Central Time, noon East Coast time, with reporting in from activists at the community and national level from the whole planet is a signal of the mobilization of this new generation of people who are pushing and won't let an issue stay invisible, won't let the higher ranks of our societies forget the individuals, and also are not going to stop until they find the innovations and the political will to address this. And we'll come back to you with some questions, and I want to talk a little more about how we move our own government in that way. But thank you so much. Our next guest, Dr. Neka Söderström, is a citizen of the world that's landed in Minnesota, and we're thrilled by that. And she's the Chief Equity Officer at what we now call Hennepin Health. Some of us have always known it as Hennepin County Medical Center, HCMC. It's the large and very amazing deliverer of healthcare to much of our community, and in all ways, a very special place. And in this opportunity of thinking about World Health Day and focusing on equity, I was thrilled that Neka was able to join us. Dr. Söderström, thank you so much for being here today. And please tell us a little bit about how it came to be that there was a Chief Health Equity Officer at Hennepin Health, and your role and how you came to this important position.
Thank you, Mark, and thank you everyone for having me here today. I recently wrote an article entitled Acknowledging the Burden of Blackness, in which I outlined that by virtue of being born Black in America, one now has a pre-existing condition, and that causes suffering in many forms throughout our lives. For Black Americans, the reality of inequity begins in utero for the child. Black mothers cannot just have the usual worries around childbirth. They must also pray that they're able to survive this joyful moment and not become another statistic just because she's Black. Birth outcomes of Black expectant mothers and the high mortality rates of postpartum Black mothers tells this story all too well. We all remember the ordeal of Serena Williams, who fortunately survived, but we can also recite the names of the others who didn't. Beautiful Black mothers like Shalon Irving, Shaija Washington, and Kira Johnson. As a Black mother delivering my second child in Minnesota, where the outcomes for Black mothers are some of the worst in the nation, the emotional suffering due to increased anxiety over whether I survive my delivery and subsequent postpartum period was intense. That lack of ability to feel in control of your well-being illustrates why other Black families deal with this sadness on a day-to-day basis as they try to navigate the health systems that are founded and maintained in systemic racism. There is the everyday casual racism that causes the continued erosion of dignity, ability, and capacity. that consistent life-altering complication that occurs as a result of bearing the burdens of comorbid conditions that are all due to racism. Black Americans live with generational trauma weighing heavy on our psychological and emotional well-being. It's one of the many reasons we have lower life expectancy rates than our white counterparts. The trauma that has been imprinted on the DNA of descendants of slaves and the colorblind ideology that has been imprinted in the minds of the dominant castes affects our experiences with institutions built on white supremacy, like healthcare. The distrust of physicians in the medical establishment is not simply because of research studies gone awry, like the Tuskegee experiment, but due to the continuous trauma of anti-Black racism that is prevalent in every medical institution throughout our country. As we've seen most recently with vaccine hesitancy and inequality, the continued distrust has significant repercussions within these communities. COVID has devastated the Black community, resulting in a drop in life expectancy by more than 2 years. The suffering born of inequality is on full display, illuminating that we are far from eradicating the ever-present pandemic of 1619 while we forge on with this battle of COVID-19. To be honest, in a discussion around inequity in Black America, we must first remind ourselves what it means to be Black in America. I recently had a conversation with a colleague about creating a statement around equity and defining how we will work on it in my own institution. This colleague disregarded and disagreed with my framing of the inequity in the context of qualifiers like discrimination and poverty. Instead, he wanted me to simply state that all inequities we're facing are due directly to racism. Acknowledging the simple yet complex concept of racism is one way to truly make sustainable impact on inequity. We have to pause and appreciate the weight that comes with the identity of being Black. This is not taught in schools, though, as we become activists in this space. We must do the work, the very, very hard work, to re-educate ourselves out of the miseducation that this is still being used to teach our children. We have an opportunity to quickly rip the Band-Aid off and begin recovering. COVID-19 is the ocean we're all in. Some of us get to ride the treacherous waves in yachts, while others are barely keeping their heads above water while hanging on to pieces of debris. The ability to pretend one was not aware of inequities in the United States has come to an end. Continued ignorance is now a personal choice. I believe most of us will choose to address the injustice presented to us. I don't believe we'll go back to the days of colorblind leading the tunnel visionaries. One way this is being highlighted is in the creation of roles like mine in my institution and others across the country. Bringing together dedicated individuals to work on inequity within all the industries is an amazing first step. As long as these experts are given the resources and authority to actually demonstrate equity in action, we will move mountains. I am concerned with the figurehead positions that are just titles without support or substance, and I urge institutions to be honest in the creation of these roles. If you're not ready to truly address inequity, then don't pretend that you are. In the same vein, there are many who hold titles and do not engage in the work. If you're not an activator and a motivator of change, then step aside for someone who is. This work really requires us getting into the daily grind and getting beaten down with the rest of the world. If staying in an ivory tower and using the title to just gain personal accolades and a paycheck is the action of the leader in your current role, then I beg you to make that change. When you have effective leadership in health equity, the impact is quick and immediate. An example that I want to share is from our Hennepin Healthcare Vaccine Community Initiative. The initiative started in mid-February with the first pop-up event at a predominantly African-American church that agreed to be our pilot host for such an effort. We vaccinated 114 elders that day who were all grateful and relieved to be able to get their vaccine in a place that they trust with people who they trusted to have their best interest. Some of the typical barriers to getting the same elders to community or hospital clinics were removed by simply going to where it was easier for them to go. Since the first vaccine event, we've completed 14 events, providing almost 2,500 first dose vaccines. We have an additional 2,900 first dose scheduled throughout this month. We started our efforts by making the institutional decision to allocate doses from our own state allocation specifically for equity. We started with 500 doses earmarked each week for equity-only events. We've since grown as our allocation grows and are at 1,000 a week, and we're quickly ramping up to 2,000 a week in our allocations. We've gone from small, intimate church-level events to community organizations banding together to sponsor and support bigger events. We have several set up series of vaccine pop-ups throughout the rest of the spring and into the summer to ensure they give the people they serve the opportunity to sign up and be vaccinated within their own community. We've seen how the power of word of mouth spreads to increase trust and decrease hesitancy in some of our most at-risk communities. One vaccine event set up in a local mosque has dramatically increased the number of our Somali immigrant community members coming in to be vaccinated. Another event placed in a donated space within a close-knit Southeast Asian community yielded over 600 doses for people fearing the increase in anti-Asian racism that would not have ventured downtown to clinic to get vaccinated. We recognize the inequities that are causing our Black and Brown communities to not get vaccinated and are intentionally putting forth efforts to combat them. We talk to them, we ask them what they need from us to make this work, and then we make it happen. That's how equity in action works. This is now the time to make a lasting impact. We can't let this opportunity go to waste, and we need all hands on deck who are in it to truly win. We have seen an enormous amount of community collaboration efforts around vaccine equity. We have states making declarations that equity is a priority. And we have a federal administration that is funding efforts to specifically target eliminating racism and health inequities. This is truly the perfect storm. Now, I think I've exhausted all my boat metaphors. And so with that, I would just like to say thank you. And I'm looking forward to this conversation. Thanks, Mark.
Thank you very much. And thank you for clearly explaining what does putting into action a strategy, a tactic, a very specific way to tackle one of the critical issues facing us right in front of our eyes, right here in our home county. Thank you so much for that. Our third panelist joining us today, Sister Carol Keehan, heads the Health Task Force of Vatican's COVID-19 Commission, which was established by Pope Francis last March. I don't know if you follow Pope Francis, but he's been on our big holidays and big religious days, Christmas, Easter, calling on the international community to look at the inequities, to get the vaccines being delivered and get the global situation really moving ahead. And so this commission is one of the vehicles for that message getting out. Sister Carol was the former CEO of Catholic Health Association, which is the association of the different Catholic health institutions around the country, and been a real powerful leading voice in discussing ways and advocating ways out loud that we can end the disparities and inequalities in our healthcare system. Sister Carol, thank you so much for joining us today, and please join us on the Zoom and give us a background and think about where that commission is headed and what your role is in bringing this new powerful voice into the international movement to deal with health equity. You're still muted.
I thought someone had pulled me off. Thank you. And thanks very much for the invitation to be with you today. I'm honored to be here and grateful for your focus on preparedness and health equity. The people of Minnesota have such a reputation for looking at situations in a comprehensive and far-sighted way. Given our situation today with this pandemic, we can certainly use your help. There are so many lessons to be learned clinically, ethically, politically, but I think the paramount issue is the importance of honest transparency. This pandemic has been made so much more serious and devastating by multiple failures in all these areas. But the overarching one has been the inability for individuals, corporations, and nations to work together in an honest and transparent way. Early last year, Pope Francis saw this coming and asked himself what the church could contribute. He could foresee the impact on everyone in the areas of economy, ecology, security, and health itself. And is so typical of him, he was concerned about the serious harm on everyone. But most especially, he could see that it would impact most severely on people who were poor. And that poverty could be to economics, race, refugee status, trafficked status. immigrant status, or a combination of any of these poverties. Pope Francis clearly saw the pandemic as a global problem and wanted to see us deal with it as a global family. He wrote an entire encyclical on our need to live in solidarity with each other, not warring, undermining each other, politicizing every choice, whether it is trade, world organizations' efforts, ecology, the economy. In his encyclical letter, he wrote, "As I was writing this letter, the COVID-19 pandemic unexpectedly erupted, exposing our false securities. Aside from different ways that various countries responded to the crisis, their inability to work together became quite evident. For all our hyperconductivity, we witnessed a fragmentation that made it more difficult to resolve problems that affect us all. Anyone who thinks that the only lesson to be learned was the need to improve what we were already doing or to refine existing systems and regulations is denying reality." The Pope wrote about the many challenging issues, but he also wrote about the need to discuss many new paths of hope. He said, "I invite everyone to renewed hope, for hope speaks to us of something deeply rooted in every heart, independently of our circumstances and historical conditioning. Hope speaks to us of a thirst and aspiration, of a longing for a life of fulfillment, a desire to achieve great things, things that will fill our heart and lift our spirit to lofty realities like truth, goodness and beauty, justice and love." With this in mind, Pope Francis formed the COVID Commission with 4 task forces, one of which is health, and I chair that task force. Our initial approach has been a laser focus on 2 issues: equitable distribution of the vaccine and treatments, and secondly, reducing the resistance to taking the vaccine. We are clearly aware of the many other areas and issues that need to be addressed and learned from our experience, such as preparedness and communications, and certainly we still have to deal with the many unknowns of the post-COVID health issues. There have been many wonderful choices made, as well as the poor ones that we all know about. One of these, in my opinion, was clearly establishing the COVAX system for aggregating money and vaccines to be distributed in an organized fashion to nations not able to purchase their own vaccines. As our task force looked at how the church could be most helpful, we listened to many groups: political, clinical, research people, pharmaceutical groups, NGOs and Catholic groups, religious communities of many faiths in many countries. It was clear to me at first from my time in Catholic healthcare that the one issue that would resurface was the questions of how vaccines were made and or tested. The use of stem cells grown in a lab from tissue originally taken from a fetus aborted many decades ago, I knew would resurface, even though the church has repeatedly addressed this issue, saying that it's perfectly morally acceptable to use these vaccines and that one is not cooperating with or promoting abortions in doing so. I also knew that while we waited for a vaccine, or hopefully lots of vaccines, that cost and portability were going to be a big factor in the choices made by COVAX and others on which vaccines to buy and distribute. We have focused our efforts on advocacy for early action to provide those vaccines to countries who cannot afford them. We have looked at and worked with countries and groups to deal with readiness to distribute the vaccines. We've also have developed ways to use the special strengths of the church to help with reducing the resistance to taking those vaccines. One major project to come out of our task force has been a resource kit in multiple languages and dialects to do a number of things. In it are the clear teachings of the church to help those who have a concern, and they are many, about the connection with an abortion decades ago. We also use the words of Pope Francis, assuring them that it is a moral action and a moral duty to be vaccinated for their own health as well as the health of their family and their communities. We developed in a question and answer format a clinical and ethical guide to vaccines and treatments. This guide is designed for bishops, priests, leaders of health treatment facilities, social service centers, and schools. We also gave many sample homilies for priests to use to help encourage their parishioners to take the vaccine. It also has several credible websites for them to use to access more information. One important thing that we developed is a family guide to COVID and vaccines. It is in a question and answer format that can be easily reprinted and given out in churches, in clinics, in schools, in social service centers. It can be posted on websites and in other social media. We have translated this resource kit into many languages and are working in some countries to translate the family guide into dialects. We're working also with the diplomats accredited to the Holy See and other government agencies, as well as the WHO and other NGOs, to utilize the vast network in many poor countries of sisters, priests, and Catholic lay organizations who have the trust of the people to promote vaccination, as well as to actually do the vaccinations in many of their facilities. One of the most senior scientists said to me, "Sister, you can put the brightest scientist or the most senior government administrator in front of people, and they will not pay attention. Many of these people will have to have someone who's been with them before COVID, will be with them during COVID, and will be with them after COVID. And in many instances, that is the church." We now have a choice in vaccines as well as good scientific evidence of efficacy and safety. We also have a high percentage of people who still refuse to take the vaccine for many reasons. It is imperative that we help them find reliable options for assuring they are getting good and safe vaccines and understanding the importance of getting them. Often there are exceptionally good reasons for their skepticism. Helping to assure a reliable infrastructure and combating counterfeit and fraudulent vaccines is a critical step. Working closely with groups who have the trust of the local people because of their history with them is essential. Additionally, our hope is that this work will help us create networks and connections that will enable rapid sharing of information and assistance as we learn more about this treacherous disease and ways to protect ourselves against it. Thank you very much, and I look forward to your questions.
Thank you, Sister Carol. And I was struck how all of you talked about really the pre-existing condition of inequity, how the pandemic, basically brought this into a broader spotlight, and it brought some new players into the system. But the important point I heard was it's not automatic. It's not just going to fall from the sky. It's not going to be just because we wish that this situation creates a better future. We have to say out loud, that's the future we want. We have to then organize ourselves, whether it's a global coalition, or organizing within the church, or organizing within the institution like Hennepin Health. There are different ways, but we have to have an intention. I wonder if any of you or all of you would like to comment on where you see that intersection of intention that gives you twice the power because you're able to connect and partner with another powerful force heading in the same direction that you are.
I will start with an answer. I believe that the only way to move this massive amount of work is to partner with others who have the same dedication, the same vision and goal, and the same willingness to do what it takes to really make a difference. And through that partnership comes the intentionality. You can't just decide to go into a community and bring in a community initiative and assume that the community is going to embrace it and be fine. What has to happen is you have to be humble enough to understand that you're the voice of reason in that community. You may have an answer that you think works, but that doesn't necessarily mean that that community agrees. You have to find the people who have already been there, who have already been doing things, who have the trust, who have the reputation, and have the report card from the community that says, we agree with the way you do things, and if you say it's okay, then it's okay. And gaining that partnership allows you to be more intentional and deliberate in how you increase your programming. Because you may have thought that an initiative would have worked, but that is not the initiative that actually would work. And being able to say, I may not know the answer to this, even though I think I know the answer. And, hospitals and big healthcare systems are always assuming we know how to better take care of others. But taking the time to truly and honestly look at what's an intentional, deliberate, and effective intervention with a community requires a partnership. And I think that having roles like mine as a chief health equity officer allows for institutions to say, we may not know the answer, but we know that we're going to trust somebody who's going to help us find that.
And how'd you get into the partnership with the first church for your first pop-up?
I honestly Googled and then just called and asked.
Okay.
It was as simple
There's
as
a
that.
great answer. I'm going to write that down. We're going to put a quotation. That's fabulous.
Yeah, it was a very simple, very easy conversation. The Pastor McDavid, it was at Fellowship Missionary Baptist Church here in North Minneapolis. I called him and I said, we really, really would like to figure out a way to partner to provide vaccines for your congregation and the elders in your community. How could we make that happen? And he said, I will put you in touch with my program manager and we can make this happen. And they did the heavy lift. They contacted the parishioners. They created frequently asked question handouts, and they put them on their social media. They had physicians who were part of their congregation do little videos on addressing some of the questions that have been coming up. They used their van to go pick up people and bring them to the site. They set up a rotation in their building that allowed for safety and ability to rest for the 15 minutes and be watched, and social distancing. And they were sanitizing. They had a nurse who was a retired nurse of the congregation, and she was in charge of ensuring everything was sanitized and everybody had hand sanitizer. She was very focused in her job. You couldn't walk anywhere in that
Talk
building.
about superheroes here.
Yes.
We're talking about superheroes.
And they did all the organization. We literally just came and gave shots. And it was that kind of partnership that they needed. They didn't need us to control it. They just needed us to be available.
But they also needed you to contact them.
Yes.
And so this is really critical. Leith.
Yes. I am a huge believer in working in coalitions. So obviously, because the Every Breath Counts Coalition has 50 members and a much wider network. And I'm a huge fan of bringing unlikely friends together. So the kinds of groups that would not normally be in a coalition together, nothing gives me more pleasure than seeing them seated around the same table, having to really come to a middle ground. So in the coalition, we have the wealthiest multinational company right through to the smallest NGO based in rural Africa. And we force the two to look at the world through each other's eyes. But, we have a total bias. We always try and have the voice of the most powerless person around the table dominate. So although you're listening to everyone, you're forcing everyone to confront the inequity by listening to the voices of the people who are, facing the ugliest side of life. And only by creating a platform where you force those conversations, I think, can you truly get real action. A great problem of our time. It's one of the unfortunate side effects of the deep inequality we all live in every country. We live in deep inequality now. We don't talk to each other. We have very few opportunities to sit around the table, whether it's virtual or real, and truly confront each other civilly, but always trying to have the voice of the most powerless person dominate the room.
Thank you. Neka. you put that coalition together, and it was with a church in that instance. Sister Carol is talking big picture about connecting to the churches. It seems like there were the things that you described are part of that community that's before, during, and after COVID or whatever the experience. I'm wondering if Sister Carol, did that specific example resonate with what you have found in your organizing work? And are there elements of how that might be woven together for a more powerful, bigger coalition?
You know, that's exactly what we are trying to do on a global level, going through the many of the religious communities and many of the organizations like Catholic Relief Services, as well as working with WHO and working with COVAX, Gavi, and then unlikely partners, as Leith pointed out. We have a meeting frequently with the International Association of Pharmaceutical Manufacturers. You know, they're people that are often maligned for only being interested in money, et cetera, et cetera. But we've had very good conversations, and they've done some wonderful things to help the situation, and to advance particularly trust and reasonableness in portability and vaccines and things like that. So yes, I think that's it. We have some good models of that globally in some of the African countries, with a group of lay Catholics and the Daughters of Charity, which is the religious community that I belong to, which is a worldwide community. And they have about 15 or 20 years now of experience in maternal infant transmission of HIV in African countries. And because of listening to the people, as Nika talks about, and because of dealing with their real issues, they have a 99% effectiveness in preventing maternal infant transmission of HIV. But it is with a lot of humbly holding people's hands, humbly listening to what their issues are, humbly trying to help them with their issues, that people, you know, and a real concern of the issue that might not be the hospital issue, you know, your medicine. Well, that's fine, that's important. But if you don't have clean water, or you don't have food, and so it is really important, I think, to do the listening and to do the partnering and to be open to anybody of goodwill, because people, I'm really amazed at how many people there are of great goodwill who want to help, and to want to help you in the mission you have.
And this desire, the human nature of humanitarianism or empathy, or you know, feeling a connection and wanting to find a way. It seems like COVID has presented some barriers, of course, because of all the elements. But COVID has also really helped move us to a place of saying, you know, if we're not all okay, none of us are going to be okay. Now, this is another way of thinking about climate. If we don't quit destroying our climate in the way we are, I mean, this will affect, and it will affect people differently. But this coronavirus has really been kind of global. I wonder if the analogy of preparedness, you know, as a portion of getting to some of the inequities that will be exacerbated if we're not prepared, if the new discussion about the treaty, the possible treaty about pandemic preparedness and response, or the idea of a decade of United Nations decade for pandemic preparedness, do any of these resonate as tools that could be used in the broader kind of mobilization of the public and in the creation of truly innovative and truly successful partnerships?
I would say yes, very, very definitely. I don't know what's the best way to go at it, whether it's that treaty or something else, but we have to go at it because we were woefully underprepared. And we are among the richest, one of the richest nations in the world. I mean, when you think about people saying, well, we couldn't do the tests because we didn't have cotton swabs, you think about the number of nurses and physicians and auxiliary staff in our hospitals who did not have enough personal protective equipment. I mean, that's not, building a rocket. That is very simple things. And I think it's just really clear that in many ways we had just cut corners, and you can pass on a curve and get away with it sometime. You pass on enough curves and you're gonna have an accident. And I think that's what happened to us.
I would agree with Sister Carol, and I would add that especially for like the United States, we can't jump into global treaties like this and pandemic preparedness if we haven't done the work ourselves to just get our own house taken care of. The inequities that were highlighted with COVID, many felt were like that this was a surprise, and that in of itself is a problem that we have to face. This is not a surprise. Inequities are not new. They've been here and they've been part of the fabric of our being since we started as a country. And if we don't take the time and energy to address those, then we're not going to be able to be a good resource to other people in the world in trying to help. We can't say that we could help them deal with their inequities and then turn a blind eye to our own. So I think that some version of a treaty makes sense, but what I would hope is that if our country and others decide to sign on, that we all take the responsibility of making sure that our own inequities are being treated as we build this global coalition to prepare for another event coming in the future.
Amen.
Yeah, let me just add a few thoughts. So I think coming out of the pandemic, we're going to be asking a lot of questions about the United Nations and the international architecture, because it's not fit for purpose in a world where climate change and pandemics, I think, will continue to occur. This is like we've had a taste, I think, of the world to come. And the international global health agencies are just not where they need to be to respond effectively. So I think we need a whole reassessment of the system that was built after World War II, another tragedy. It served us quite well in the decades after World War II, but it is not serving us well with the current threats. So I'm hoping for a conversation about a radically different UN, like a UN 2.0, that has the full support of all of the major countries, but that has new institutions. The World Health Organization has many flaws. It really has its hands tied. We need to untie those hands and have international agencies that can truly act quickly and also hold countries to account. So we're entering a phase, I think, where national governments will need to come to some understanding that we need powerful international institutions and that maybe they won't dominate. National governments can't always dominate in specific sectors like health.
We had a very interesting panel and then a presentation with former Prime Minister Helen Clark from New Zealand. And once she was Prime Minister, they upgraded and prepared their pneumonia or their influenza pandemic plan, which they had in place, and they were able to respond. And we know New Zealand's had a good effect. But she will be bringing forth, as the leader of the independent panel on preparedness and response to the World Health Assembly, I think ideas and suggestions that are somewhat along these lines, Leith, and just in terms of thinking, what do we need to have in place to go forward? And I'm reminded that it takes some kind of a crisis or some kind of a shocking event to get us to move. I mean, even Mayo Clinic came out of a terrible tornado where the nuns, the sisters who provided the care and the Mayo father and the two sons who were part of the care, the sister said, listen, we've had this gigantic tornado and 100 people killed and many people injured. We gotta be prepared. We gotta have a real hospital. And at first, Dr. Mayo said, no, that's not what we do. But the Mother Superior insisted. They made it happen. And today we have Mayo Clinic, but it took a tornado that killed many, many people to then precipitate that kind of thinking. And we've had an unbelievable impact of this COVID. So we're trying to harness it to make the changes, especially around inequality and disparity. And that's our purpose going forward. Would each of you like to take part of this last few minutes and give our audience from around the world some wisdom and advice about the ways that they can think about how to be the best kind of partner with others to then maximize and multiply their power to make change?
I guess I'll go first. I would say that I think we all have to just take inventory on where we are, figure out the things that are the simple low-hanging fruit that can be quick wins to help with getting the momentum built. I think we have to trust that people are in this for the right reasons. I think we have to give people some grace when they're not aware of the mistakes that they may be making or as they stumble in this work. And I believe that coalitions and partnerships are the way to move things forward. And without that, we're not going to. I think the COVID-19 experience has helped us all see that even when it seems like the world is coming to an end, we can still pull together and make it through. And we can make it through better than where we started. And we can do things that we never thought were possible, like work from home with 5 children running around and a dog and a cat in the background, right? Like we can make things happen in the most uncomfortable situations and still come out on top. Facing inequity is the most uncomfortable situation. And we can work on making differences and coming out on top when we put together our minds and our resources and the intent and partner with the community. There's nothing that could stop us in actually making a difference and moving forward. So I am fully prepared and excited and can't wait to see what happens. This day has been a great day, and I've been listening on and off throughout the day with some of the most amazing speakers. And I'm really excited that the World Health Organization has outlined health equity as the focus and the strategy. And I think that this is the time, this is the moment for us to look back on 10 years and go, that was it. That was the catalyst that got us to now where we are. All this low-hanging fruit that we didn't even know was there that has been settled, has been addressed, and people feel the movement and can now tackle some of the bigger, more heavier lifts because those easy things are knocked off, and we can see that we can make progress. And I think that this is the moment for us to shine, and I'm really excited to be part of it.
Thank you.
You know, one of the things I certainly agree with Dr. Yugat, and I think she made a number of wonderful points. We have a lot to do. This is a big problem, and we don't have the best political environment, and we don't have, for us as a country, we have some real challenges. Never mind the challenges that we see in so many other countries. But I think it is really important as we try to look honestly at what went right, what went wrong, what needs to be fixed, that we need to take comfort in the fact that you eat an elephant one bite at a time, and we can do it better together, and we can enjoy doing it more together. And I do think it is a time that while we have a lot of things we need to fix, a lot of things we need to repair, a lot of things we need to build anew. We can not only do it together, but we can enjoy doing it together, and we can become closer. We can solve many issues as we work together on this issue that we think, oh, I didn't realize how talented that person was. I didn't realize the resources. I didn't realize. And suddenly we've moved to much more of resolving this really serious global problem as a global family. And that would be an incredible, incredible step forward.
I would add advice to those building coalitions to identify the most powerless person and build the effort around that individual. And if you're making a demonstrable difference in the life of that individual, you're on the right track. So for us in Peru or Bangladesh or Zambia with COVID, and there's no proper treatment, and that person will probably die because there are not simple things like oxygen, PPE, and other healthcare. If we're not helping that person, we shouldn't be doing what we're doing. So that would be my advice to anyone working in COVID at the moment, is build, or any area really of social justice, build your effort around the person who has the least power and elevate that person. I like my colleagues, I'm enormously optimistic, even though we've had the most horrendous year, really, everyone in the world. I'm enormously optimistic because of the way the human race tends to rebound after tragedy. We always come out of these episodes with a great period of creativity, innovation, a desire to cooperate rather than compete, and to move ourselves one big step forward. So I'm actually, after we get the vaccines will come, this pandemic will be behind us, I'm looking forward to that next decade when I think we have a window to truly transform institutions, the way we relate to each other on race, gender, you name it, all the things that have divided us in the past. This is going to be our big moment this next decade. So I'm very excited to get there, Mark. We need to get all of this behind us so we can get to that spot. And I know Global Minnesota will be right there in the middle of it. So thank you.
Well, thank you so much, and amen to all of that. And what I love is that now we have this hour-long recording. And so when I want to get my inspiration pumped up, I know where to look. When I have friends in Asia who are in bed asleep right now and aren't able to watch us, I could say, you've got to go watch this amazing panel. All of you in your life's work, you are changing the planet and saving lives. But in explaining and taking time today to really talk and to be public and talk about how it is you approach your work, you've given a roadmap and the inspiration to get people into this movement. And Leith, I think that next decade is going to be really, really something. But of course, we're all going to have to put our shoulders to the wheel and make it happen. Neka told us about, if you're not ready to lead, get out of the way. And Sister Carol talked about, really building out from the bottom up how we do our work. These are the elements of that partnership, that multiplying our power that we've been able to see, and our guests that are watching today have been able to really receive as a gift of treasure from all of you. Thank you all so much, and I look forward to all the things we'll get to do together, working to get us to a new place, but working to make that new place a different place, a better place, a place that is for the future. Thank you again, and goodbye.
Thank you, Mark. Thank you, everyone. Bye-bye.
Thank you, Mark.
Hello, everyone, and welcome back to International Setting, our Symposium on World Health Day 2021. My name is Mark Ritchie, and I have the honor of serving as President of Global Minnesota and your host for today's special symposium. Some of you have been watching since this morning. Some are just joining us now. We've been looking at a global level and at a tactical level of all kinds of ways that people are tackling the question of health equity and health equality. This particular panel is very special because we're going to be hearing from four of the people who've been thinking deeply about the social and economic benefits of health equity. Sometimes people think of these issues in dollar and cents terms, and we're going to really take a much bigger picture here because, in fact, we've come to the conclusion globally, not every single person, but as a planet, there's a sense that we now are saying out loud, we cannot all be safe from this pandemic until we're all safe. We can't be vaccinating part of the world and not another part of the world and be staying ahead of the variants who could take us back to day one. Those inequities between countries, within countries, those inequities that come from, not enough vaccine in one place or another or other issues, these are some of the components of this discussion. But this specific panel today, we're going to be joined by some of the people who've been thinking the most deeply and in the most dramatic way about how the social and economic benefits of health equity can be understood in the broader society and really bring about greater change. Phyllis Costanza heads the Union Bank of Switzerland, their Optimus Foundation. She opened my eyes to the ways that new financial tools that were linked to the Sustainable Development Goals could be used to bring about the possibility of social change and economic change and educational change, linking the role of women and the educational opportunities of girls in the changes around health. And Phyllis Costanza's visionary work on social bonds has been translated many ways into many different features. We are just so fortunate and grateful to have you join us today, Phyllis, to give a picture of how those social bonds have worked, how you've come to see the linkages of the social and economic benefits of equity and equality in general, and especially in the area of health. Thank you again, and please join us on the web.
Great. Well, thank you so much for having me. It's an honor to be here. And to put this into context, I'll first explain where I sit. And as Mark said, I'm at UBS, which is a large global wealth manager based in Switzerland, but we have clients globally. And we service some of the wealthiest people in the world, and many of them, most of them, in fact, want to give back to society. And so we have a whole team, a philanthropy services team around the globe, about 60 people, helping clients do that. And we do that in three ways. One is we offer them advice. The second one is we give them insights, experiences. We panels such as this, where they can open their eyes to new ways to provide healthcare to some of the most marginalized. And then finally, we have an execution platform. And that's the Optimus Foundation and some donor advised funds, where we actually help our clients to give their money away and we help manage it for them. And we have been focused overall on areas of children's health, education, child protection, and we've recently added also climate. And the reason we focus in these areas is because our clients care about these areas. And when we ask our clients if they're actually satisfied with their giving, and let me caveat this, about 90% of them, more than 90% of them are giving philanthropically, only 20% said they were satisfied with their impact. So we're trying to find ways to help our clients have genuine impact serving these communities. And we, our goal really is trying to say it crassly, is bringing the ultra high net worth down to the ultra low net worth, and trying to find ways to connect them that is meaningful and beneficial. And right now we know that we have we're about $2.5 trillion short every single year to achieve the Sustainable Development Goals. And we're here talking about SDG 3, and we won't get there with philanthropy alone. Philanthropy alone accounts for about $1.5 trillion annually. And so even if everybody put their money into the SDGs, we still wouldn't get there. And the private markets don't focus on the most vulnerable in communities. People who are investing in markets don't see opportunities to invest in healthcare and education for the poorest in communities. And we've seen commercial capital has generally not been invested in things like development. But there is an estimate of about $280 trillion in household wealth, 80 million of which is discretionary and can be invested. And so we believe that innovative social finance can make investments in development much more attractive for commercial capital. And so we focus on what we call social finance, and that is laser focused on impact. And it really addresses some skepticism we see around things like impact investing or sustainable investing, where the impact can be nebulous. I mean, people may say, yes, we're financing a cybersecurity firm. And this, of course, is good because nobody's going to break into people's computers. That is good, and it is providing a valuable service. It is not, however, focusing on the most marginalized, mostly in its work. Those usually aren't the beneficiaries, and those are the beneficiaries that we want to target with commercial capital. So this type of social finance is niche indeed, but it's growing. And we actually, and when we talk about social finance, we're talking about concessional capital. So we're not always achieving the type of risk return profile you might see, say, in private equity, where one might expect a 15 to 25% return. And we're investing in some risky communities. And so we would expect to see a large return, and we may only be getting an 8% return. So the good news is it's not correlated with the markets, but it's also, it's not without its risks. And many people for that kind of money think that they for those types of investments, think they should get a higher return. But when we interviewed our clients, a third of them said that they would be willing to compromise on returns if they were guaranteed impact or if the impact was higher. So that is really encouraging to us. And those are the people that we're targeting right now. And so far, we've applied this approach to two models. One is called impact loans, and the other one is development impact bonds. I'll give a quick example of what an impact loan is. And again, the returns in these mechanisms are tied directly to impact. So the higher the social impact, the higher the return. And this is contrary to the way social bonds work. If you look at social environmental bonds, if they achieve the environmental outcomes, the investor actually gets a lower return because it's benefiting the person who's taken out the loan, and they're incentivized to reduce environmental impact because they pay back less, but the investor gets less money. So this is actually the opposite of that, where investors will get more money if the return is higher. And so the way that works is, I'll give you one example. We invested in a company called Impact Water. They're providing clean water solutions to low-cost private schools in Uganda. And this is a health intervention. We know that when never more so than now, we know that when children and people wash their hands with clean water and soap and they drink clean water, that they're less likely to be sick, therefore more likely to be at school. They'll be absent less. So we gave a loan of $500,000 to Impact Water and said, the goal though is not just to get those clean water systems into the schools, but the goal is to make sure that the children and the teachers know how to use that clean water and wash their hands with clean water and soap so that attendance rates go up. So as attendance rates go up, the interest rate on the loan goes down, But we don't get, as the investors, we don't get less money because Rockefeller Foundation is playing the role of an outcome funder, and they'll pay back the investors plus give a bonus to Impact Water because they're achieving not just the operational outcomes of getting that water solution into the school, but also important health benefits of making sure that the children are healthier. And that's an example of an impact loan. And so far with this one, the interest rate was set at about 5%. And right now, the interest rate, I think the actual interest rate that they're paying is close to 2%. And we've gotten so far a return of about 7%. So far they're achieving these stretch goals of health outcomes. And then the last example I'll share with you is development impact bonds. And I'll give you an example. Mark mentioned one that we did on education, but we're also doing one in healthcare in Rajasthan, India, improving the quality of low-cost private healthcare facilities. And we are investing, our clients are investing in this, and they're primarily serving poor people in communities. And the outcome funders, so the people paying for the outcomes, are partners like Merck for Mothers, Dell, and no, I'm sorry, Dell's not in that one, and USAID. So Merck for Mothers and USAID are paying for the outcomes. And as these facilities get accredited within India, and they have to abide by the government accreditation, which improves the quality, then the outcome funders will make a payment to the investors. So the incentive is for these healthcare facilities to actually achieve these quality standards, which we know is directly linked to improvements in healthcare quality. So I'll stop there. Those are just a couple of examples of how we're trying to bring more capital and get our clients engaged in actually delivering measurable outcomes in healthcare for some of the most marginalized communities.
Fabulous. Thank you so much. And our next panelist is thinking into some similar notions, but Efe Ukala was the founder of Impact Her, and that organization supports women entrepreneurs in East and West Africa. And she's been developing business models based on surveying the African women entrepreneurs during COVID. What were the impacts? What were the things that were needed for those businesses to be able to come back and come back better and stronger, and creating the kind of service model around it. But some of those entrepreneurs were providing healthcare services and mental health services. And Efe's been figuring out very creative ways to deal with the way the pandemic is impacting those women entrepreneurs, but tying it to making for a brighter future for all of them. Efe, so grateful that you could join us today, and please join us here in the Zoom conversation.
Thank you so much, Mark. It's such a pleasure to be here. And it's also great to meet the rest of the panelists. So with this segment, I'm gonna focus more on the mental health piece, as you mentioned. I think COVID made it very apparent that, you know, Africa's healthcare infrastructure was further behind than we hoped it was, in that, you know, lots of people that naturally would have traveled abroad for their healthcare services or to get healthcare attention were forced to stay in the country. And as a result, you know, a lot of them, you know, started complaining about the state of the healthcare infrastructure in the country. But what people weren't talking about as loudly as they were talking about on the healthcare part was the mental health part, which is not something that is highly discussed or a very socially acceptable topic to talk about culturally in the African space, right? Because, you know, when people talk about mental health sometimes or feeling stressed, you know, response could be, oh yeah, but you're a strong woman or you're a strong man, you should be able to handle everything life throws at you. So the accommodation is not quite there for you to really explore deeper. But as COVID struck, and a lot of the women-led businesses that Impact Her was working with were beginning to dwindle down, and we could tell that this was taking a toll on the women. we decided to conduct a survey, first of all, to understand how were African women-led businesses doing during the pandemic, and how were the women also managing. Um, the survey revealed, and it was across 30 African countries. So and the respondents were about 1,300 from 30 African countries. The result revealed that at about 56% of them were already exhibiting sort of mental health stress associated with, their business resiliency plan, the business running, and also things going on at home. And to put things in context, in the African home, the woman is sort of like the glue in the family. She's the one that makes sure that the grandma is okay, the mother, the kids, the relatives are all okay. So against that backdrop, given that very sensitive position she holds, and also given that, there were the results of the survey were already showing that, those women were already being impacted mentally by the stress associated with, their businesses looking like it was failing, family members passing away, and also trying to care for their workers. Given that, that became very apparent, we had to sort of go back to the drawing board to figure out how to help tackle this. Because again, it appeared as though it was that sort of, other pandemic that people weren't talking loudly about. So for starters, we had a group counseling session just to get a feel of, what people were really feeling, besides the survey results, besides what they had written out, besides what we were reading. And that group's counseling session was very revealing and also encouraging. You had people that were talking about the fact that they had lost loved ones and there was nowhere for them to let it out. They still had to sort of, act as strong so that other members of the family do not break down, seeing them break down, and they had to sort of have this false face going in to appear to be stronger than they were really feeling. Obviously, these are extremely impressive women, very strong women. So after that, we had a couple of those, and then we had to seek out ways to ensure that, those women are able to get the help that they need without being ashamed, right? Because if you are getting on a bus and going to a doctor's office, and then rather than going to maybe the GP, you're now going to a therapist, right? People that could raise eyebrows. So as a result of trying to make sure that we were giving them a service in a way that made them feel safe, right? So creating that safe space for them. We recently started offering the mental health piece through telemedicine. So this is where a woman, as long as she's a businesswoman, anywhere in Africa, running a business, feels that she wants to talk to someone about maybe the stress of the day, or maybe it's worse than that, or she just, needs someone to guide her through something that she considers severe. She can do it from the privacy of her home. She can do it from a locked bedroom without anyone knowing that, she's calling a therapist or she needs that mental health piece. The way we looked at it was that obviously there are all these therapists out there on the continent, but having everyone there doesn't necessarily mean access, because if you're not really providing the solution in a way that makes someone feel safe, that person can actually really tap into it and utilize it, then we're not really talking, we can't really talk about equity there if, that ability to use it is missing. So that is how we're hoping. It's still in the early days. We're hoping to tackle this. And obviously from the backdrop that, I think according to the Financial Times, mental health will cost the world about 16 trillion by 2030. That is also something to sort of pause and think about. How many people are not able to function at their full capacity because they don't have the right support that they need, or because they're feeling down and they call out, or we have people that are, taking it as far as harming themselves. So that is something we're hoping to solve. And that is something that we're hoping that with telemedicine and just having a phone, that the lady can call in the ladies that need help can call in, or they can use an app. They feel safe and able to get the help they need, because ultimately that would transform into healthier business women running successful businesses that can also trickle into the economy and allowing, for positive growth all around.
Thank you, Efe. Thank you very much. And it's exciting to see the whole network that you've built up throughout Africa and the way that this network is now helping each other. And, that's part of the social value, but it's also part of the long-term economic, as you were pointing out, the economic benefits of every step we take towards equity. Our next panel member, Dr. Aza Karam, serves as the Secretary General of Religions for Peace International. So this is the largest coalition on the planet of different religious tradition. And part of that work in her life has been serving as senior advisor on culture at the United Nations Population Fund, chair of the UN's Interagency Task Force on Religion Development. She's really seen in her work and in her life the understanding of the cost of inequities and inequality, and the many benefits of bringing equity, equality, tackling and addressing disparities directly into our work. Dr. Karam, thank you so much for joining us today.
Thank you very much for the opportunity to be with you here. And I am so incredibly impressed with what I've heard from Phyllis and Efe. I don't think I can quite follow in that particular amazement, but I just wanted to share a couple of things from where I am, because this theme is extremely important for all of us and for a future for us to share. Let me just share that with Religions for Peace is basically all the religious institutions of the world coming together. They come together at the global level. That's my board. I have over 100 religious leaders, each representing the different religious and faith communities around the world. So it's not just, there's no individuals. They're all representing institutions and communities. And then we also have them at the regional level. So they come together at the regional level, representing their religious institutions and communities regionally, and nationally. We have approximately 90 interreligious councils around the world. Now, the question often within these kinds of spaces is, what on earth do these people do when they come together? And is it just a sort of a talking shop? Isn't it, how nice do they do anything? And the truth of the matter is twofold. One is these religious leaders have been coming together, yes, congregating and conversing about common issues for 50 years, but they've not just stopped at coming and speaking with one another and coming up with a joint voice as the voice of the communities of faith around the world, but they've also been serving together in different countries, different issues of priority for these different countries. So when the HIV and AIDS crises hit the whole world, these communities came together and served very powerfully. And very few people know that largely 30 to 50% of the world's basic healthcare, basic primary healthcare is being provided through religious institutions. Very few people know that this incredible amount, that's more than a quarter of the world's basic primary health care, is being provided through religious institutions. Few people know that 80% of the world, people in the world, will claim an affiliation to a particular religious tradition. That's 8 out of 10 people are religious in some way, shape, or form. And when we talk about healthcare services, primary healthcare services, that means that a good quarter in every nation in the world are being provided through religious organizations. So that's a very powerful block of voices of existence and of service providers. And it's important for us to keep that in mind when we're starting to talk about the value of equity, because what these religious institutions do, who together actually respectively control more than a quarter of healthcare around the world, what they do is they don't discriminate based on, well, if it's a Muslim entity, well, you can't come in if you're not a Muslim, or you can't be served if you're not a Christian, or they don't do that. They actually serve all communities, regardless of their religious affiliation. So if we're talking about healthcare providers, these communities are absolutely integral to what we mean when we talk about the value and the enactment of actual equity of service, right? These guys have a role to play in not just actually defining and realizing equity of service, but in actually being able to tell us what it is that's impeding some of these issues of access, applicability, and value. if we speak about who amongst us has a remarkable base of power on Fridays, Saturdays, Sundays, Mondays, Tuesdays, they actually speak to millions of people around the world, because millions will tune in to speak to them now that many of them cannot go to the different religious synagogues or mosques or churches. They actually tune in. So together every day of the week, these are the first and most impactful influencers on people's behaviors and attitudes everywhere in the world. That includes the attitudes of those who are, for whatever reason, seeing profit only gain in their horizon and acting based on that. So this, even if we were to decide to overlook the power of the spaces and outreach and influence that these religions can provide and these religious institutions actually provide, even if we were to overlook that, we cannot overlook the role that they play in influencing and impacting on the accountability of decision makers, political, financial, economic, cultural. These are the conscience, right? So they're the public conscience and they're the health service providers. And they are essentially the people who can first identify where inequities are hurting most, because the ethos of all of them is that they have to serve the most vulnerable. So their ethos is actually the motto of the Sustainable Development Goals agenda, which is leave no one behind. Every single faith tradition demands service, and every single faith institution is obligated and has over centuries, long before we had hospitals and ministries and states, every single faith institution is obligated to serve the most vulnerable. Now, whether they do that or not is another issue. But one of the things that we noticed when the COVID pandemic hit, first of all, there's plenty of knowledge within these religious institutions of how they are already and how to serve as the frontline service providers. Because remember, I said they control at least 30% of basic healthcare around the world. So whether they liked it or not, and nobody really had the choice, these people were on the front lines. These religious institutions were on the front lines. Those, if any of our listeners know, here in New York, one such religious institution even set up an ICU unit tent in Central Park in New York City. So hello, we think that they don't exist. They very much exist, and they're serving way above and beyond the capacities because the needs are so high. One of the things we realized was that they're serving independently. So these massive networks of healthcare providers, these massive networks of emergency responders were all serving at 110%, but they were serving separately. So the whole principle of working to serve together was pretty much endangered, if you will. So an endangered species out of all of this is that we suddenly realize that it's not lack of service, but it is lack of the incentive to work together. Now, a lot of people tell me, well, why is that necessary? As long as they're able to save lives, why should it matter that they work together or not? It matters because we're sending another message of equity and justice through how we serve. And the message, subliminal in some cases, but still pretty impactful in all cases, is that when religious communities work together, when religious institutions are able to work together, we're not just talking about coordination, we're talking about the message being sent to our societies, which we heard Phyllis and Efe speak about very beautifully, which is the social dislocation that is happening in our societies. That where we talk about contexts where these institutions are serving on their own, the subliminal message here is everyone to his own. And that's a very problematic message to send out in a time when the world is facing the largest potential and real social dislocation ever witnessed, because the pandemic has hit at a time when inequities were already at their highest in almost every single country around the world. So we can't afford any more social dislocation. We have to be very intentional about social cohesion. And what we believe in the context of Religions for Peace is we've got to make sure that we can enable religious communities, the religious actors who are serving on the front lines, to continue to work together, to actually serve as they are, to serve together, to combine their resources, their opportunities, and their centers as much as possible to serve the humanitarian response together. That is an equity issue that goes way beyond a pandemic, that goes way beyond the here and now, that is about the kind of societies we're envisioning post this pandemic. Do we want societies in which each religious institution has become more powerful, more strong, more enabled, and more central in the lives of its people on its own because it has served to save lives?
Or do we want a society in which the question of equity of access and equity to health and social justice is being made by virtue of how we're serving at this moment, because all the religious communities and organizations and service providers are actually coming together to serve together? That is the question that Religions for Peace deals with and tries. And that's why we set up the Multi-Religious Humanitarian Fund, to say to the religious communities and to others around the world, can you help us insist on keeping our faith communities to serve together? Because it's not enough that we can save lives on our own. It is very critical to build a future in which people understand that by virtue of having come together because of our faith, we can overcome better and build back better indeed, rather than build back in silos of religious, political, financial domains. So that's the message. And the lesson we learned in that process of trying to put together this fund, which has been now around for a whole year, and it's supported 20 amazingly innovative projects, largely championed by women and undertaken and designed by women and youth of faith. The lesson learned is we're still each to his own. The finance sector is still looking at the finance sector. The UN is still looking at the UN. The NGOs are still looking at their respective NGOs. We have a lot more to do to work better together. And the religious sectors are working independently. So the message I have here is that we can't build equity if we're going to be doing our work in our respective silos. That ensuring the equity that we want to see, that starts with health but goes way beyond health, that ensuring that equity also means we have to increase systematically, diligently, the way that we work together and actually pool our resources together. Thank you.
Thank you so much for that powerful message, but also reminding us, there's that SDG 17 about partnership. There's that whole understanding that we can all do better, but only when we all do better. These are the elements of trying to think about the social values of not just equity, but of being together. And so thank you so much for that message. Diane Tran has been a leader in our community here in Minnesota in many different areas, and now has the position of Senior Director for Community Engagement at Fairview Health Services. Those of you who tuned in this morning heard from Fairview's CEO about all of the different things that Fairview is tackling in the range of initiatives about health equity. And Diane is the person who's making those happen, making and bringing those to life in our community and making such an impact. Diane, thank you again for joining us today, and the floor is yours.
Well, thank you very much, Mark. Thanks to you and Global Minnesota for hosting this conversation today, and to all of my colleagues here. It's an honor to learn about and discuss these social and economic benefits of health equity. As Mark said, I'm Diane Tran. I serve as Senior Director of Community Engagement for mHealth Fairview, and I also serve on the Hope Commission, which I'll share about further shortly. And mHealth Fairview is a partnership between the University of Minnesota, University of Minnesota Physicians, and Fairview Health Services. And we are a partnership that really combines the university's deep history of clinical innovation and training with Fairview's extensive roots in community medicine. So just for way of background, this partnership represents over 34,000 employees, 12 hospitals and medical centers, 56 primary care clinics, currently 600 plus active clinical trials, over 3,300 providers, and then partnerships, of course, with hundreds of community organizations to improve community health and health equity. And importantly, for today, we're headquartered in Minneapolis, Minnesota. It's home to where George Floyd died nearly a year ago at the hands of the Minneapolis Police Department. And we currently are undergoing the trial here locally. And that really was a galvanizing event for us to think even more critically about some of the work that leaders in our system and employees with great passion and commitment were undertaking of their own initiative. And with the leaders that Mark referenced earlier today, our CEO and Dean of the medical school, standing up the Hope Commission this past year, a chance for us to take a much more systemic look at the role that medicine, healthcare, higher education has played, disparities that we're currently seeing the ramifications of in our communities. And so, I think we want to start by just acknowledging that this work really is centered in our mission to provide care and healing. We know certainly it's the right thing to do, and that if we want to meet our mission to create greater health that, of course, 80 to 90% of what actually affects health and well-being takes place outside of the walls of our hospitals and clinics. So we do need to engage, as the last speaker spoke to, with partnerships, recognizing that it's truly these systems are social determinants of health, as well as the significance of history and the context of place that we need to bring together as we think about trust, community healing, and community empowerment. We also know that we'll never truly have equitable health outcomes until we have a diverse workplace. Numerous studies show and continue to show that increased diversity in the healthcare workforce leads to improved health equity. And we know for marginalized populations in particular, representational healthcare workforce diversity increases patient engagement, access, and the appropriateness of care. And, the third and most significant reason that we engage in this work is we recognize the importance we play in the state of Minnesota. The sheer size of the combined organizations of our partnership are the fourth largest employer in this state. And that means we do have the ability to affect change, particularly in marginalized communities, by making our employee populations more diverse. That, of course, will help our organization be more successful in our mission in years to come. And who we employ and what paths we create for upward mobility within our organizations can directly impact the health and well-being of our community. And so what we've done, like many organizations throughout this past year with greater intentionality, is to engage a system-wide process, really emphasizing this past fall, listening and learning sessions, several dozen of them, with especially our employee population, who were very hungry for this conversation, and really centering particularly our BIPOC identified, our Black, Indigenous, and people of color communities in this conversation so that we could elevate the voices of those who are traditionally most marginalized within the normal reporting and conversation streams within our organization. And, as we learned, I think the themes really around a hunger to be able to have more diversity and engagement, to see the leadership of this organization commit to the resources, the pathway forward, to be able to make this work real so that we can see the outcomes that we desire. And what I'm excited to share about today is just that we have started to make some of these strides. We know that this work will take years, if not decades, to progress, especially a partnership of this magnitude and complexity, given the organizations listed here. But as we think about some of the efforts currently underway around our sociodemographic data improvement to better understand the diversity of our patients so that we can disaggregate and understand the disparities that exist within our populations, and that we will be able to more targetedly improve those in partnership with those populations. And we are undertaking also a similar effort to clean our workforce data so that we can understand who we employ, how, and how we can retain and develop leaders that really reflect the communities that we serve locally. We're also excited that our vaccine equity response, building on the COVID-19 testing, outreach, and education in multilingual approaches with hands-on navigation from our cultural brokers for different communities, have also been a way in which we've served and responded to these dual pandemics. We did this past summer and fall host 48 COVID-19 testing clinics with nearly 20,000 tests in partnership with different cultural groups, faith communities, community partner organizations trusted by BIPOC communities. And then as we have launched our vaccine incident command, have really centered equity in the midst of all of that work, such that at this point now we've undergone at least 64 clinics in the community, again, with a diversity of trusted community organizations. And this is outside of our own health systems distribution of vaccines, again, with partners of all kinds, and over 11,500 doses administered to today. And so really excited that, again, we've been able to uplift the efforts of many people who have been passionate advocates on the individual and systems level within our organizational partnership over the years through this effort, and that we're really getting clearer on why this is so critical and why we need to increasingly invest in this work at every level of the organization. And we're grateful to our CEO and Dean of the Med School for that leadership. as well as for the employees and patients and community partners who have continued to raise their voices over the years for the ways in which healthcare can serve our communities, not just in a clinical setting, but in being an anchor institution, contributing to the economic wealth and well-being of our communities. So that's what I'd like to add to today's conversation, and looking forward to continued discussion.
Thank you so much. And all of you described amazing things underway, experimenting, making a difference, but also trying to link and connect to others and to build out and to build a kind of stronger or a multiplier effect. I wonder if all of you have had one particular instance that gave you an insight that was, partly because COVID created some new conditions, but gave you an insight that you want to hang on to and use really effectively as we move into this next period. Some element that said, oh, that's a new tool or a new insight for me as I move forward.
I'll take a yeah. I think what I was trying to say when I spoke that there's such an instinctive tendency in the height of a pandemic, when everybody's feeling a little bit threatened and everybody's concerned about where resources will be coming into their respective organizations, there's a tendency to go it alone. But there's I would say even stronger tendency that I've at least noticed from the religious realms of trying to see how to support one another. So that humanity that the reverse side is just let me alone, let me do this, let me take care of this, we're fine, to hey, how can we make this better together? I think that realization of that particular tendency was, well, but actually the realization of both and how incredibly polarized those two positions are, that was very, very important for us, because when we speak in rounds of, in the sort of giving and multi-religious and everything's great and fine and God's always beautiful and all that, but then you realize, wait a minute, there's the other side of this, which means that we have to actively and deliberately support the good side. We can't just assume the good side's going to be there and is going to prevail. I think there's an obligation that we have to try to support those who are ready, willing, and able to work together. And that's why we created the fund. And that's why we sought the WHO and the UN and said, how can we help you to make sure that these religious leaders and institutions that are ready, willing, and able to work together, how can we help you help them work together? Because we have to be deliberate in that support, not assume that it's going to happen and it's going to take place and it's okay, we just work with those we know, right?
Right. The better angels of our being.
Yeah, and I think for us, I would add that I think that COVID appeared, at least because pre-COVID, we will talk to those women to find out how they were doing, how was the business, how are you feeling? But it almost appeared as though COVID allowed them to speak boldly about the fact that they are struggling, right? Because it was almost like people weren't feeling ashamed anymore. People are dying. How do I manage this? I recall we were in a webinar and this woman said, look, I just lost an aunt who I was close to, and then my shop caught fire and my employees are without food, right? And this was in Kenya. So it's sort of, allowed a lot of them to feel like, given that they weren't suffering alone, they knew other people were suffering, it was okay to voice it out. Whereas pre-COVID, maybe those would be conversations people have in privacy, in private settings. But then it also got us to think more about, because as COVID happened, right, we started thinking a lot about technology. Every single person started thinking about, how do I utilize technology to help ensure that my business doesn't die, to help ensure that I'm keeping connected with family and friends. So that was a bit where we started thinking, okay, how can we ensure we utilize this to serve women in Africa as a whole, not just Nigeria, not just Ghana, but how can we utilize technology to create this safe space? I'm not sure that's something we would have given such deep thinking to prior to COVID, but it allows us to think, and I think this is a model that we definitely would adopt. As I said, we're still going through that test phase going forward, because it gives access to any woman on the continent.
Well, and you also created in response incredibly beautiful websites that got many of those women into a new way of marketing, a new way of keeping their business alive in the midst of this. I mean, that technology has been transformative. Phyllis, it's been a wild year.
Indeed, it has been a wild year. Do you want me to answer the question that you just posed the earlier one? What have we seen? You're going to ask me something new.
Another question.
Okay.
No, I think that all of us have, this has been a really big thing, but it has also pretty much universally, people have taken away certain things that now are part of, like, I don't want to lose that, when we go something back to what we call normal.
Yeah. I think one thing, particularly as I sit in the United States, I've actually spent most of my career overseas, but here in the United States, the majority of philanthropic giving stays in the US, 96% in fact. And for the first time, I'm seeing more people, through this pandemic, realize that we are only as strong as our weakest healthcare system. So while we all have a desire to do things in our own backyard and make sure that marginalized community, low resource countries as well, because unless, I think you said it at the beginning, Mark, unless these countries also get their communities vaccinated, this will continue to be a threat for all of us. And I hope that we continue to see the global importance of addressing healthcare globally and not just locally.
It's really alarming that it's 96%, but incredibly encouraging that you're seeing that awareness beginning to pop up. Yeah. Diane?
Yeah, I would definitely echo what's been shared so far and appreciate that point, Phyllis. I think seeing that some of these countries will take several years to get to vaccination is alarming. We obviously live in a very globalized world where it does matter that our backyards are experiencing very different experiences since viruses don't discriminate. And I would just add, I think what FA was referring to, just the veil dropping in so many different ways of what we normally have to hold up as normal is shocking in a lot of ways and is liberating in a lot of ways. And it certainly requires a lot of emotional intelligence and courage to show up and energy that not everyone has after a year into this pandemic. And yet the opportunity that comes from being able to square with ourselves, square with the institutions that we have entrusted, whether government or large entities and anchor institutions that we've entrusted our care, our commons, essentially, seeing, what their responses have been and what more we need to do to invest in our shared prosperity, well-being, and infrastructure, I think is critical. And so we're still, I think, trying to understand the magnitude of that and what we can do as individuals to be able to affect that. And yet it's clear that this is a time ripe and rife for action. And that some of that is starting to shift in really significant ways. And so I hope that we'll hold on to this sense of, what was normal was not working well for most. And there is an opportunity and a need for a new world. And so how can we start to build that?
All day, we've been hearing, all different levels and different components, but there's an element of sort of the changing moment where there's a race, getting a globally immune planet and variants popping up everywhere, including here in the US, because, we're being kind of slow and we have so many anti-vaxxers and all of that. But the fact that there is this sort of positive energy, and I don't, I know we are getting a few more hours of sunlight. That always helps. But, you know, and we're in Minnesota, so when it reaches spring, there are elements. But it feels to me like there's some component of what Asa called people like addressing that better angel, that like we need to do this together, that notion that we need to be thinking philanthropically about the rest of the world, or we need to be thinking about impacts and actually making a change, or we need to be inside our institution using the resources that we have, or thinking and really paying attention to what are people feeling the courage to say about their actual condition, and then finding solutions that maybe have technology. There are positive elements in the midst of this big crisis we've had. I wonder if any of you want to share the thing that gives you the energy to get up tomorrow morning and do what needs to be done, that thing that inspires you in that positive way that gets you going.
I'll take a dip because I know that I probably have the least important thing to say and all the other colleagues have plenty of valuable to say. So let me just get this over with because I think it's important to share it again and to nuance it. One of the lessons I learned is how about this willingness, the better angels, it, in a way, the good way to put it is this really induces me. The not so good way to put it is, my goodness, do I feel ashamed at not wanting to wake up in the morning and serve that. And I think this is the beautiful thing here was noticing how the young people around the world were bubbling with ideas of things that they can do and did do. So for instance, in our case, we have many interfaith youth networks and women's networks, interfaith women's networks. So these are women who are inspired by their faith. Some of them are ordained, many of them aren't. They're just doing normal things, but they're very much inspired by their faith, and they come together to work together. And we realized that the young, in the African context, the African Youth Network, Interfaith Youth Network, decided on their own that they needed to train the Women of Faith Network on social media, because now, okay, we can't communicate, we can't see each other anymore. So now it's social media. You don't know social media? What do you mean you don't know? What do you mean you don't know what a tweet is? All right, so they arranged, I don't know how they did it, but they managed to actually provide a training totally on their own. We gave them zero resources. They did this on their own. They did a training for the African Women of Faith Network. That's women of faith from across the religious spectrum, from across the sub-Saharan African countries. And now the other women of faith networks in the Middle East and South Asia, whatever, are saying, what can we do? We want that too. We want that too. And we found this remarkable resilience and creativity that was produced by, that was completely led by the young people. And now they're ready and willing, and they're doing so many other things. And to me, this makes me wake up in the morning and want to wake up in the morning, because I realize that it's an obligation, not just to celebrate them, which is very important, but really even more important to see how to support them, how to make sure that there is active support for this will that is there, that seems to, this resilience that's there, very much part of who they are as younger people, serving and surviving so much. I think, honestly, I don't know about the positive stuff, but this is the obligation stuff. And the call that I would make to my colleagues on this screen and to others, there are pockets of amazement that are taking place. And if we're not deliberate about working, even if they're outside of our scope of normal, or the kind of people we know, or the kind of organizations we work with, we have a duty. We have an obligation to make sure that we reach out and find them and support them.
Thank you.
I'll go next. I'm incredibly inspired by what we've seen. Think about it. Within days, major corporations and everybody around the world was working from home. We never, ever thought that was possible. Within a year, we came up with a vaccine. I mean, these are things that would have been inconceivable. We have the ingenuity, we have the technology to solve problems that we have been living with for decades, if not centuries. And this pandemic has taught us all that absolutely anything is possible. And if we're really committed to solving some of these health inequities around the globe, we have the technology and the will to do it.
Amen.
And I'll just tag along to that. I definitely echo the themes you've probably seen throughout today already, and what people have talked about that have been the beautiful things. I'll just say, maybe the less noticeable thing, which is the communities that have come together to advocate for themselves and one another in solidarity. And so the acts of, mutual aid and what we saw in the Twin Cities this past year, the public art and how people came to express themselves and grieve together for the harm that was done in our communities, but to support one another. And the organizing that has been happening and that has continued to happen to call for change, to call for what's needed and for justice in our communities. And, that has always been there. People and communities have been organizing, and that just always hasn't been heard. But with greater technology and access, with not being able to be out in the world like we have a little bit more time to hear a little bit more clearly, and we can't look away. And so this is the time that I think we have the obligation as well to be able to listen more closely in a way that moves us to an even more beautiful world. But just a kudos to those who have been doing the work to get us to this watershed moment where we can use this opportunity to take that action that's been being called for.
So for me, it's really seeing the effects of the work that is being done for them. Getting those emails, I was trying to find one where, I think a member of my staff had written to say, hey, I hope this helps contribute to your success story. And she started by saying, no, it doesn't help to contribute to my success story. In fact, is my success story, right? Those messages are inspiring because you feel like you wake up every morning and the little you're doing is having a positive impact on someone else and gives them a better outlook to life.
Thank you. Thank you. Thank you. I'm so grateful this is recorded and it'll be on a website and archived. And when I want that energy and that inspiration, I can come to this, but also people around the world will be able to see this and be inspired by your work. But I also know that we all will have the chance, and Phyllis put it pretty clearly, we've got the technology. As long as we have the motivation, the oomph to do this, we can help each other and find new ways of working together and weave together all the better angels into more and more spaces of amazement. Thank you to all of you for joining us today and being part of World Health Day 2021. Thank you very much.
Thank you so much.
Thank you, Mark. Take care, everyone.
Bye-bye, everyone.
Thank you all. Blessings.
Hello, everyone, again. And if you're just joining, thank you for coming with us today on this World Health Day 2021. If you've been here all day or part of the day, welcome again. I want to take a couple of minutes and just talk about some of the things that are happening at the end of the day before we start this last session. Today's been a lot of incredible presentations and a lot of talk and some slides, and it's been not a conversation, but a set of presentations. And we felt like there was a desire, and we've just heard it from people over and over, for a real conversation about health equity. It's something that stirs up emotion. There's a lot of ideas. And so Global Minnesota has partnered with Marnita's Table, which is a local organization that curates community conversations. In fact, they've been curating community conversations about health equity on behalf of Blue Cross Blue Shield throughout the country, but also throughout our region here. And so this evening, after we're done, kind of afterwards, there'll be 5:30 to 7 Central Time in the US. a curated conversation that Marnita herself will be doing. And if any of you are interested in continuing in terms of a conversation, there will be a slide with an email to be able to connect and to get that information. But I just wanted to alert you that some of you may be wanting to really have more of a conversation, and Marnita's conversations and this particular topic is one that really does rise to the level of something that is going to be the continuing work both for Global Minnesota and beyond. So watch for that slide. If you actually want to have a question about it, you can email me at just mritchie@globalminnesota.org, and I could get some information to you now. Our next panel in this conversation is one that's actually a very special one to me personally, because I've been very, very devoted to the question of involving our nation, our state, our community, our organization in the achievement of the Sustainable Development Goals of the United Nations. You know, we have a 2030 deadline, so to speak, of a lot of very specific things like zero hunger and reducing extreme poverty or reducing road fatalities by 2030. But it's clear that there's a special connection between equity and equality and meeting those Sustainable Development Goals, and especially health equity and equality. And so we've partnered with organizations from around the country that have really put their focus on that. And we've done that because in Minnesota, we are proposing to support and to offer and to organize a World Expo, like a World's Fair, in the summer of 2027 on the health-related aspects of the Sustainable Development Goals. Healthy people, healthy planet is our sort of tagline, but it's an opportunity to partner with others. For example, the Expo in Dubai that's taking place next winter, they've stated as their legacy goal the creation of an inclusive global health system that's crisis-proof and prepared for the future. And so those Sustainable Development Goals and that global commitment to work together really does fit today's theme about health equity. And one of our partners in this work, Claudia Romo Edelman, from the founder of We Are All Human Foundation, she's been at the heart of much of the UN work around the Sustainable Development Goals. She invited the Canada's ambassador to Canada, Juan Jose Gomez Camacho, who was one of the organizers at the UN when he represented Mexico at the United Nations in the creation of and in the adoption of those Sustainable Development Goals. David Navarro is a co-director of the Imperial College Institute of Global Health and Innovation, another leader in that campaign, in that effort to bring those Sustainable Development Goals. And she invited journalists, her co-host on Global Goals Cast. There's an entire incredible podcast series that Edie Lush, from a journalist from the UK, who's really bringing these Sustainable Development Goals into life and bringing them into our work by the methods of the social media around podcasts. And so Claudia has put together an incredible look at the Sustainable Development Goals and how they fit together with our ambitions around achieving health equity and equality going forward. I'm so grateful that Claudia has put this together, and please sit back. And this is going to be a very, very interactive and very exciting session. Thank you again.
So, greetings to this audience of decision makers and companies that are part of Global Minnesota. I thank you, Claudia Romo Edelman, for being part of this panel on health equity. It's a subject that's never been more relevant than today, because it affects millions of lives. And we've seen with the coronavirus pandemic underway right now, that equity must be taken into account in response strategies. Now, health equity among countries is just absolutely critical. It's wrong that people should face higher levels of suffering and risk of death just because of where they might have been born. We need to focus on what is happening now and what should happen, and then how to get there when it comes to acting on health equity. Companies, as well as local leaders, have hugely important roles to play in enhancing health equity everywhere. And I suppose nowhere is this more important than when it comes to understanding how minorities, including Latino people, are affected by inequity. Can they access healthcare? Can they get the necessary treatment that they need and deserve, given what they're suffering from? These issues need to be addressed. And that focus here in Minnesota, if you get it right, will have a ripple impact nationally, both economically and socially. So I'm hoping that with Claudia today, you'll all look at what you can do to make a difference to health inequities. And you'll look at how you can be setting an example that'll be meaningful far and wide in the United States and beyond. I do hope your conference is really fruitful, and I look forward to hearing the outcomes. Thank you.
Hi. Thank you so very much for the opportunity to address you at Global Minnesota. Thank you, Mark Ritchie, for this wonderful opportunity to be celebrating with you, to be discussing with you this Health Day, April 7th, the World Health Day, never more important. My name is Claudia Romo Edelman.
And I'm Edie Lush, and we are the co-hosts of the Global Goals Cast. Really delighted to be with you here today.
And Edie and I were really talking about how important this conversation is today. Never a more important year, never a more important moment to be discussing health. And I think that the theme of your conference, health equity, is at the center of what probably can impact the lives of millions of people today, and just like bridge the gap or join the gap, make it smaller or make it even wider. Edie and I have a podcast, the podcast of the Sustainable Development Goals. I was working for the United Nations launching the Sustainable Development Goals, and it was clear to me how important it was to be able to have a place to be able to showcase the incredible contributions and the incredible progress that we're making on the champions that are making that difference. And that's why we created this podcast. Edie and I just launched an episode particularly on health equity. Edie, would you like to share with our audience what's the
and in
podcast
fact, we
about?
launched it as the beginning, the first episode of season 5. Can you believe it? We've been going for 3 years, which is hugely exciting. And actually, Claudia, I was reflecting that almost every one of our episodes has dealt with this idea of equity in some way. Closing the gender pay gap, getting all of girls into school, educating boys and girls equally, and equity in all access to clean water, for example, equity in accessing other aspects of healthcare. But in this particular episode, as you mentioned, Claudia, we talked very precisely about this idea of access to vaccine, equity in access to vaccine. We took the look from a really global perspective because we know that the 10 richest countries in the world actually are on path to vaccinate most of their populations by the end of the year. Whereas the lower middle income countries in the world, through COVAX, which is a fantastic institution, fantastic initiative, are on path to vaccinate about 30% of their populations by the end of the year. So there is a real difference in terms of vaccine equity when you look at it on a global scale.
And Edie, also part of the episode, and which is, I hope that a lot of the conversations you have been having today is about what does it mean, health equity? What are the things that you as leaders, leading companies, leading states, leading organizations need to be aware about health equity, particularly in a time in which mortality has affected us so dramatically with COVID, in which health has been affected, economics have been affected, and now mental health for a number of people are coming all into play. And yet, now that we have a vaccine, we just have to make sure that we understand what does it mean to have equity? Where do we stand when it comes to openness or closeness about like taking in or sharing? And a lot of the discussion, Edie, a lot of the discussion that we have seen all across the world is about vaccine nationalism.
And it's entirely understandable, right? Because as you've pointed out in the episode, if you're elected leader of a country, of course you want to protect your people. Of course, President Biden wants to vaccinate everyone by the 4th of July. Of course, Boris Johnson wants everyone in the UK to be vaccinated by July. You want to protect your people. We have all lost so much. And I know that both of us can speak from that from a personal basis. However, and it's really interesting because I think what we've asked national leaders to do is to act internationally. And that's not what they've been elected to do. So we do have a very different, a clash between what leaders are elected to do, help and support their people, versus what the world needs, which is for people to act all together, altruistically. And actually, as we discuss in the episode, COVAX is an amazing way to get vaccine to the rest of the world. And it is absolutely right that we should support that.
Vaccine nationalism is intuitive, where vaccine globalization is not, it's counterintuitive. But as we discussed later today, with our interview with Ambassador Juan Jose Gomez Camacho, Ambassador of Mexico to Canada, who has been a health expert for Mexico and in global affairs for decades, it is important to realize how interconnected the world is, that it doesn't really matter if you have one country that is vaccinated 100%, if you have health workers in Africa that are not, if you have care essential workers in Latin America that are not receiving the vaccine, it's gonna come back, because we're all interconnected and people are on the move. So it is important to realize the reasons, and we will go into that later in the interview that we have. It is the other thing that we discuss in the episode, which will frame, I hope, the conversation that we will have with Ambassador Gomez Camacho, is vaccination hesitancy, and how important it is to realize that there's a lot of people that are hesitant, maybe because of trust, maybe because of lack of access. But at the end of the day, for the Latino community, 50% of every Latino has dropped their vaccinations altogether. Not only the COVID vaccine, this COVID vaccine gave them fear to start taking the vaccination altogether. So there's a real danger out there to have outbreaks in other diseases as well. So vaccine hesitation, vaccine nationalism, and at the end of the day, understanding health equity is equity for all. So why don't we, Edie, go into the interview that we have with Juan Jose Gomez Camacho, Ambassador of Mexico to Canada, and then we can come back and just like talk a little bit about what ideas we can all agree on that are good for us to have in mind, particularly for leaders attending this Global Minnesota Summit. It is a pleasure to be able to have a discussion here. Ambassador Juan Jose Gomez Camacho and I are delighted to be able to address you at Global in this incredible summit that you have. And the conversation that we're going to be leading in the next couple of minutes is about health equity. What is the issue? What are the things that we need to be contemplating? What are things that leaders need to understand about health equity, particularly in such a time? For that, I'm Claudia Romo-Irma, founder of World Human, and Ambassador Juan Jose Gomez Camacho, Ambassador of Mexico to Canada, but also not only an incredible expert on health and governmental affairs, but also very, very involved in global health, global issues from the very early days when I met you in Geneva, doing multilateral affairs. So let's start actually just like setting the scene. What do you think are the things that are right now at the heart of health equity? What is at risk? What should people know?
Gracias, Claudia. I think the drama of the pandemic is finally the hard way, if you like, making us understand the value of health, not only as health itself. We all understand that health is important because we are humans, but we don't see that health, in fact, goes well beyond health. Health means economic growth. Health means development. Health means equality. Health means jobs. Health means performance. Health means everything. And in the same way, the lack of health means the opposite. Means no business, means no productivity, means no workers' performance, means no community that businesses need, etc., etc., etc. So the first critical point is to understand this. Number two, in my view, and I'm always fighting the argument of, not to challenge your point, just let me explain it differently, the idea of equity or solidarity around health, and in this case, vaccines. Clearly, equity and solidarity now with the vaccines and the pandemics and all that is absolutely critical and is intrinsic to everything we do on health, absolutely. But we also need to understand, especially if we are now addressing businesses, that beyond equity and solidarity, it is self-interest in the good way. Self-interest matters, and it's very important to pursue it in the proper way. And when businesses and governments understand that by sharing vaccines, that by taking care of everybody, in reality, we are doing ourselves a very important service, then the logic changes. Let's go to the vaccines now. We all understand, and it's the same history always, or the same story always, whenever we have experienced pandemics and all that, is that we are motivated by fear, of course. We are motivated by self-interest, of course, it's natural. And we react by acquiring all the vaccines possible, taking care of ourselves first, etc., etc. Fair enough. It's human nature, it's normal, it's politics, it's everything. But at the same time, what we need to also understand, and this is my point of self-interest in the good way, that in reality, by trying to protect myself only, what I'm doing is precisely the opposite. What I'm doing by not helping the others is to make sure that I keep protecting myself, but the viruses, the pandemic, and the disease will keep knocking my door all the time, all the time, all the time, because I'm not taking care of the rest. We can only be protected as long as we all are protected. In the most pragmatic point of view, you cannot address a pandemic like this country by country. You see, country by country. Only all of the countries together. Otherwise, the pandemic won't stop. So back to your point of equity, and I was adding solidarity, that is always also used. Equity and solidarity are fundamental, are principles, is ethical, is the right thing to do. But beyond that, or in addition to that, is the most pragmatic, smart, and self-interest thing we can all do. Let's work together. It's really out of pure pragmatism as well.
But you see, I could agree more, but nevertheless,
if I would be addressing some of the people in Minnesota that saw the birth of the racial conversations, racial injustice, social injustice, you might be thinking like, wait a second, so we have to really start looking at the world in a different way, putting diversity and inclusion first, putting equity first as a way to achieve it. And yet, if you're America or the States, the United States, you have seen 500,000 people die more than the World War, World War II, Vietnam, all together. And as leaders, there is an incredible, not only self-preservation that happens about, like, I have to take care of my citizens, I have to take care of my essential workers and health workers, but also elderly and also everyone else. Not only for self-preservation issues, but for political reasons, for business issues, like most of the businesses that are, for example, in the Midwest, probably have, like multinationals, General Mills and others, but also have a huge footprint in the States. And it is hard. It's hard to imagine in a way like how countries like Germany being so open-handed and open-armed for refugees only a couple of years ago, now is like totally closed down, right? For vaccines, because that's lives that you're losing right there in that moment. So how do you make that argument? And it's not only within countries, it's not only outside countries, among countries, it's within countries. The Hispanic community, which I hope that we can address later, it's also part of that. But so how do you make that balance? How do you actually say, like, what is the right ratio for for health equity with that absolute knowledge that we have to take care of our people first? That's business, that's people, that's lives of our citizens, and at the same time understand that there's a correlation of providing vaccines to health workers in Africa. Health workers in Africa are getting their first doses of vaccines as we speak in March 2021, when a good deal of more than 20 million people in America have received it.
I think first, you are totally right in the analysis. It's very difficult. This is, at the end, it's human nature. Politics are human, businesses, everything is a human activity, and we react like that. I go back to my point. Once leaders fully understand, and one would have thought that is very obvious, but sometimes it's not that obvious. But once leaders, whether in the public sector or in the private sector, understand that it is the only way they can take care of their own interest, whether it's business or people, if you are a politician, is by taking care of everybody, because otherwise it's only totally self-defeating, then I think you are on the safe side of the road. That's the first one. It's very difficult. And the second is leadership. Leadership. Politicians or business leaders that have the capacity not only to understand this, but to communicate and to explain. The biggest challenge of a politician on this, as in many other challenges, is that you are always, or they are always, between doing what is necessary and being elected to office. And that's a very difficult balance to strike, because you are listening, and in times of pandemic is the most dramatic example, when you have people are experiencing fear, people are dying, people are getting infected, they are demanding rapid response from your government, from my elected authorities, instead of sending vaccines to Africa, as you said. So doing that is, to me, is the arts of a real politician. Again, doing the right thing, communicating properly, and persuading people that by doing that is in fact protecting them. Is a very challenging thing. I don't have a formula to that, other than we've seen throughout history, both in business and in government, great leaders that can do it. That's probably what distinguishes a real great leader from those that are not.
And I just like, probably we should speak a little louder so that all of you can hear us properly, because this is a very important point. But you and I saw firsthand the power of having a war chest. The Global Fund to Fight AIDS, Tuberculosis, and Malaria, the creation, PEPFAR saying, instead of actually having so many different people running like chicken without head, like being panicking and distributing little pieces of money, let's create a war chest where everybody puts their monies, and then from here we'll distribute according to a heat map, according to a need base that will actually have a ripple effect in the world. And we saw it, like dramatic improvement. Prevention from mother to child transmission prevented, no more, like a generation free of being born with HIV. So much progress. And so COVAX was established, this platform to deal with the vaccine of COVID the same way, pretty much, right? That the Global Fund, I think the mentality, I actually have a feeling it's pretty much like a failure right now, because governments are not really utilizing the platform again. And I'm not sure whether you see countries like where you operate, like Mexico, the States, Canada, taking that platform as a whole, or whether you think it's just like the first wave and then it's going to come and be more useful.
No, I think there are two different things, or two things together here. One is that we clearly are not good at learning from the past, because within the international community, WHO, when we were there in Geneva so many years ago, and we were experiencing the first, after the previous pandemic of influenza in 2009, H1N1, you remember. Within WHO, we built a system precisely to avoid what you just described it as chicken without head running around, which is what we did then. So government, societies, everybody just reacted out of fear. Chaos came. Everybody just shut down and tried to see for themselves, which again was completely self-defeating. As a result of that, we built a phenomenal platform that created a mechanism whereby countries first and foremost would react based on epidemiological criteria. What is it? What it does make sense? Or it makes sense to stop the pandemic from spreading. Not only how I protect myself, how I stop the pandemic.
Right.
That was number one. And number two, we worked very closely with the pharma industry, with the big ones, with the 5 major producers of vaccines, influenza vaccines at the time. After a year of intense negotiations, we reached phenomenal agreement with them. They were very helpful and very understanding. So how to, for example, scale up manufacturing of vaccines, that is challenging.
Affordable.
How to make them affordable, how to send them to the right places that otherwise they simply don't have them, etc. So the system is there. Now I have to say that years later, different pandemic and way more serious than that, we honestly didn't use what we had. We started in a way all over again. Now, that said, COVAX exists, which is an idea of the UN, Secretary General Guterres. It's a very good idea. What is it? It is a platform basically that gets funds from richer countries and donations, contributions from foundations, etc. And then does two things. One is, with the funds it has, it also comes a purchasing power, or bargaining power rather, with the pharma industry. That was the concept. So they could acquire vaccines in a competitive way, let's say, right, and then send these vaccines to the poorer countries. And number two, let's say middle income countries or more, Mexico or Canada, could also join this fund, putting money to buy vaccines, not to get them for free, but to buy them. So the system itself, the concept is very good. What are the challenges? Two challenges. First, not enough resources. Now with the new US administration, funds are coming. But second is the production capacity of vaccines.
Yeah.
That's the biggest challenge. And the biggest challenge that the pharma has now is how can they scale up quickly the vaccines. We need 12 billion or so doses. And the total capacity is 2-3 billion. Don't take me too seriously on that. I don't remember exactly the figures I saw very recently, but it is very dramatic. So I think it's a question of being very creative, because if they can do it, the farm is very good and there's capacity. They have to be creative, imaginative. Governments have to support the pharma so they can scale up quickly. If they scale up and countries, richer countries, keep funding COVAX, we can do it. But the longer it takes, the more dramatic it becomes, because then we have the variants. And again, we enter a vicious circle that is going to be very difficult to be broken.
And I mean, like, I really, when we were talking about the chicken without head, I mean it. I would like for those of you, just to illustrate, literally, it was the religious leaders that were like against distributing condoms, the activists that were tying themselves to the desks of the senators until they did something, the like governments that were panicking, a lot of philanthropies that were trying to help their own friends that were dying, governments that were talking to each other, and all of a sudden it was like, from that cacophony came a voice singing from the same song sheet. It was all about getting affordable drugs for everybody. And that was putting a lot of pressure on pharma, talking to them, but also putting a lot of pressure on the purchasing power capacity to deliver and purchasing power, deliver production capacity in so many different ways, which I think that pharma was outstanding at that time. And I think that we can go back to that memory of that time in which, like, they really reduced their prices and governments were
and let me say something that very serious, very important. Years ago, and now you still see it again, there's still miscommunication between governments and the industry. And something from the government side, we on the government side, or the public side, need to do much better, is to keep conveying a clear message that we need a strong pharmaceutical industry, profitable pharmaceutical industry with capacity, and we need to help it. And the pharmaceutical industry needs to hear that message loud and clearly, needs to hear and understand that these challenges that you hear everywhere, precisely because of the drama we are living, they are not challenges to the business itself, or they should not be. It should not be a questioning of the credibility and the legitimacy of the industry. On the contrary, we need a strong pharma. And also the pharma knows, and is, I think, clear about that. Now, one thing is to produce and to manufacture bicycles or consumer goods. And the other is to manufacture things that are needed for people to live. That makes or brings or makes the nature of the pharma a very critical, singular business. But again, we needed a strong one. We need to support them, and we need to help them do what they are supposed to do. But it's challenging. There is a huge communication issue there that needs to be worked out.
And there's a huge communication issue as well. I mean, like, I have to bring it home, right? Like within the country and what I'm seeing in the States, and I would love to go back and just like see what you're seeing in Canada and whatever you can comment on that. But communication in pharma and also companies, just to put it out there, to some degree, it is shocking to me that there are services, there are availability of issues, and services and drugs that people can access, not necessarily the vaccine, but in general, that minorities within countries are not aware of, are not accessing because they just simply don't know. In the case of the Latino community, the US Hispanic community, 60 million people, 18% of the population, 44% of Latinos were in denial of COVID 3 months after the pandemic had hit. And that is related to a huge issue that the world is living that is making the pandemic even worse, which is distrust. Distrust in everything, distrust in information, distrust in media, distrust in the government, distrust in, I don't know what to do, I don't know whether this is right or this is wrong. And what was shocking to me, Ambassador, was that 117 companies that changed their communication budgets, communication messages from selling to solving, meaning if I have a product, if I have cereal, if I have a shampoo, if I have something, I'm not gonna be advertising my product, I'm gonna be advertising health issues. Yep. I'm going to be talking about what do you do in case you have these symptoms and so on. From 117 companies that changed their communications during the first 6 months of COVID, only 13 addressed Hispanics or went into language or went to target them. And so there's no surprise, there shouldn't be any surprise that Hispanics were disproportionately affected at the health level, that we were disproportionately scared to a degree in which vaccination has dropped to 50% in the Latino community. And that is not even related to COVID. COVID created even more fear for vaccines to a degree that now we're not like taking packages of vaccines like measles and others. So there's a risk of outbreak as a huge lack of awareness and investment in communications from pharma and other companies to their employees, to their communities, because if there's one thing that I have learned from the Edelman Trust Barometer is that the highest trusted institution that for many people, at least the Hispanic community, the number one trust source of information is my boss, is my employer, is the company I work for. It's absolutely not the media. It's absolutely not, like in general.
Not even governments.
Not like absolutely not governments. Governments drop like crazy. But so it is really important that area of communication of pharma within companies, but also pharma and other companies towards their citizens, because people are watching and people are trusting you, and you just need to be able to address that. And I don't know whether,
No, I agree. I would add is certainly there's a huge challenge of communication, as we were saying, and I'm very glad to hear what you are saying. I didn't know it. Very good. Now, deeper than that is a question of business models. Mm-hmm. Is companies understanding that sustainability in the broadest possible way is the only way companies will remain in business in the future. It's not ethics again, it's not philosophy, it's not morality, doing the right thing because we are moral. Fair enough, all that is there, obviously. But most than that is that if companies do not pursue a sustainable or sustainability as a business model, green energy, health, quality of your workers, services to your workers, working with the community you are serving or you are operating in, etc., etc., etc. I wouldn't say companies' days are counted, of course not, but profitability will be very difficult. If companies want to keep growing, that's the number one thing to do. And at the same time, society is demanding this.
Yeah.
Society, and I get so, on the one hand, fascinated, and on the other, so enthusiastic when you see young people. Young people are angry. And there is a sort of fault line between our generation and younger generations, where it is not only they are younger and see things differently. Their value system is changing. And their value system is precisely much moral, protect the planet, protect health, works rights, the community, etc., etc. And they are expecting and demanding this from businesses. So communication, critical, changing business models equally so, or even more so.
And also understanding that we're, at the end of the day, I know it sounds so cliche, isn't it? Like we're all interconnected. But in reality, if you vaccinate everyone in America, everyone in the States, and we do not have anyone in Africa, not even health workers or teachers get vaccinated, or Latin America and others, it's going to come back and bite you.
It's self-defeating.
Say why?
It's self-defeating. It's self-defeating for the simple reason of what you said, that is not a cliche. Interconnection. No country in the world, as no community within a country, lives in a vacuum. Before, years ago, decades, we could argue that we lived in a vacuum where we could isolate ourselves and pursue our own things internally. Now that's impossible. Communications,
trade,
travel, trade. It's just that the movement is so massive.
And it's unstoppable.
Globally. That is unstoppable. You can't stop it, and you don't want to stop it either, because that depends your own growth, development, future, etc. So the virus just jumps. There's no way you can stop it. So how you can protect yourself? Let's protect everybody. Let's say you get immunization in one country. Let's say in the US or in Mexico or in Canada, you get full immunization. Fair enough. But in Africa or in other parts of the world, new variants will keep being developed or discovered, because that's the nature of viruses. They mutate, and the new variants will keep coming. And the vaccine you have will not be enough to protect you against those variants. So it's self-defeating. That's why the only way you can deal with this is by doing it together. And to your point on Hispanics in the US or minorities in the US, that's a real problem of inequality.
Yeah.
Inequality is not just not being equal. Inequality means that everything surrounding communities is meant to keep them there, or not meant, has as a consequence to keep them there. So their access to services, their access to information, and their access to opportunities is way more limited than the rest of the community. And you see this here, you see this in my own country, in our own country, and you see this everywhere. That's why inequality is one of the major challenges we need to address. Again, not only for morality, ethics, and all that. It's a self-preservation thing. We have to address it.
And for the audience of this summit, a very clear message. It's, you said self-preservation, and I would say self-interest. There's no way that your companies can be hiring without Hispanics, that can be selling without Hispanics. So it is really not only a responsibility, but an opportunity for you to realize how scared we are as a community, how frightened we are to go and access services of health because we don't understand what is at stake, how little we can afford to stop working. In some instances, how much we have been devastated because we're small businesses, entrepreneurs, and independent workers that work precisely in the industries that have been affected the most, that are coming back later. But because of the resilience of our community, because of our hard working, you better actually have really strong investment in information to your employers, to your community, to your consumers. You really want to make an effort to investigate how much of the access you're providing for people that trust you the most, for people that actually have purchasing power growing 70% larger than any other group. So the Latino community is growing faster than China. And if you're not investing in the Latino community, you're missing a great opportunity. So I think that this is a message saying, like, well, if you didn't see it, I hope that this would be a message for you to understand, that it's important for you to take action.
Yeah, let me add something. The most important asset for a company is human capital, is the people. Hispanics represent a gold mine in terms of human capital. Capacity, education, work ethics is really very impressive. So companies should not miss that out. Absolutely, I agree completely.
So
Thank
if
you
you're a leader,
so
much. Both of us are so excited to hear Ambassador Juan Jose Gomez Camacho. Go on, Irin.
So I think if you're a leader, there's a lot to think about. One of the issues is this idea around vaccine nationalism. It's one of the issues we discussed in the podcast. It's one of the issues that you discussed there with the ambassador as well.
So, long story short, what affects one affects the other. And it really makes no sense for us to consider having one part of the population completely covered and vaccinated and having the others not having access, because at the end of the day, because people move, it will actually come back with different, bigger, and more intelligent bugs, the super bug, the super pandemic that has a risk, because we're all interconnected. So vaccine nationalism has to be relaxed, and we have to find ways in which to do it. COVAX, as Ambassador Gomez Camacho mentioned, is a good idea, but it has to be implemented, and is failing today. We also heard that a lot of corporate leaders that are attending this summit have an incredible role to play to informing and somehow providing trust to their employees and their consumers about getting access to the services in health that they require, whether it's a vaccine, whether it's testing and others, because trust has fallen so low and people trust their employees in number one place. So there's a role to play for all corporations to take an active role in being a source of information for your employees, for your consumers, and for your community.
And I think the third thing is that we all have to fight the fear in any conversation that you have with people who may express some idea of vaccine hesitancy. That we all have a role to play. I remember when I interviewed the representative from Gavi, Tabani Mafosa, for the podcast, he was saying that the thing that keeps him up at night as a public health expert at Gavi, part of COVAX, is that he can do absolutely everything to get the vaccine to Zimbabwe, where his mother lives, and his mother says to him, "No, I don't trust it. I'm scared." So we all have a role to play in spreading facts and not the virus.
And not fear, whether it's in social media, and everything else. And that's why our podcast is offered to you, from us to you, Global Minnesota with Love. So we'll put that to Mark Ritchie for you all have access to it, because we just need to spread information in all ways that we can, to make sure that people understand the pros and cons and can take informed decisions about what they want to do. So we want to say thank you for the opportunity of talking to you. Congratulations, Global Minnesota, taking these important conversations to celebrate World Health Day, April 7th. From Edie Lush and myself, thank you so much.
Happy World Health Day.
Thank you so much, Claudia, and thank you for weaving together how our work on sustainable development goals can take us into new areas around health equity and equality. We know these issues are interwoven, and occasions like World Health Day and World Food Day and others give us an opportunity to go deeper, to meet new partners, but also to remember and refresh the work that we're doing. I mentioned a little bit earlier that these questions of health equity and equality, these are emotional and they stir us up. They make us want to be more active, to do things. And so we've arranged for any of you who would like to continue with a conversation, because we know today it's been a lot of talking at you over this Zoom. But Mornita's Table is a local nonprofit organization here in the Twin Cities that's been curating conversations about health equity around the country and around our state on behalf of Blue Cross Blue Shield and others. And we're going to have one of those special conversations curated by Mornita's. When I get done thanking a few people, there'll be a scroll and there'll be an email where you can just click on that and you'll get the information right away, 5:30 to 7. And it will be a conversation, a curated community conversation, kind of limited in size. So, let us know if you're interested. But we know that today's panel and today's theme, this is the beginning of a conversation, or maybe it's the middle of a conversation, but it's not the end of the conversation. Global Minnesota is committed to these issues of equity, of equality, and how they fit together in our longer term plans of holding an expo here in Minnesota on health and wellness, connecting with our partners in Dubai who are looking at a legacy of creating an inclusive global health system that's not crisis prone and is prepared for the future. So those of you who were with us all day, those of you who came for this last hour or participated off and on, thank you so much for your interest in the topic, your interest in equity, your interest in figuring out ways to all of us make a difference. And I think this final panel repeated the notion that we've been hearing all day long, that we've come to a place where solving the challenge of the COVID pandemic will require all of us in some form or fashion becoming immune through vaccination or maybe having COVID. But if we don't get there fast enough, the new variants will keep coming and coming and coming, and they will challenge us and maybe push us back to day one again. So we're in a race, and today we heard about the importance of all of us being safe before any of us can be safe. And we want to be able to continue our work and the work of other organizations that you might have heard today or you might get connected to make sure that we are carrying that forward. Again, this was a day of many people's contributions, our entire staff and board and volunteers and interns. This is a really big effort, these international days. And some of you know we do these on World Food Day and International Day of Education and others. So we thank you for participating today. And if you'd like to be kept informed, sign up for our newsletter on our Global Minnesota webpage. And if you're a member, thank you so much, because your membership really does make these kind of free programs possible. And if you're not yet a member and you'd like to help support this kind of global policy and world affairs programming, these issue days and these special opportunities, please consider joining. And again, there's information there on the webpage. I want to thank our premier sponsor today, GHR Foundation, and we were really blessed to have Amy Goldman, the Executive Director and President of the Board of GHR. It's an amazing partner of ours here in the Twin Cities who blends their focus on the local with their focus on the global, really committed to racial justice and social equity, and really have been a key institutional supporter, institutional member for Global Minnesota. So thank you again. And thank you to the other sponsors, King Solution and Blue Cross Blue Shield, and our corporate members, leading corporate members, Carlson Family Foundation and Delta Airlines, Cargill, Medtronic, United Health Group, and our program partner, World Affairs Council of America, and our promotional sponsors, our organizations that are our key allies in work and helping to get the work out. So today we were using the separate YouTube page for American Sign Language. And so those will be also put into an archive form, and they'll be available on our website and our YouTube page. So you'll get information about that. It'll have some subtitles in languages, but you can check on our Global Minnesota website for the video descriptions on where to find those that have the American Sign Language and other translations. And again, St. Cloud State is our incredible sponsor and promoter, and really our partner in making sure that our programming is becoming more and more accessible. And it's just been great to work with, and thank them. So we've reached the end of this particular day, but after there will be continued conversations. I mentioned that earlier. So watch for the scroll that will happen after I'm completed. And keep in mind the messages. These will be available, and the various recordings will be on our webpage. It usually takes us about a week to get it all there. But if you have not registered, so we don't have your email, and you would like to be kept informed, just go to the Global Minnesota webpage and just fill in the registration. That way we'll have your address and be able to keep you informed. There were a lot of different things that were woven together today. But my takeaway is that there is a kind of understanding from all kinds of people and all kinds of societies and cultures that not only do we have to make sure we're all safe, because we know that's what's going to be necessary for us and our families to be safe, but there's also a kind of turning towards that as a new way of understanding who we are as a humanity. Our need to partner with others because we are in this all together, and the value of the power of collaboration, of partnership, whether it's to move an agenda faster or it's to make a scientific discovery more quickly. But I do believe that the kind of reason why the day felt optimistic in the midst of understanding the level and scope of the death and dying and the long-term effects and the mental health effects, and how many more cases there will be, and I mean all of the things that you can imagine at this point in this pandemic, where for 6 weeks our global numbers have been going up, and Brazil is over 300,000 deaths. The United States is heading towards 600,000. In the midst of that reality, with no sugarcoating, people were seeing lessons that they've learned that they want to hang on to. People were seeing changes in the way that people understood their interconnectedness, and beginning to see that institutions can be mobilized to help support those better angels, those pathways towards partnership and collaboration and cooperation. That if we have an intention, we can find the amazing places of collaboration and partnership. We can reclaim our joy, as Aza told us in one of the last panels. We can find that opportunity to help build back better, not just with saying it and hoping that that happens, but by linking arms, putting our hands together, making the real hard work of tackling inequities, and racial inequities in particular, a very difficult problem, very difficult conversations, yes, for sure. But knowing that the only way for us to be safe and our loved ones and families and communities to be safe is for all of us to be safe, gives us a new way of understanding the connection. Senator Paul Wellstone in our state of Minnesota was famous for saying always, he said this all the time, we all do better when we all do better. And if Paul was here today, he would say, and you know what? In addition, none of us can be okay till we're all okay. Let's hope today is another step, a big step, a leap forward in helping us be working together to make sure that we are soon all able to be better, because we've made it possible for all to be better as well. Thank you again to all who've watched and been part of this process today, and have a good evening wherever you are, or a good morning wherever you are, or middle of the day. From all of us here at Global Minnesota, thank you for being part of World Health Day 2021 towards health equity and equality. Good day.